deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination app.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we.
Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. You're most welcome to our first national annual conference on non-communicable and communicable diseases, together with the Joint Scientific Health Forum. We shall be starting in a few minutes from now, as we had indicated, 9. And as you are aware, today and tomorrow we are having the pre-conference. So before we start, I would like to pass on a few remarks. Number one is that we kindly request that we adjust our seating arrangement. We are expected to have a few numbers for this morning, but we request you to come and occupy these front seats that are in so that we can have a good discussion. So the ushers, please help me. Request the people kindly to come and take up these seats. Our first session today will be hosted by the Uganda Pediatric Association, and Dr. Kulu is already in the room. She will be here to tell us about the session, but also introduce the people that are going to be taking us through for this morning. What is unique about this conference? Our program for the entire conference is available online, and you can get it by scanning this QR code. In case you pass the registration desk, make sure that you scan and you download a copy of the program. We shall not be having any physical or hard copies of the program. It's going to be online, so please ensure that you scan and you can follow the events. We want you to scan and get a copy because it has a lot of detail and key messages alongside the agenda. There are also very important messages that you need to have. We shall be here for this morning. Our places of convenience are just on the left-hand side. You can use the door at the back, and then you walk up to, like behind where the stage is, it's where the places of convenience are. We request that each of you has registered, and your tags will be issued, but in a few minutes, we are going to be starting from now. So, Dr. Akulo, as you get ready with the presenters, together with the person who also give us an opening prayer, we want all presentations shared online. So far, we have, I think, 2 out of 4. Let's have all of those. The IT team is going to play the key videos, and then after that, we shall be back to officially start within the next 5 minutes. Thank you.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of
this conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions. This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together.
Recording in
to
progress.
deliberate.
Good morning once again, ladies and gentlemen. You are most welcome to our national annual communicable and non-communicable diseases and the 9th joint scientific health conference, where we are going to be discussing key issues in the health sector in partnership with the MakCHs University and Ministry of Health. So like we had earlier indicated, we are going to start with our first session for this morning. But before we start, I request that the people handling registration kindly send the members in the room. We shall follow up later on the accreditation process as they are seated. We want people seated in the room so that we can start. Then those who are already here, please, I once again mention to the people who have joined us, our conference agenda is online. So the ushers make sure people are able to scan a copy of this so that they can download the program. This program is combined with the key messages about the conference and from some of the key speakers. So that's why important that we should have it. We again request you to come and take the seats in front here so that the people who are going to be presenting are able to interact with you freely. Before we start, I want to dedicate this morning before the Lord, and I will call upon Mrs. Damali Waiswa. Mrs. Damali Waiswa is the regional TB supervisor for the Bugisu and Bukedi regions. She will come and step forward and give us a word of prayer so that our conference is dedicated before the Lord.
Is it on? Yes, may I say good morning, ladies and gentlemen. Kindly let's stand up and we honor our God. Father in heaven, we give you glory and honor. We bless your name. We acknowledge that this is the day you have made for the annual conference for the communicable and non-communicable diseases. We appreciate your name. We appreciate your goodness. We believe that it's not because of our might, but it's because of you that we are here. We thank you for the journey mercies. We thank you for the hand of protection. We thank you that we've made it here. Father, may your name be glorified. Thank you for making for us this conference. You've planned with us, and finally we are here for that 5 days conference. We commit into your hands, Lord, that you continue guiding us, moving with us, giving us the wisdom. We commit the interactions, the discussions, Lord, for everything that is bound to happen here, that may your name continue to be glorified. Give us the good health, O God. Give us the knowledge. Give us the wisdom. Give us the ability to participate throughout the planned conference. We've prayed, believing in the name of Jesus Christ. Amen. Thank you so much.
Thank you, Damali. Please, can you give Damali a big hand clap? Thank you. Once again, good morning. And just to introduce, my name is Michael Musime from the Ministry of Health, and I will be supporting you for today as we have the sessions run. Just to be clear, this is a 5-day conference, but purposely for these first 2 days, we are having what we call the pre-conference. So those of you who may have been waiting to hear the anthems and the opening remarks, that will be for Wednesday when we have the official opening. For today, we are going direct into business in this pre-conference, and we have a number of organizations that will be leading us in the pre-conference. So for today morning, 9:30 up to 11, when we finish our break tea, we are going to be hosted by the Uganda Pediatric Association. And the team from the Uganda Pediatric Association is already in the room. Please give them a big hand clap. And on that note, I would like to introduce and welcome the president of the Uganda Pediatric Association, Dr. Anne Akulo, who will be the chair of this morning session. So this morning session, we'll be looking at non-communicable diseases in children. And we are blessed to have Dr. Anne with a team of about 4 presenters that we are going to know and hear from, share with us. So please, I request you to give them the audience. Once again, come and take the front seats here. We have started, and let's follow. The team online has also joined, and we shall also be recognizing the members that we have in due course. Dr. Anne, welcome. Members, please welcome her. So you can press one.
Sorry. Yes. Okay, thank you, MC, and good morning, everyone. A very good morning. It's Monday, so I expect a bit more energy. Good morning, everyone. And you've already been welcomed to today's conference. And we are privileged as the Uganda Pediatrics Association to set the stage and kick off the conference. Today we'll be discussing NCDs in children. We just had a discussion recently with one of the professors, and his concern was that sometimes we don't look at the broader aspects of pediatrics, and by the time the children with non-communicable diseases come to the specialists, it's usually late and we're dealing with the aftermath. So the objective for today's session, which is going to be about an hour and a half, is for us to shed light, create awareness, but also tell you a little bit more about non-communicable diseases in children so that we can detect them early, We can advocate for training, we can identify them and refer them early so that we can see these children and begin the longitudinal care rather than caring for children with chronic diseases as if we were treating acute illnesses. So this is going to be, we're going to have a few presentations, and then we encourage a lot of discussions from your end, and also ideas on how we can spread even more awareness about non-communicable diseases in children. Today we looked at the most common conditions that we see in children. There are many more non-communicable diseases, but we decided to choose 3 of the common ones and we see, and that we feel inadequately managed and referred late. We will be looking at the topics of sickle cell disease in children. We'll be looking at childhood asthma, the diagnosis, the acute management, and the chronic management. And then we'll be looking at childhood cancer. And we'll focus more on what are some of the early warning signs and how can we get these children to the specialists on time when we can still salvage them. So with those few remarks, I just want to appreciate all the members of the Uganda Pediatrics Association who are here. We have been joined by some of very senior members. We have Professor Chiguli, who has been a teacher for a very long time, a mentor, and she still leads the education in MakCHs University. Let's give her a hand clap. She was here very early. We've also been joined by Dr. Joyce Balagade, who will make the first presentation. She's online. Unfortunately, she had other commitments, but she's very passionate about her subject, and I will introduce her in a bit more detail, but let's just give her a hand clap. She's online right now. Professor Idro, who is also an educator, a researcher, the deputy principal of MakCHs University, is also going to be joining us online because of so many other commitments he had, but he made sure he had to attend this conference because of the importance, and is going to be talking to us about a very important topic on sickle cell disease. And lastly, we also have a young pediatrician who is very passionate about childhood asthma and is going to be speaking to us and representing all the lung specialists with us. Dr. Nampija, she's in the house. Let's give her a hand clap. I request Professor Chiguli and Dr. Nampija to join me up here as I call on the first presenter. Joyce, Dr. Joyce Balagade, just confirm that you can hear me.
Yes, Anne, I can hear you very well.
Okay,
Thank you.
Maybe let's work on the volume so that we can hear her loud and clear. So thank you, Dr. Balagade, for joining. She had pressing commitments, but she said this was very important, too important for her to miss. Dr. Joyce Balagade is actually a leading pediatric hematologist and oncologist. She was among the first in the country, and she's now leading even regionally and globally. She is the head of the pediatric cancer unit at the Uganda Cancer Institute, and she set it up after her training. She has more than 10 years in experience in pediatric hematology and oncology. And she's also the continental president for the international SIOP, which is the International Society for Pediatric Oncology. So she's leading hematology both locally and regionally, and has immense experience to share with us. And Dr. Balagade today wants to raise awareness on childhood cancer so that these children can be referred to us when they can do something about them. So over to you, Dr. Balagade, and feel free to share your slides from your end. Thank you. Let us welcome her with a hand clap as she shares her slides.
Okay, good morning, everyone. And thank you, Anne, for that very nice introduction. I will move right ahead into the topic that I thought would be fitting for this discussion with regard to childhood cancer. And I wanted to focus on early detection of child and adolescent cancer in Uganda because it resonates very well with public health interventions. So let me put this in a slideshow. Okay, there we go. All right. Childhood cancer is a leading global health concern with annually 400,000 new cases diagnosed, and only about half of those, not diagnosed, but developing cancer, but only half of those are actually diagnosed globally. This translates into about 1,000 cases diagnosed each day, and the majority of these cancers, the 400,000, are in LMICs, low and middle income countries. And 40% of these are in Africa alone, meaning that the majority of the global burden of childhood cancer is on the African continent, where the survival rates are less than 30%, less than 10% in many, many areas, as opposed to the high-income countries where we have survival that exceeds 80%. This map is a heat map that is showing very clearly the survivals of childhood cancer globally. And you can see in the African continent here, the sub-Saharan region in red where Uganda lies, the survival estimates are less than 25%. There are reasons why our colleagues in high-income countries have managed to secure such high survival rates. Sorry, I'm in my office and therefore there is noise outside. You pardon me. So there are reasons why there are very high survival rates in high-income countries. It didn't happen by chance. There's been concerted efforts to reach this point. There have been a lot of improvements in timely and accurate diagnosis. And in the next slides, I'm going to show you where we are as Uganda. There has been a lot of work and progress made in precise evaluation of the disease. This is in terms of how far has the disease gone and therefore what should be the treatment strategy. There has also been advancements in those countries in their ability to predict, to stratify, and to tailor treatment intensity based on individualized disease factors and treatment response. And there's been increase in the quality of disease-directed treatment as well as supportive and survivorship care. And a lot of these, as you can see, I've indicated here, are driven by innovation, by research, by science, and so forth. So everything is research-driven in those high-income countries. And this has resulted in the tangible gains that we see in those settings.
We seem to have lost her sound. Can IT help?
I hope you can hear me better now.
Yes, we can hear you now.
All right. So I'll go back one step. All right. The causes of inferior outcomes are many, but I've highlighted 6 of them. And I have tried to extrapolate these causes into our setting so that we can think about them and what we could do, especially from a public health perspective. So the number one cause is the fact that some of the children, many of the children, are either not diagnosed or misdiagnosed. And this occurs really at our lower level health, at the lower levels of our health system. And this is something that really has to do with our frontline health workers, as well as the general public, in terms of recognizing the symptoms and signs of childhood cancer, but also the health workers recognizing that the presentation of the child before then could actually be childhood cancer. So this leads directly into the issue of delayed diagnosis. And we've done studies, including here in Uganda, where the second delay, that is the time interval between which a child's family presents to a healthcare facility to the time that they actually reach a cancer treatment facility in Mulago is much, much longer, almost 2/3 of the entire duration, that second delay. So we have a lot of moving around within the health system and treatment for things that might not be cancer, so that by the time they get to the actual cancer treatment facilities, they have late-stage disease. And with late-stage disease, treatment with a curative intent becomes very difficult. Then once they get to the treatment facilities, they are then faced with challenges such as limited access to diagnosis and treatment modalities. At many of our cancer treatment centers on Mulago Hill, that's Cancer Institute, and Mulago National Referral Hospital, as well as Mbarara, we have challenges still with regards to pathology, with regarding accessing imaging, that's the radiology, chest X-ray, ultrasound scans, CT scans, MRIs, which are usually available at cost, and that becomes a huge barrier. Chemotherapy stock out sometimes, radiotherapy access, surgery, all these limited access to diagnosis and treatment modalities further reduce the survival of those who present for care. And then one of the biggest challenges is supportive care. A lot of the cancer treatment that we have in our country is associated with toxicities, including anemia that is severe, including thrombocytopenia, the very low platelet counts so that they bleed, and we have limited access to blood products. We also have challenges with investigating the infections when they present in this population, because many times they require antibiotics that are significantly of a higher grade than normal and things like those. So eventually we end up losing our children to what we call toxicity of the treatment itself. And then comorbidities like malnutrition, HIV, TB. We live in Uganda. These are still some of the most common disease conditions, and the children with cancer are not spared. So comorbidities like these further cause problems. And then when all of this is done, we have very high treatment abandonment rates that approach 60% in some settings. So when you put all of these together, it is no wonder that in our settings, we still have an overall survival rate of childhood cancer that is less than 25% when everything is put together. So I wanted to show this slide, and it's really putting everything in perspective. If you look at this bar, it's looking at, and you can see that in high-income countries, this is where we have cure. That's all the way above 80%. They have almost non-existent abandonment. If you can see the gray bar, it's almost non-existent. Misdiagnosis is almost non-existent, no diagnosis. But when you come to the low-income countries like Uganda, you can see that misdiagnosis, no diagnosis is more than 50%. When you add on the no treatment, the abandonment, this
Dr. Balagari, are you there?
where our children are actually, including our health systems that are generally broken, and including the lack of data to inform policy or interventions. This is very, very important and will challenge the community that looks after children is provide the policymaker. So because of in survival between high-income countries and low-income countries, there was a global initiative for childhood cancer that was launched in 2018. And this initiative was to ensure an overall survival of childhood cancer of 60% by the year 2030. And also importantly, to reduce suffering for all. This second part is usually missed out when messages are sent out, but this second part underscores the importance of palliative care. So by 2030, we really need to be having this kind of survival, even in Uganda, and by so doing, saving 1 million lives. So this is the challenge that has been put before us globally. And the initiative was not launched and left in a vacuum. It was accompanied by a technical framework, which is called the Cure All Framework. And here I just showed it to show that there is a template from which all countries are working to ensure that there's a sustained improvement globally. And this framework underscores national cancer control planning for children and adolescents. And at the time that this was launched, the plan was to have 6 to 10 countries that are focus countries of GICC, Global Initiative for Childhood Cancer, by the year 2020. And I'm proud to say that Uganda is one of those countries on the continent that are focus countries. We achieved this status about 2 years ago in recognition of the efforts that the country is making to streamline care and survival of children and adolescents with cancer. Under this framework, and this is probably one of the most important slides for us as a country, is the prioritization of what we call tracer cancers. These are 6 cancers, which I have listed here: acute lymphoblastic leukemia, Burkitt lymphoma, Hodgkin's lymphoma, retinoblastoma, which is cancer of the eye, and Wilms tumor, cancer of the kidney, and low-grade glioma is really brain cancer. So these cancers are the tracer cancers that countries, especially in low-income settings, are called upon to emphasize in terms of initiatives for childhood cancer control, including others, but emphasis on these. And the reason for this is that interventions to identify and manage them appropriately would result in a robust national cancer control framework. I won't go into all the details, but I can probably mention one, like for example, the brain tumors, because of the multidisciplinarity of management of brain tumors by the neurosurgeons, by the occupational health, by palliative care. If the country streamlined the service for low-grade glioma with the multi-sector interventions and so forth, this in itself would strengthen the health system for childhood cancer in general. And in the next slides, I'm going to highlight Ugandan setting through a lens of these tracer cancers to some extent. So now pivoting to the situation in Uganda, according to GlobalCan, in 2022, Uganda has 3,278 incident cases of child and adolescent cancers up to the age of 18. Cognizant that this represents about 9 to 10% of the national cancer burden, that is children, adults in one basket. So these 3,000 are about 9% of what Uganda gets globally, annually. And in terms of characterizing what this looks like in tangible terms, we have a population-based registry that is very, very well known to most of us, the Chadondo Cancer Registry, which is one of the oldest registries in Africa. And according to this registry, our incidence of childhood cancer is about 146 per million, which is important. And when we break down this into relative frequencies, you can see certain things come up highly here. If you look at number 2 here, where my cursor is, you can see on this row, if you follow it up, that lymphomas constitute almost 30% of the incident cases that we register at a population level through childhood cancer registry. And this is the lymphoma. The lymphomas, it's a whole basket that has bucket lymphoma that everybody knows very well, Hodgkin's disease, and all other types of lymphoma. The other one that is quite surprising are the soft tissue sarcomas, which are also constituting about 1/3. And then the rest fall somewhere in between these. However, when it comes to survival, and before I go to that, I wanted to point out, if you look at the tracer cancers in terms of incidence, you can see leukemia here, which is 8.3. We don't have a segregation of Wilms tumor. It's a basket of renal tumors. So our data, as it is published through childhood cancer registry, also really needs to be aligned to enable us to actually evaluate ourselves. So recently there was a publication again from this registry, and this was in response to the launch of the Global Initiative of Childhood Cancer by Being and others in 2020. So this was just after the Global Initiative was launched, and the group was looking very specifically at the tracer cancers in our country. And these are them here: acute lymphoblastic leukemia, Hodgkin's lymphoma, NHL here, which is a proxy for the whole group, but they pulled out bucket lymphoma, so you can see retinoblastoma, Wilms tumor, and others. And you can see our survival rates. The one thing I wanted to point out that probably is the one thing we can really say is very good is Hodgkin's lymphoma. At 3 years, our survival is 86% as a country, which I thought is very good. If you look at the survival of the other tracer cancers, you can see that we are not at the target, which is 60%, but we are not at 30% for the tracer cancers, because you can see we have 46 here, 42, 54, and so forth. So this is where we are as a country in terms of the tracer cancers. And here, osteosarcoma was pulled out. Why? Because it's the most common tumor amongst our teenagers. And we still have a survival of about 50%. So as a country, we are not doing where we need to be. We are somewhere, but a lot of effort is needed to improve this survival to the global standard. When we went further to the hospital-based registry at Uganda Cancer Institute, the picture is slightly different of the most common cancers. You can see that on the whole, in our setting here, the 2 most common cancers we are seeing, contrary to what used to be said that bucket lymphoma is the most common cancer, we're actually seeing cancer of the kidney as the most common one, followed by rhabdomyosarcoma, which is a soft tissue sarcoma. And we still have a lot of bone tumor. That's because of the teenagers' second decade of life. If you look at bucket lymphoma, here is where it is. So it's not nothing, but it is not the most common one that we are seeing currently with the precise diagnosis that we have. We have also gone ahead to look at survival at the Cancer Institute in select tracer cancers. And you can see here with the bucket lymphoma at 5 years, the survival drops to about 44%. This was a time period about 2015, 2016. The Hodgkin's lymphoma, we are still doing fairly well, 76%. The Wilms tumor, we are approximating 50%. So this is data from the hospital-based registry. I want to change again and now look at us as a country in terms of the children that are diagnosed, that develop cancer, vis-a-vis the ones that are actually diagnosed and present for care. And this is where, as a country, we need
Dr. Balagade, I was just looking at time and asking you to maybe speed up. I don't know how many more slides we have.
I have about 4 more slides.
Okay, great. Thank you.
So we have, so when we looked at the data in 2022, we found that of all the children that develop cancer in our country, only about 1/3 here present for care, meaning that 2/3 of all our children in this country are not presenting for care. And this was the focus of my discussion in terms of, can we have interventions to improve early detection at a public health level, because that is probably one of the biggest barriers for us in terms of survival. Because when they present to us, you've seen the kind of survival that we have, but the proportion of those that present to us is still very small, and they are presenting late. So if we get that proportion to come in and to come in earlier, we'll be able to drive the survival upwards. This slide is showing that care for children with cancer is still highly centralized for those that present in care. You can see here on Mulago Hill is where we have almost 80% of the pediatric oncologists and over 80% of the children with cancer presenting. However, in the country's decentralization strategy, we've planned to decentralize the services so that they can be closer to the people. And already you can see Mbarara here, we already have children being cared for with a pediatric oncologist, and the Gulu Center has already opened with a children's service due to start there as well. And these two centers, Arua and Mbale, construction is going to start this year. So there is some work that's being done. Additionally, we have our National Cancer Control Plan, which I'm very proud to say has a dedicated pillar on childhood cancer control to organize us as a country. And I pulled out just one section. I'll move very quickly. The issue of early detection here, focusing on things like awareness of symptoms, primary care evaluation, and referral for diagnosis. This is where we need to be focusing at a global, at a national scale. And the plan articulates a number of interventions, and I would want to encourage all of us to look at this plan to see where we fit in for early detection of children's cancers, and where we can integrate as a country with existing services. So for example, to scale up coverage of retinoblastoma, the only screenable cancer in children, we have a number of opportunities that could be leveraged, maternal child health interventions, the EPI, IMCI, school health, improving awareness creation. There are interventions that are articulated very clearly in the plan. Integrating early detection of cancer in children. Again, this slide is going to be available online for all of us to have a look and actually see where we can fit in. So in conclusion, child and adolescent cancer is a leading global health concern, with over 95% of children with cancer in LMICs. In Uganda, we have 3,000 incident cases, of which only 1/3 are presenting for care. And when they present for care, they are presenting with advanced disease. However, as a country, we have a National Cancer Control Plan that has a specific pillar dedicated to children, and this pillar is included in the costed implementation framework, and it is also supported by a ring-fenced 8% of the consolidated budget. So the country has actually tried very hard to provide us with this roadmap. We simply need to rise to the challenge. Thank you all. I think that is the end of my presentation. Back to you, Anne.
Okay. Thank you, Dr. Balagade, for showing us the picture of childhood cancer in Uganda and also the progress that we have made, giving us hope. So it's now up to us to do our part in addressing the issue of childhood cancer. Because we spent a bit of our time, I'm going to invite our second speaker, who is Dr. Joanita Nampija, who is with us in the room. Dr. Joanita Nampija is a passionate pediatrician, and her interests are in lung health. She's a fellow of the McChs Lung Institute, and she's going to take us through another very important topic of NCDs in children, which is childhood asthma, one of the probably most mismanaged conditions in children, chronic conditions in children that we've seen. So she's going to highlight the diagnosis, the acute, and the chronic management. Over to you, Dr. Nampija.
Thank you, Dr. Anne. I'm glad to be here to share with you a little knowledge that I've compacted together, both acute and chronic care in asthma. Yes, I'll go straight to the point. Okay, so this is our outline for the presentation. It's a short one, so I'll look at the definition of asthma, common presentation of asthma, criteria that we use to diagnose both children and the adolescents that has been recently updated, and then our goal of treatment in asthma care, and then our treatment plan. So in short, asthma is very common to us, and it has been seen both in adults and children, and the elderly as well. It's a heterogeneous disease. It happens in all different forms. It's chronic, and it's associated with airway inflammation. So what usually happens is that there are key symptoms that we look at, and they are called asthma-like symptoms, and these are basically four. One is wheezing, that we all know. The other is shortness of breath. Another one will tell you chest pain. And the common one also is cough. Now, these symptoms may be present, but not all the time, and their intensity will always vary. So that is why we call it a heterogeneous disease. So because of these symptoms, they will be associated with chronic inflammation, and with chronic inflammation, then we will result into air flow limitation that will result into variable expiratory flow. So with this, if it continues and continues, then it's going to cause chronic or persistent, thank you, then it will cause chronic disease, and that is why we call it a chronic disease. Yes, it has its acute exacerbations that may come in, but because it is continuous and this is not going to go away, then it becomes chronic. And as a result of this chronic inflammation, airflow limitation, then our airways are going to become hyper-responsive. Anything that will pass through that airway will cause irritation, and that's what we shall call the triggers. So this is an asthmatic airway. As you can see, do I have a pointer here? Oh no. So if you look onto the middle, there's one on the right and one on the left. So there's an airway that you can see that is very gentle, smooth, normal bronchial muscles. And when you look into the middle, that airway is an asthmatic airway. It has already inflammation, there's swelling, and then there's also narrowing of the airway. As you look at the other one, it's an asthmatic airway, but with an acute exacerbation. So it has also become narrower, it has secretions in it, and thicker. So as you can see, most of the asthmatics, their airways will vary within the other two. The chronic one, that's already there, and then an acute one. So then what happens? Because of that pathophysiology I've talked about, that is how they will present. One, they may come in an acute exacerbation before you as a doctor or any other health personnel, or even people at home who have them. Or they will come in with their chronic symptoms. The symptoms we have already talked about, chest pain, the cough, the wheezing that are on and off. But something to them, they will tell you they are already on their inhalers. They are steroid inhalers, which we call inhaled corticosteroid containing inhalers. But they don't have a formal diagnosis because in our communities, people are afraid to tell them that they're actually asthmatic. Or they'll come with these already known chronic symptoms with their recurrent treatments, but they are not on inhaler. They are getting either tablets or syrups over the counter, or also treating themselves or being treated by health workers. So they may present in variation. Something nice associated with them also, they may have other symptoms besides their asthma symptoms, and most of these will be allergies. They can be allergies of the eyes, so they may come in with itchy eyes, red eyes, darkening around their eyeballs, or they may come in with allergic rhinitis. Allergic rhinitis is when they have recurrent sneezing, itchy nostrils, and some of them will have actually growing nasal turbinates that are actually popping out. Others will come in with atopic dermatitis, what we call eczema. In one of those images, you have seen the baby with eczema. Some of them may have it on their heads, faces, or the whole body. So these may be associated symptoms with them. They may all be there, or some of them. So how to make a diagnosis of asthma? One, you need good history. We all know in medicine, history makes 80% of the diagnosis. And then sometimes you also need to make just proof or to show how bad or how severe the disease has been. So the severity of disease can then be checked with a peak flow meter, which we usually have in our clinics, in our chest clinics, or you can send a patient to do what we call a spirometry test. Spirometry is not very common in our environment. I think right now it's only present in Mulago and Mbara Hospital. Asthma in young children has been very difficult to make a diagnosis. However, we have come up with a form or criteria that you can use to help you make a diagnosis, because as a child, they don't have effort to mount to do the peak flow meter test or the spirometry, because these tests require engagement or breathing of this child. So those who are younger, 5 years or up to 6 years, we use a criteria diagnosis. And you need 3 of these, and they have to be 3. One of the criteria is the recurrent wheezing. If a child came to you, or if you have one that you know of and has episodes of recurrent wheezing, they have at least one episode of recurrent wheezing, but with the asthma-like symptoms I've already talked about, that one is a suspect for asthma. Plus, if there is no evidence of any other respiratory cause of these symptoms, it also continues to give you further suspicion that this child has asthma. Other causes of wheezes or chest pain in children, continuous viral infections. Some of them have a foreign body, others have tumors in their airways, others have many other problems. The third thing that you can use to also make the diagnosis and the criteria is the timely response of this child of the asthma-like symptoms to medication we use. And one of the medication we use is the short-acting beta agonist, and that is the salbutamol. A child who responds to nebulization shortly after a first phase of wheezing, a child who also responds to inhaled corticosteroids or to oral corticosteroids. The example I can give here is a child comes to you with recurrent wheezing, and the parent tells you they have been giving some bit of Dexa, some bit of prednisolone. That is a high suspect for asthma. So for you to make a confident diagnosis, then you have to add the 3 criteria. You cannot use only 2 criteria. The 2 criteria will only tell you probable asthma. So you need to have criteria 1 of wheezing or recurrent wheezes, plus there should be no other cause for this wheezing, and the response to treatment that we use in asthma. So with this, then you're able to make a diagnosis smartly. So for the adults, I already said they have their symptoms, which is chest pain, cough, wheezing, and these are recurrent. So the main goal of asthma treatment is 2. 1, you want to make sure that this patient has long-term symptom control. And 2, you want to make them have minimal risk to their asthma symptoms, because asthma is associated with death. I didn't go into the burden because I know this is very clear, but asthma burden is very rare and it's associated with death, even in high income countries. So the fewer the symptoms, the better sleep for this child. If a child can't sleep, they will not grow, they will not concentrate, they will be in and out of hospitals with current illness. The minimum risks are death, risks of exacerbation, recurrent going to hospitals all the time. That's an expenditure to you as a parent and to also the country at large. And also improving their lung function. So your aims are basically those two. The main cornerstone of pharmacological care is basically two. One, acute control of symptoms. You need to know how to manage acute control of exacerbations and also the long term to prevent these symptoms coming in. So when you're on a control, your aim is to step up in case the patient is not improving or step down when they are better controlled. For those that are in acute, it's also the same way. If they respond to their SABA, then that's it. If they don't, then you need to step up. I'll go into detail. So when they come in with acute symptoms, your aim is to relieve them of these symptoms because they can't go into acute respiratory failure. And what the mainstay we have said is short-acting beta agonists. This government has made them very available in our health centers. So the short-acting beta agonists are Ventoline, which is salbutamol, albuterol, terbutaline. Some of these are found in our over-the-counter syrups. The other short-acting elements that we use are the cholinergics. We call them the SAMAs. This is ipratropium, oxytropium. We also have short-acting methylxanthines, and this is the common one on the table we know is aminophylline. There is a long-acting one, which is theophylline. So when the patient comes to you, if they're in the doctor's ear and they have an acute exacerbation, we encourage you to use the salbutamol first. Either you use the inhaler or the nebulizer. But we are now advocating for the inhaler. I'll talk about it later. Then you can step up in case you fail to ipratropium combined with salbutamol. If you fail, you can step up to IV magnesium sulfate. And if IV magnesium sulfate doesn't work, then you know we need IV aminophylline. But we are advocating for two things here. Inhaler, salbutamol, plus or minus ipratropium combined. And if you fail, go for magnesium sulfate because aminophylline has shown to have a lot of toxicity. The mainstay, like I said, is salbutamol inhaler. I will show you how to administer. You need about 2 to 4 puffs of this. I'll leave something as a message, but this will depend on age. Ages less than 5 years, you need only 2 puffs. Ages above 5 years, you need about 2 or more. Usually we advocate for 3 to 4 puffs. If you have a salbutamol nebule, all you need is a nebule of 2.5 of salbutamol. And then for bigger children, 5 years and above, you need about 5 milligrams of salbutamol nebule. You can nebulize for 3 times in an hour, but this should be in a space of 20 minutes. Because salbutamol is short-acting, you need it to come to effect and give you relief for your patient or for yourself. And because we know this is an acute state and there is inflammation, then you also have to have an anti-inflammatory. And the one that we encourage is the prednisolone or the short-acting oral corticosteroids. You may use the DEXA, but we prefer that you actually go for prednisolone. If your salbutamol fails, then you can go up to ipratropium combined with salbutamol. The doses are basically combined 2.5 mics to 5. That's okay. The same way you allow the phases to be 3 phases of nebulization or inhalation in a period of 1 hour. And that means if you fail to improve, then you go up to IV. The IV medication we use is basically magnesium sulfate, and the doses have provided them. This should run slowly for about 30 minutes. And by the end of 30 minutes, your patient should have obviously improved. If they don't improve, you using aminophylline may not cause much improvement, but also step up to look for chest support for your patient. The main controllers, when I talk about a controller, this is the symptom controller. This is daily medication, and that is an inhaled corticosteroid. The corticosteroids we can use on the market are budesonide, beclomethasone, fluticasone. These are all available, and these are combined with long-acting beta agonists. For older children, we use a combined inhaler that is short-acting and long. That is the inflammatory and the LABA. We also have what we call the add-ons to reduce on the inflammation as well as allergies. Those are the leukotriene inhibitors, and that is montelukast, which is common on our market. So this is how we look at the doses. I won't go much into them. But there's something I want to talk about. Choice of drug delivery. Like I said, we encourage now the use of inhalers. An inhaler can be an MDI or DPI. MDI has a propellant. The DPI is an automatic inhaler. It doesn't need a propellant for you to take in the drug. So for all the children, all they need is that DPI. Quite expensive though, the good technology. The MDIs are the cheaper ones, and they will need you to use a spacer with a mask or not with a mask, depending on the age. So these are our locally made spacers. We cannot say that we don't have spacers. This is what we have created. You can use a bottle and cut and make a spacer attached to the mouth, and then the inhaler is attached to the end. Or you can make a spacer with just a mouthpiece. So you open up the bottle, it enters into the mouth, and then the other end is the inhaler. This is another way of delivering the drug. We have use of our plastic disposable cups that will act as a spacer on a young child. And then the other one is a bottle steel. And then the one in purple with black background, that is the modern spacer. It can have a mask for children who are less than 6 years. My key message here today is asthma can be controlled well if you have appropriate therapies, that is the controllers, and the short-acting. We need continuous education to our patients, to also our health workers, and especially to our school nurses where our children are, so that they are helped to control their acute symptoms and also encouraged to take their medication. One of the commonest cause of poor symptom control is inadequate inhaler technique. If your inhaler technique is very poor, then your drug is not delivering directly into the lungs, yet you need it into your lungs. So we need to achieve good inhaler technique. That means we need to take away the stigma associated with asthma. We encourage our patients who have asthma to have daily inhaled corticosteroids as the mainstay of treatment, other than using salbutamol whenever they need, because continuous use of salbutamol is associated with hyper-responsiveness, or your chest responds worse, what people call addictive to the drug, because your symptoms have become worse. So we encourage that they actually stay on their ICS to allow reduction of their symptoms. And then the last one is the long-acting beta agonist should always be added on if we're going to provide control medication in children with 6 years and above. We work along with the inhaled corticosteroids. Thank you very much. My main references were the Global Initiative for Asthma, which is the GINA guidelines of 2025. And we're kindly inviting you for our 10-year anniversary in MLI. Thank you.
Again, thank you, Dr. Nampija, for touching on a very important topic. I know you've just scratched the surface, and maybe later you'll tell us about the capacity building opportunities that are there at the McCherry Lung Institute and how people can get more information on the management of childhood asthma. Now, our next presenter as we go on is another very exciting presentation, and now we are going to switch gears to sickle cell disease in children and one of the disease-modifying agents. Professor Richard Idro is going to be sharing research on the use of hydroxyurea and neurocognitive impact of hydroxyurea in children with sickle cell disease. As we load Dr. Idro's presentation, the IT team should have that presentation. He shared a new version of his presentation. I'll just introduce him. Dr. Idro is joining us online. He is a pediatrician and a researcher. He's a pediatric neurologist and also the deputy principal of McChs University College of Health Sciences. He's has several years of experience in neurohealth, and he's neurohealth and malaria. And today he's going to share one of his research on the impact of hydroxyurea on neurodevelopment and a little bit about sickle cell disease. So Professor Idro, you're most welcome. Let's give him a hand clap as the team shares his presentation.
Thank you very much, Dr. Kulo, colleagues. Good morning. Thank you for the invitation and share this and listening through. We can go to the next slide. Uganda is one of the most highly burdened countries with sickle cell anemia, with sickle cell disease. And now in our country, we have the severe form, which is which is sickle cell anemia, where we have the double, the homozygous sickle cell genotype. In parts of West Africa, maybe they have sickle cell with hemoglobin C, which is less severe, and as opposed also in the Arabian countries. Worldwide, it's estimated that over 400,000 children are now born with sickle cell disease, of which about 75% are in sub-Saharan Africa. Now, previously, the outcome was really dire. Less than 80% of them reached the age of 5 years, but currently this has improved. Between 40 and 60%, yet it's still horrible, reach the age of 5 years. And this has mostly improved with some recent improvements in healthcare, which has led to, somebody says no slides are being shown. Can I share it from this side?
We are seeing the slides on this side, so maybe someone online.
Okay. You go back to the previous slide. So in one of the major impacts which we have observed over
the slides had come, but now they have disappeared online.
The person sharing has removed them.
We apologize for us. Just give us a minute.
Okay, they're back. So as the children grow, increasingly, we have been seeing an increasing number of children presenting with stroke. Now, sickle cell cerebral vasculopathy presents both as an overt stroke, but more commonly, the children sustain clinically silent infarcts, small infarcts, especially in the border zone regions, as marked in the images which will be on your right. And these infarcts accumulate with time. In the US, French, and Jamaican studies, which have previously studied these ones extensively, by age 10, between age 10 and 14, at least more than 10% of the children will have had such infarcts. But brain injury may also follow acute inflammatory events, including acute infections, malnutrition, which are really highly prevalent in our continent and may contribute to this. The problem with such infarcts, even the silent infarcts, leave alone the overt strokes, is that they may impair neurocognitive functioning. Next slide. So we set up to conduct a study. It's been actually a series of studies to work on understanding the brain impact of sickle cell in Ugandan children. Our first study was between the years 2016 and 2018, and the objective was to try to determine the burden of neurological and cognitive impairment and the risk factors for this impairment. And then the second one, following this observation, we also took an brain imaging study where we did brain MRIs and brain magnetic resonance angiograms looking at the vessels to try to define these lesions better. And then the third, still within that context, was to look at academic performance in children with sickle cell anemia. And the fourth was to look at biomarkers for evidence of this injury. Brain MRIs are not all over the country. And the question was whether we could identify a biomarker, a blood-based biomarker, which may be an indicator of the development of such silent infarcts. And then lastly, not lastly, the next to follow was a hydroxyurea trial to try to see whether we can prevent these neurological injuries with the use of hydroxyurea. And we have also done a malaria chemoprevention study, and there are other studies which are using micronutrients. Next slide. So in the first study, the goal was really to establish the age-specific burden and spectrum of pediatric brain injury in sickle cell and identify triggers and risk factors. And the hypothesis is that sickle cell brain injury starts early in childhood and progressively increased. And we then looked at different risk factors to try and explain this. Next slide. What came out clearly from this study is that we recruited 265 children in Mulago Sickle Cell Clinic. If you can go to the next slide, in Mulago Sickle Cell Clinic. In that clinic, ages between 1 year and 12 years, what was striking was the really significant age-based mortality. The number decreased markedly beyond age 5, so that the majority of children were in the ages 2 to 4. And then from age 5, 6, you started seeing an age-specific decline. 2, about 26% of these children had cognitive impairment at that time. And 3, if you go back one slide, over 50% of these children at any one time had brain infarcts, either the silent infarcts or abnormal vessels with stenosis, as in this image which we can see here. These are MRI images and magnetic resonance angiograms, and you see vessels which are blocked. Actually, they get damaged progressively, and eventually the blood flow gets blocked. With narrowing, the cerebral blood flow velocity increases, so that one of the earliest markers of the of evidence of brain injury occurring is on a transcranial Doppler measuring the blood flow. You see the blood flow in this cerebral blood flow in this child increasing and eventually going beyond 200 centimeters per second. And any child with such a blood velocity is at a very, very high risk of stroke. And the guidelines, the recommendation is that should be put on a hypertransfusion regimen. Next slide. In the study for the academic achievement, this is an image, and the image that's in the slide, there's a PhD student, it's called Subaya Kasule. Subaya conducted a study we selected children who were 6 years and older and who should be already in primary school. And we also got age-matched children without sickle cell and compared their performance on a standardized writing academic achievement test, and which looked at spelling, mathematical computation, word reading, and sentence comprehension. And clearly, the more difficult tasks, which is spelling and mathematical computation, were performed worse by the children with sickle cell anemia did worse in these areas. Of course, there are a number of things which can contribute to this. They get crises, so they are missing school. They may be unwell. Although during that time, one of the things which we did was we did the tests when the children were in steady state. Their hemoglobin was at least 7. They had not had any illness or a crisis in the previous 2 weeks. But all the same, clearly that these areas of academic achievement were the more difficult areas. Spelling and mathematical computation were most affected. Subaya has gone on to do a lot more work, and she will be sharing some of this. Next slide. Now, just as these results came in, our colleagues had also been conducting a very large trial of hydroxyurea in sickle cell. And this study was published just before we started our next study. And previously, I think many of us know we were not using hydroxyurea because of our concerns that this is a potentially an anti-cancer drug, and if we give it to our children, it may be associated with immune suppression, it may increase the risk of malaria, it may increase the risk of infections, and we may lose many children. Because of that, although it was standard of care elsewhere, actually in our region here, it was not used. So it was a very courageous study to be undertaken, led by Professor Robert Opoka, and it was published, and it is one of the things which has transformed care extensively. It demonstrated that children get less crises, they need less blood transfusion, they have fewer infections, even their well-being is much better. So as we planned to conduct the trial to try to see whether we can prevent this brain injury, because of the non-neurological improvements which were there, we could no longer do a placebo-controlled trial. Next slide. So we proposed to do a hydroxyurea trial for neurological and cognitive protection in pediatric sickle cell anemia. And we did a single-arm open-label trial where each child became its own, his or her own control. But we also had the historical controls from the first study which I had described, to try to see whether the improvements occur over time. And the objective was to evaluate the effectiveness of hydroxyurea with a starting dose of 20 milligrams per kilo, escalated to a maximal safe dose on reducing the burden of stroke and cognitive impairment in children with sickle cell anemia. We aimed to do a study for a 3-year study, 36 months, and so performed assessments at time 0, next slide, midway at 18 months. Next, please. Yes, so these are really the large objectives in more detail to determine the impact of hydroxyurea on 3 outcome measures of sickle cell vasculopathy. That is stroke, neurocognitive impairment, and transcranial Doppler velocity. But we also wanted to evaluate its impact on changes on brain MRI and magnetic resonance angiogram in a randomly selected one-third of the group. And lastly, assess changes in anemia, nutritional status, markers of inflammation over this time. Next slide. And so these are the procedures This study we started just around in COVID in 2021 and so it was a fairly difficult study to conduct. The COVID pandemic had just broken out, so we had to make quite a few changes, and continued with this study until just the end of last year, and exited all the participants at the beginning of this year. So at baseline, we measured neurocognitive functioning, transcranial Doppler velocity, measured the blood flow velocity in 8 cerebral vessels. We left the basilar, which is the 9th, and then we did an MRI or stroke mRNA. For cognition, sickle cell is thought to affect attention. So neurocognitive functioning, it affects cognition, attention, and executive function. And executive function is the ability for a child to plan things, to organize different tasks. Then attention is sustaining your ability of concentration in a task. And then cognitive functioning, of course, is a combination of this. So we selected tests which could measure this. At 18 months, we repeated these tests and then analyzed the data. There were marked improvements at 18 months. And so with the DSMB, we elected to shorten the study and ended the study at 30 months instead of 36 months. Next slide. And so this is really the trial profile. We screened 334 children and started 264 on hydroxyurea. Along the way, 4 children died, 4 got a stroke, 2 withdrew, and then 2 were lost to follow up. And at 30 months, we therefore, so in between from the children we started on hydroxyurea and end at 30 months, we lost 12 children, 4 to stroke, 4 to death, and 4 either lost to follow up or withdrawing. And we have assessments on 252. Next slide. So these were the initial assessments at 18 months. And by 18 months, we had lost, we had lost 2 children, not 3. We had lost 3 children, 2 children, and 4 children had sustained a stroke. And looking at the incidence of stroke, there was a decline, almost a 50% reduction in the incidence of stroke. For the transcranial Doppler velocity, which is the marker of risk for developing strokes and neurocognitive impairment, the mean velocity reduced from about 148 to just 130. And then for the cognitive, the neurocognitive functioning, by 18 months, the cognitive functioning had markedly improved. Attention scores had markedly improved, but the executive function measured using 2 tests remained stable. That was at the 18 months. Next slide. For the transcranial Doppler, at time 0, about 6% of the children had an abnormal transcranial Doppler velocity, which is above 200 centimeters per second. Those children, the risk of stroke within the next year is up to over 30%. But by 18 months, this had reduced to just about 2% and maintained about 2% at 30 months. Next slide. And this is the current draft. We are currently writing up this. We are currently writing up this paper. The improvements have been sustained at 30 months. The cognition, for cognition, there has been the main cognitive scores have improved by by 75%. Attention scores, the Z scores have improved by 55%, but for executive function, they have remained stable. The mean velocity for the transcranial Doppler has improved actually by about close to 17 centimeters per second in the flow velocity. Overall, the number with a child with any cognitive impairment reduced from 9% to 2.5% between baseline and 30 months. Next slide. This is really a graphic representation of the improvement in cognitive scores, in neurocognitive scores, in cognition and in attention in the two upper graphs, and then the lower ones is in executive function, the ability to plan things. Those ones have really not changed, but they maintain, they have remained stable. And our hypothesis was that hydroxyurea will either stabilize this functioning or improve it. And so in either way, the alternative hypothesis, not the null hypothesis, has been proven true. Next slide. So currently we are maintaining a long-term follow-up of these children. I did mention that we also conducted a malaria chemoprevention study, and in which we compared current standard of care with sulfadoxine paramethamine versus monthly sulfadoxine paramethamine versus weekly DP. And weekly DP reduced the incidence of malarial infections by 70%. It reduced the need for blood transfusion by 30%. There are other studies which have just recently concluded and looking at zinc and vitamin C, and we are planning a new trial to try to look at secondary strokes in these children. I want to end there and say thank you very much for listening.
Thank you, Professor Idro, for a very important piece of work that informs us. I think just picking from this, we realize that sickle cell disease is not just about pain or infections or acute chest syndrome. There's more that we are not seeing. And thank you, Professor Idro, for highlighting this. We shall have a few questions after this. But right now, I want to invite Professor Chiguli, who is no stranger to us here. She's taught and mentored most of us, and she's still passionate about teaching. And she's done also a lot of work on sickle cell disease. And now she's going to share with us her thoughts on capacity building, education around sickle cell disease and other childhood illnesses. Over to you, Professor.
Thank you very much, Dr. Akulo. Good morning, everyone. Yes, my presentation comes with a change. I have no slides. I have no slides, but I'll share with you what I think is important and should be done for sickle cell disease. I'm interested to know, selfish reasons, how many of the people here have seen me at medical school, have been my students, have worked with me. Okay, thank you very much. I'm honored. I've been a teacher since I joined my postgraduate studies in 1989, before a number of people here were born. Yes, and I'm still working. Today, I want to share with you what I think are the needs and the opportunities for capacity building in sickle cell disease. In my many years of service, sickle cell disease has been a problem at Mulago Hospital, but also beyond, and that's why I'm here. I was telling people that we've worked in that clinic, which has been there since 1968, courtesy of Professor Ndugwa, our great teacher. And it was one of the first sickle cell clinics actually in the whole world. Many countries even now don't do what we do. And I worked in that clinic as an SHO, as an intern, as a pediatrician. I saw what was happening when I was a head of department, when all the funds were going in another direction, and many people were coming and saying, we want to do work on HIV/AIDS. And I used to tell them, why don't you think about sickle cell disease? Even then, it was not the time. I think the time is now when we should all stand up and work together and do something about sickle cell disease. We've been told that there are about 8 million people living with sickle cell disease worldwide. The number could be much more. Many of them, about 75%, are in sub-Saharan Africa. And Uganda is number 5 in having the greatest number of people living with sickle cell disease in the whole world. In the whole world. Following Nigeria, India is number 2. In Africa, we have Tanzania, DRC, and Uganda. So the numbers have been given, about 20,000 children, 20 to 30,000 born with sickle cell. I have a feeling that's a small number because I believe many die before we make a diagnosis. That's why we need to build capacity to address this disease, which is of public health importance in our country. As a pediatrician, I've moved and worked in the acute care unit of Mulago. These days, not so much. But you know, going, and if you know that place, there's a cubicle where patients with sickle cell disease are. Of course, they don't need to tell you. You look and you see. You look and you feel the pain. And I remember one mother telling me, Musao, I wish my child had something else. This mother was seeing the children at Baylor over, playing and happy. And she told me that at least those with HIV are playing, and ours, we don't have any hope. And I told her that, you know, I think they also go through different challenges. But that tells you the pain that these families and these patients go through. And in order to reduce the burden, we are here talking about what can we do about this disease, which of public health importance, in order to reduce the burden, in order to improve the quality of these patients, of the caregivers, the quality of life. Many people need to be trained. We need to build the capacity of many people. Okay? And you can't build the capacity without knowing what are the needs, what is needed. And the needs are different for different groups of people. For the health workers, what are our needs? For the doctor, okay, for the nurse, for the midwife, for the community health worker, okay, that one should be at another level. What are the needs? Do we know what sickle cell disease is? There's a time when we had one medical school, and I think during our days, you would never go through Mulago or Makerere without knowing what sickle cell disease is. Then another medical school came in Western Uganda, but I don't know if they see as many patients. Probably not. But I know the patients are there in some areas. And at one time we got graduate students who would not recognize, not because they were not good, but maybe they had not seen as sickle cell. At the moment, we have universities in Dira, Busitema, Gulu. I'm sure those students know what sickle cell is because of the burden in different areas of the country. But you know, even in Mulago Hospital, the teaching hospital, it has changed. It is super specialized. So sickle cell disease and hematology on one pause, then another. So if a student is not on that ward, they may actually go through without knowing what sickle cell disease is. So everyone needs, the medical officers have graduated, the students in training at all levels, they all need, but also the specialists, those who have gone through, do they understand sickle cell? Do we understand hydroxyurea and other interventions? The use of hydroxyurea in Uganda, it has been proved, the policy is there. What is the situation on the ground? A few weeks back, there's a clinical officer working in Pakwachi who called me and said, "Doctor, I want you to help me." I said, He said, "We have hydroxyurea in the store. We have very many patients with sickle cell disease, but we don't use it because we don't know how to use it. And even the in charge here says it is my business because we had trained this lady. She had gone through one of the trainings that I'll share with you. And then she said, but you know, I'm not confident. What can I do? It's expiring." And she said, you know, if supported, I think I can start prescribing it for the patients. Okay, I said, okay, maybe you should come and stay in Mulago for some times. What about the patients and the caregivers? What are their needs? A few months back, two people called me. One is someone that I know, and he said, you know, I want to come and see you because someone told me that our child has sickle cell disease and referred us to Mulago for confirmation. Came, and it was confirmed. And then he had very many questions. Okay, what is it? How is it? What if now that this child has, will the next child have? It's a young couple. Okay, the questions are there. Okay, and another caregiver who was linked to me, a health worker came and said, you know, but you know, what is the chance of my next child having sickle cell disease? I said, I don't know. It's 1 in 4, that is the theory. But in actual fact, the chance is 1 in 2. Okay? And then I said, you know, we have to link to care hydroxyurea. I said, at this stage, do I have to start on hydroxyurea? I hear it is a very strong drug. This person is a health worker. Okay? And the questions are there. What about the others? What about the community members? What do they know about sickle cell disease? Because in order for us to address, everyone needs to know what sickle cell disease is, how it is transmitted, who is at risk of getting it, not when they have grown and they're going for premarital counseling. It's too late. It is too late. We shall not reduce the burden. Okay? Should to know what sickle cell disease is, and they need to know that, you know, I'm a carrier, I'm not a carrier, I have sickle cell disease, so if I'm a carrier, what does it mean? Okay, and I was thinking that where I come from, we have clans, and Chiguri will not get married to, my father is Chiguri, I will not marry a Bosa, same clan. Of course, a few people do. But what if these children know that, you know, if I'm a carrier, then I should not marry a carrier right from the beginning, before they start developing feelings or getting into relationships, not at the end, okay, when they have chosen their partner, okay? What are the needs of the people who are going to help us make the policies, who are going to help us talk to the population? Because as health workers, we cannot be everywhere. We cannot. The religious leaders, the politicians, we have structures right to the villages. What do they know about sickle cell disease? What should they know? And how would they know this? So the training needs are broad. Capacity building is broad for other people. And we are here talking about sickle cell. I don't know if there's any other session. I looked through the program. I did not see this. But sickle cell disease is not a disease for children. These people grow. Dr. Idro was telling us, Professor Idro, that in their study, after 5 years, many patients had died. But the survival now is higher, okay? We have a registry for over 10,000 patients with sickle cell disease, Morago, Jinja, Mbale, and Lira. The majority of these patients are 10 to 14, 5 to 10. Actually, the greatest number is 10 to 18. And 0 to 5 are not so many. So the question is why? Okay, it means people are growing with the disease. Therefore, the clinicians need to be in this talk of capacity building. The obstetricians need to be in this talk, and other people, because as people grow older, then they get complications. Many of our patients are in schools. What do schools know about sickle cell disease? Some teachers confessed, they told us, when we know that this child has sickle cell disease, we believe they are going to die. Therefore, we just look on, we don't know what to do. So these people need to know even how to manage. The school nurses, what do they know? So training should be for many people, the counselors, okay, and different roles, because these people have different roles, and the training should be different. We need super specialists. We need many people like Anne Okuro here, who are the specialists, okay, who are going to help us for the difficult cases. So my suggestion is that we need to strengthen pre-service training. I know there's a topic of sickle cell disease, and I know we are doing something, but we need to strengthen. We didn't have hydroxyurea before. I don't even think that the people who do pre-service training know about these interventions, let alone even the simplest like hydroxyurea. So we need to rethink on how to have it, not only for the doctors, for the nurses, for the pharmacists, for the clinic officers, the people who are on the ground. Okay, so pre-service training, that is important. In-service training, those people who are already qualified. Okay, people who work at the different levels, from health center 2, 3, 4, the district hospitals moving forward, because we need the clinics to be down. We need to be the care to be down where these people are, and only the people with challenges are referred to the center. And this will also be sustainable. We need to think of a way that is sustainable, so that we have trainers at every region, in every district, who can continuously build the capacity. So the train-the-trainer model, okay, is important. The community needs to be trained to know what it is, how it is passed on, and how we can prevent it, and also how we can identify the patients early enough. Okay, so this needs to be done. And there are other interventions that need to be there. School health programs, school health. Do we have school health as one of our priorities? by the Ministry of Health. Because when these school children, their capacity is built, then they will go back and train others. Okay, so school health programs, we need to include sickle cell disease. We need to train other professionals, the teachers, the counselors, and everyone. We have tried to have some efforts, okay? Personally, with a team, we have tried to have something little to build the capacity at different levels, okay? And it is possible to build the capacity of the nurses, the midwives, the clinical officers, but also the capacity of other people up to the scholars, PhD, master's level. So we need to do this. We need to engage every stakeholders. We need to work together. The Ministry of Health, the Ministry of Education, Ministry of Gender, they are supposed to be in charge of the early childhood development, okay? And everyone, we need to work together to develop strategies to reduce sickle cell disease. And I believe that capacity building is one of the things that we can do. Thank you very much.
Thank you, Professor Shiguli. I think that was a good way to summarize this session. We are pediatricians and our role is to advocate for the children. And I'm glad the Commissioner NCDs is here. I think that message has been well received, and going forward, we need to work together to really build capacity for the care of children and adults with sickle cell disease, because now they're going to adulthood. We've lost doctors who managed to go through the pediatric age group, graduated and died because of sickle cell disease. So we need to really up our game in the management and the care for children with sickle cell disease. So this was just kind of like a scratch of the surface of what NCDs are in children. You realize that there's a lot more than the infectious diseases, the minor things that we see. And if the organizers will allow me, maybe I will take just a couple of questions. I know I am between you and T, but just to allow the people who have just walked in to hear something as well on pediatrics, I'm going to ask just for maybe 2-3 questions. I see if the rapporteurs can help and pass the mic around. I see some hands up in the audience.
Thank you so much for such wonderful presentations. Things have changed a lot, and as Dr. Chiguli says, when we're in the medical school, actually, Professor Nduga was one of our icons. But you see, I'm coming to the cancers. When we were in the medical school, Burkitt's lymphoma was one of the commonest. Actually, we were talking so much about Burkitt's lymphoma. I'm just wanting to find out, we have now an integration agenda in the Ministry of Health coming up, and I'm wondering, all with the integration agenda where standalone clinics have been carved down, and now all cases are going to our OPDs with a lot of patient load. I'm wondering how our pediatricians are faring. I was recently talking to some adolescent young group sometime about 2 weeks ago. And they said, there's so much confusion, Kabuyo, they called it, in the clinics right now, in the OPD clinics, we just go pick our medicines and go. And I'm wondering to myself how this fits in. My second question, and I'm not talking about presenting to one, all of you as pediatricians. My other questions is I wonder how your peers are doing. For sickle cells, and Dr. Chiguli knows the peers, those who have actually suffered from sickle cells are very useful people. I think we're talking about their diseases. We now have CHUs, we have VHTs, all those people. And now the caregivers. Many children are actually not looked after by their own parents. They're looked after by guardians. And I know there's still a little bit of stigma in almost all diseases. How are we handling that? These are my few questions. Thank you.
Thank you. We'll take a couple more questions and then just answer them at a go. There's another hand at the back.
Thank you, Madam Chair, and I would like to thank the presenters. But my question goes to Professor Richard Idro. Richard, we appreciate that actually the half-life of dihydromethyl phosphate, DP you mentioned, is about 42 days. But I note you are giving it weekly in sickle cell disease. What would be the sequela of prolonged use of DP, given that actually it's given weekly compared to its half-life of 42 days? Second question, was there any relation in the affected area in the brain where MRI and MRA demonstrated that actually sicklers or sickle cell patients were performing poorly in mathematics? And we know that the brain is compacted into parts that deal with the letters and those that deal with figures. Was there any relationship that the sicklers were more affected in the mathematics area? Over to you, Chair.
Thank you.
Yes, one more question this side.
Let's have another question. Oh.
Thank you very much. I have a question for Dr. Nampija. My name is Dr. Kajimu David and I work with TASO. So, Dr. Nampija, I wanted you to just support me, understand. I heard that children with asthma that actually engaging in co-cultural activities like swimming, it's actually healthy and good. I'll let you give a comment on that because from the medical perspective, sometimes you hear issues of exertional dyspnea, especially if the triggers are within maybe the coldness in the air or the coldness in the water. In your view, from the expert view, do you think children with asthma it's okay to engage in all these kind of activities? Maybe the other one also is, are there alternative medicines that beyond the conventional medicine? Because nowadays we have a number of traditional, herbal remedies that actually can be helpful to people. Last one is for Professor Chiguri. I like your idea that starting from down instead of waiting at the point of premarital counseling, but how shall we mitigate the stigma right from childhood, adolescence, and sometimes difficult to legislate against feelings of love. So how can we address the issue of stigma at that level among the youngsters? Thank you.
Thank you. This is Emmanuel from Bundibuja Hospital. Professor, we appreciate the clinic of sickle cell in Bundibuja, in Mulago. However, you seem to have concentrated about sickle cell in Mulago and he left us in the upcountry. For instance, in the district where I work, we've established 2 sickle cell clinics at Bundibuja Hospital and Nyauka Health Center 4. But the challenge we face is the screening kits. As you are aware, ministry does not actually have a general screening kit that NMS supplies to the facilities. Although there is this new kit which is being developed by the Bubu product, we hope that it cascades down to the rural areas. So Ministry of Health, we really need to up our game and ensure that we have these screening kits for sickle cell at the NMS and they reach to all government facilities. Thank you.
Thank you.
Maybe we have the last question.
Mulumba Matthias Sona. I work with civil society organizations and represent ATIPA, but also lead the coalition UCAM on malaria. Yes, Professor and the rest of the presenters have listened very well and also talked to my neighbor here. It has a lot of science that probably we in communities may not understand, but it's also important for us to cascade this science to the communities in the language they understand. In line with that, my question is probably to the Commissioner, what are the efforts, for example, to disseminate some of these unscience messages to the communities, the sickle cells, because it affects the people themselves and they suffer, and sometimes the solutions are with them. what efforts are there, and out of this conference, what are we saying we can do next year, beginning January, to make sure that our communities are saved from some of these probably easy to solve problems? Thank you.
Yeah, thank you very much.
I asked the rapporteurs that is the last question so that we catch up on time. Please go on.
Thank you very much. My name is Seko Abdul Muttalib. I'm the district chairperson of Yumbe. The submissions that have been raised by the previous speakers are more academic and more professional. And mine will simply be on the political perspective. I'm a teacher by training. I've been in class for some time. And I know the challenges. Students who have been screened to be asthma positive and also sickle cell diseases have gone through. And in my own view as a teacher, I used to think that asthma and sickle cell diseases are not treatable. I'm just getting to learn from the presentations here that we can treat these diseases. I want to give a recommendation to Ministry of Health that we have regional referral hospitals, we have the general hospitals and health center force. If you go to the up-country areas, I know we not have clinics for sickle cell disease treatment and also giving maybe guidance on how we manage such diseases to parents and also caregivers. Can we make it a policy that we have the health center force, the general hospitals and regional referral hospitals in this country to be centers of treating and supporting such conditions? It's so worrying that if we say Uganda is number 5 in the whole world when it comes to sickle cell diseases, it's so worrying. I think Ministry of Health needs to be concerned about this. Thank you very much.
All right, thank you. Thank you for being a very engaging audience. And I'm glad that this raised so many questions. So I'm going to start with the team in the house first. I don't know if Professor Idro can hear me. Professor, can you hear me? Professor Idro? Okay, we'll start with the team. Let's start with the team out first. Professor Chiguli, if you could take some of your questions. You had maybe the most.
Okay, thank you. Yeah. Thank you very much for the questions. I'll try to address those that I can. The integration agenda is good, but we should plan, because I don't see how one clinic will be looking after this patient with sickle cell disease crying with a parent, a young one, an adolescent, and the next patient has diabetes. I think, though, I don't know what happens there, but I think we should try to organize ourselves. I don't believe that one health worker can see and take care of these patients and give them quality services when we are integrating, when everyone is coming at the same time. I think at that point, we need to plan which day, which time, one type of illness can be, the patients can come and treated. But as a pediatrician, I know that when our children are with the adults, they will miss out. But also, the adolescents are with everyone, the elderly and all of us, they will stop coming. So we need to think and see how we can do it, even if we want to integrate. I think the thing is for us in health services to care for these patients without special clinics. And I think this used to be the case before these special clinics came in, and we are not seeing everything at the same time in the same line. The peers, yes, they need to be used, and the caregivers, to educate, to support, and everyone needs to be educated to reduce the stigma. The issue of stigma is there, but we can work on it, and people, when they are trained and they know that this disease, sometimes they even fear a child with sickle cell disease sitting with the other person because they fear the child will spread. And with education, I think this can be dealt with. Upcountry, yes, you know, for what we do or what we've done is what we can. But the ministry, this country needs a program for sickle cell disease. We need a program coordinated by the highest organs in this country if we are to address sickle cell disease. Well planned. Otherwise, this small chiguli cannot reach everywhere. But also the ministry need to work with everyone. So we all need to work together to ensure that the patients are screened and the patients are managed. Okay, and I agree that science needs to be communicated effectively to the communities. It can be done. We've talked to parents, we've talked to those people in the communities, and we can even get materials translated to reach. We need to do this, because if we don't, and still we don't know as communities how many of these diseases are transmitted, chronic, non-chronic, how they are managed, we shall not reach where we want to reach. It's not only for sickle cell disease, but it's all for the other non-communicable diseases that we've not talked about. And yes, we need policies, and I know the ministry is doing something about it. Thank you very much.
Thank you, Professor Chiguli. Just to supplement on what some of her comments have been, someone asked about the issue of stigma and community engagement. There are certain communities that are already coming together. I was recently in Lira, and the religious leaders, the CHUs, the VHTs had actually come together, and there were local community testers and counselors for sickle cell disease. So maybe to comment that this is still being done in small clusters, and what we need to do is scale up some of these interventions. We had like a shake, so the religious leaders of different denominations actually came together, formed a task force for sickle cell disease, and each of them targeted to preach this in their different churches and mosques and different areas, and the community was very receptive. So there are models that are happening there. I think it's now the role of Ministry of Health working with the academia and other partners to scale up some of these interventions at work, but also to think about other creative and innovative ways to reach the community, but also reach the primary healthcare providers. There's already a move, we just need to scale this up. So the next questions were I will now ask Dr. Nampija to answer the question on the co-curricular activities and any alternative medicines for the management of asthma.
Okay, thank you very much, Dr. Akulo, and everyone who listened in and gave me the questions. So about asthma and exercise-induced acute exacerbations, asthma has a lot of triggers, including exercises. But what we are trying to tell people with the current research that has been done, that actually asthma can do better even with those activities. We have had people who have performed in marathons and won medals, gold medals, even with their asthma. What is important is to control your symptoms, like I talked about it. If you control your symptoms, you're able to perform, and your lungs, with those exercises, are able to grow and also do better. So we actually encourage that children should go for co-curricular activities. The other good thing about co-curricular activities, they reduce obesity. Obesity increases asthma exacerbations as well as asthma prevalence, or the asthma type associated with obesity. So if you're able to engage in activity, then chances are that your obesity is going to go down and your lung functionability will also go up and hence improve. About the alternative medications, yes, besides inhalers, we have other alternative medications which we call immune modulators. Those are quite high stake and quite expensive. Truthfully speaking, even the people in the high and middle income societies find it a challenge because they're expensive, but they actually work. The truth of the matter is we can only use immune modulators in cases where we have severity. We can start with our simple inhalers and they will help. Why am I insisting on inhalers? It's because the problem is the lung and the drug has to be administered at the root cause of the problem. You can't run away from that. So even if we look for alternatives, that is the only way shortcut. People who have used herbs, we all know as health workers that herbs, which are our plants, are the sources of medication, right? The pharmacological agents we have come from those plants. So truthfully speaking, herbs they use maybe are containing some scientific element of pharmacology that we use. Though we have also found that some people who create herbs actually use our pharmacological elements. They add them into their herbal medication or concoction. You find salbutamol tablets diluted or even corticosteroids like prednisolone diluted into their herbs. So be careful. I will not go so much there, but be careful as you use the herbs, as you also protect your liver. The other thing I want to talk about, which they asked, was basically the teacher from regional referral area, how we integrate. What we are encouraging Ministry of Health is, may they work with us to improve our essential drug list. We are running away from salbutamol tablets to salbutamol inhalers. May you provide the inhalers instead of the tablet, instead of the theophylline, the aminophylline, give us the aminophylline and magnesium sulfate so that they are able to be used to the health workers. Let them have what we have trained to use other than looking for alternatives to use. As we also look at things like stigma and training the basic knowledge and transiting it to community knowledge that can be known by everyone, going back to the roots where we come from. Thank you very much.
Thank you, Dr. Nampija. And now I will invite Professor Idro to answer, I think 2 questions were directed to you. It was about the relationship with the MRA findings and the math center in the brain, since these children were found to have difficulties with math, and then to expound more on the feasibility of DP for prophylaxis. Over to Professor Idro, if you can hear me now.
Thank you very much. One, the overall cohort was 265 children, and then we selected 81 children to do the first MRI cohort. And by that time, we had not initially planned the study to correlate whether because we didn't know even about these academic difficulties. So the number of children who are included the study was not designed to correlate the MRI findings and the academic performance. But we are currently doing a volumetric analysis of the different brains and the different regions. And it is going to take a bit of time. It's a fairly difficult process. We had underestimated it because you go region by region. And hopefully we'll be able to understand and correlate from the volumetric analysis of the brain MRI images and relate it to both cognitive functioning and then academic proficiency, whether spelling or in mathematics. Then 2, about the DP study, I thought let me just share this. We published this study at the end of last year, and this is really it's crowded, but it's the summary slide. One that all clinical malaria, that is on microscopy in children with sickle cell and anemia, when weekly DP was compared with monthly SP, there was an 80% reduction. Now, if you stratified them by use of hydroxyurea, because this study, we conducted it in Jinja and in Kitgum, and that time the use of hydroxyurea was not widespread. Again, we also did this study during COVID. It was actually quite a tough thing to do during the COVID period. And we ended about April last year and published it by December as the first set. And malaria hospitalizations, 70% reduction. But what is clear was that in children with sickle cell, just having an episode of malaria was potentially severe malaria, because 50% of the children got hospitalized. And then quite a number of cases of stroke were induced by the malarial attacks. That's the other thing. And the other unique finding was, although there was a marked reduction in the malaria incidence on those who were on DP, in children above 5 years, other illnesses were much more common in the DP arm. And we could understand this because SP has antibiotic properties. So, and we stopped penicillin prophylaxis at age 5. So one of the major questions which arose from this study is whether we are really doing the right thing by stopping penicillin prophylaxis at age 5. We put in an application to try to conduct another study, but unfortunately, these recent changes in grant funding are caught us. Hopefully, this will be done in the not far future. But practically, we chose to use weekly DP, and the reason is we know DP can prolong the QT interval, and children with sickle cell anemia have a degree of cardiomyopathy, and we didn't want to add a potentially cardiotoxic drug in the children with sickle cell anemia being given large doses. So we thought of giving small doses weekly, and really the uptake was very good. Acceptability was quite good. The parents were quite happy. We have a social science study which was aligned to it, so we evaluated. Their only concern, there are two concerns. One, DP, the test to them that it has a funny test. They some of them didn't like the test. Then the other one, of course, the pill burden had increased. But overall, the parents were really, really happy. You could, from the social science studies, some of the videos, they were really incredibly happy. We presented this to the Ministry of Health. I hope the Ministry of Health will be discussing how to implement it. But clearly, DP has a lot more advantages over SP. In the next coming, I think January, February, we'll be presenting it to the WHO Malaria Global Program, the results, because we also did a cost effectiveness study. So we measured the annual cost of care of a child on sickle cell anemia and versus and then those on DP and compared to those on SP. One of our PhD students is called Carol Kamia, actually conducted a whole PhD on the cost of care and also the cost of using the two different interventions. And these results are also available, and part of it will be presented during this conference. Thank you.
Thank you, Professor Idro. I think let's give him a clap for that. And lastly, I think in half a minute, Dr. Balagade, if you're online, just comment on, I think your question was on the changing epidemiology of childhood cancer. Initially, traditionally, we thought BL was the most common cancer in Uganda, and now from your presentation, there seems to be a change in the epidemiology. So if you could just in maybe 30 seconds address that, then we can conclude the session. Over to you, Dr. Balagade.
Thank you very much. So in the 30 seconds that I have been given, the changing epidemiology is not restricted to Uganda alone. I think that in the rest of the bucket lymphoma belt, Sub-Saharan Africa, we are all noticing that bucket lymphoma is not as prevalent, let me call it that, as we initially thought it would be. But specifically here in Uganda, there are a number of things that we think could explain why this is so. One, the numbers are bigger. So for example, at the Institute alone, we are seeing more than 4 times what we saw in 2009 in terms of patient volumes. And the patients are also coming from more representative parts of the country. So that in itself might explain. But two, more importantly, is the precision of diagnosis is so much better, because in the past we were diagnosing bucket lymphoma. There's a lot of clinical diagnosis and morphological diagnosis. And the morphological diagnosis, this is like the staining of the slide and looking at the microscope without doing the special staining, gave us high rates of bucket lymphoma. But subsequently, the studies that we have done, including looking at historical samples stored in the pathology department, have found that almost even up to 50% of those historically stored samples that were thought to be buckets weren't buckets. And so here, the study which we did in around 2014-15, when we had more precise review of the children prospectively, we found that on morphology, even when we had 2 pathologists look at the same specimen, 1/3 of what was thought to be buckets was actually not buckets. So it was other tumors that could occur in the face or in the abdomen that might look like buckets but are not buckets. So that's one of the explanations, precision of diagnosis, which is a good thing. 2, is the changing epidemiology of things, factors that are involved in the etiology of bucket lymphoma, the endemic bucket lymphoma. So it was an interplay between EBV, malaria, in that pathophysiology leading to bucket lymphoma. But we've had a lot of success with efforts in malaria, like for example, the Royal Black Malaria Program, that has been very successful, and we think that some of those interventions are having downstream effects in the endemic form of bucket lymphoma that was very common then. So much so that the bucket lymphoma we are seeing now, its presentation is not the typical one that we saw in the jaw tumor. We're getting a lot more abdominal.
Joyce, I think we had an interruption in your network, but I think we got it clearly. There is better precision in diagnosis. I'm in the childhood cancer world, so I can identify with that. Now we can diagnose down to the molecular level of childhood cancer, which really shows progress in the care for children with cancer. Now, I just want to summarize. We've come to the close of the session. I know the organizers have been very anxious to hear this, and I just want to summarize by appreciating my seniors, my mentors, my teachers for taking off time to being a part of this session. I just want us to appreciate all the panelists with a big hand. And maybe some of the messages that I just want to recap to the Ministry of Health and NCD leadership here. One is about really boosting the capacity building for NCDs in children, specifically sickle cell disease, childhood cancer, asthma, and the other NCDs in children. We need to work together to build that capacity beyond the central region down to the primary healthcare centers, but also procuring the essential drugs that we need for the treatment of children with NCDs, the inhalers, the hydroxyurea, and this should be backed by data and also informed in consultation with the experts, and then enforcing policies for NCDs in children. I think those are the 3 key messages here, but the team as the Uganda Pediatrics Association, we are committed to continue with this capacity building and supporting in really putting the child health agenda forward. I just want to appreciate the organizers for giving us this opportunity to raise awareness on issues around NCDs in children. Thank you very much, and thank you for being a very engaging audience. A big hand clap. I'll hand over to the MC now as we exit the stage.
A big hand clap to Dr. Akulo, ladies and gentlemen. Thank you, Dr. Akulo, for that. I know it was quite a long session, but thank you for bearing with us. We started 15 minutes late, but we're able to catch up. Right now, we are going to have our break, and we request that you take 20 minutes, because if you can look at the agenda, those of you who are just joining us now, let's continue to be digital. Our agenda is online. Scan, download, and then you'll be able to follow the session. So the presenters for the next session are ready, and during the break time, we shall be engaging them. Let them come and start arranging. So break tea is outside as you move, and then we should be back to start the next session. Thank you once again.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now, as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination act.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases combined with University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination app.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity.
The organizing team will request that you get people in the room. Ruth, you can help me behind there. Let the ushers and the organizing team inform the members that our time for break tea is over and we should be getting in the room for the next session. In the meantime, the chairperson for the next session, I request that you get ready so that we are able to start. Our second session is going to be hosted by Uganda Cares, AHF, and all the people that are supposed to be presenting, please ensure that you're in touch with the chairperson, who is Dr. Kazora Wilson, to make sure that your presentations are shared. And the next session will be focusing on services integration in Uganda, and we are going to have a dialogue to focus on issues of integration and this will be a dialogue with the government. We shall have the civil society and also other development partners on board to discuss issues of service integration. So colleagues, I request that you take your seats so that I'm able to introduce to you the chair for the next session, and we can be able to begin. Thank you.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts.
Okay, good afternoon once again. We are going for our second session for today, like I had mentioned, and we are going to be talking about services integration. And this session is going to be chaired by the AHF, Uganda Cares. And I would like to call upon my chair for the next session, Dr. Wilson Kazora. Please come and take your seat. You can give him a clap as he comes to take his seat. And just to mention quick feedback as you come, Chair. In the room, we have some good number of people who may not be so much in the science field. We have political, we have administrative leaders, and these are representatives of the district chairpersons, chief administrative officers, and they have requested that in the discussion and presentation, if you could try to at least break down some of the science to understandable terms, especially the abbreviations and key terms, so that they're able to follow and see how to engage the community on some of these aspects. So colleagues in the room, we also have representatives from other ministries with us. We have the Ministry of Water and Environment, we have the Law Reform Commission, Judicial Service Commission, the Judiciary, and the Office of the Prime Minister who are with us here. In addition to the Ministry of Health as the host, and also Makerere University, we also have the district stakeholders, we have district chairpersons, district health officers, chief administrative officers, and also directors of regional referral hospitals, in addition to all the participants and stakeholders that have joined us today. So, Dr. Wilson, you're welcome. You'll call upon your participants. This session will take about 1.5 hours, and we want to have some good time for the discussion according to the feedback that we have gathered. So you'll guide the presenters to mind time so that we can interact with them freely. You're most welcome. You can come and invite your speakers. Thank you.
Thank you very much, Chair. Again, Dr. Wilson Kazora, serving with HF Uganda Cares as a Quality Improvement Manager. And as we dive into this session, I'd love to say good afternoon to all of us that are here. Welcome back from the break. As I invite my panelists or discussants, I want to first recognize very specifically the team that I came with from HF Uganda Cares, led by a country program director, Mr. Henry Magala. You're welcome. Oh yes, it's a good thing to celebrate people. And so, without wasting a lot of time, allow me welcome our panelists led by Dr. Stavia, a commissioner for communicable disease prevention and control, to come and join me on the stage. Dr. Stavia, you're welcome. She in the room? Oh yes. And as she joins me on the stage, allow me also to welcome Dr. Kabona Anna, who is an assistant consultant, public health, Jinja Regional Referral Hospital, who will also be standing in for Dr. Yaye, the director, Jinja Regional Referral Hospital, who is not able to be here. So Dr. Anna, you are welcome to come and join us on the stage. In addition, as Dr. Anna comes, yes, Dr. Anna, allow me also to welcome Mrs. Flavia Chomukama, who is the Executive Director, Nafopanu, who will also be joining us for this panel discussion. So wherever you are, Mrs. Flavia, you are welcome. She's right there. It's a good thing to celebrate people when they're called up, except if you're still having some breakfast. Let's celebrate them. They're going to do an incredible work with us in this place. Dr. Anna from Jinja Regional Referral Hospital, are you in the room? So, Miss Flavia, you're welcome. Oh, yes. And then I also want to introduce another person who will be joining us in the due course of this discussion, and that will be Dr. Mutumba, who is currently not in the room, who is the Assistant Commissioner, STD AIDS Control Division at the Ministry of Health. As soon as he joins us in the room, he will be joining us in this discussion. So, and again, I want to welcome you, our panelists. One of our panelists, I don't know where they could be at the moment. Yes, Dr. Anna, please join us on the stage. So, colleagues, we are going to have a very interesting discussion this afternoon, and hopefully we are ready. I'm excited to know that we have quite a number of stakeholders in the room. Everywhere you go in the country today, there is something about integration. A few minutes ago, while we were speaking from the previous session, I still had elements of integration, knocking at the door. In fact, lately, yes, Dr. Flavia, you're welcome. In fact, I always love to say that in this year 2025, if there is anything I would call an elephant in the room, integration is the elephant in the room. When you go to the town clerk's office, you find a discussion on health systems integration. When you go to the LC5 chairperson's office, you find this discussion. And so, without wasting a lot of time, I want us to put our hands together. So, to set a stage for this discussion, I want to welcome a very experienced person. When she speaks about integration, all of us are bound to listen, because then you know you are getting the right information from the horse's mouth. And she's going to set the stage for our discussion this afternoon on integration. And she's also going to give us a background of why integration. I've had many rumors about it, but now it's time to clear the air. And allow me, and with your hands together, I want you to welcome Dr. Stavia, the Commissioner for Communicable Disease Prevention and Control, who will be giving us opening remarks, but also setting the stage for this discussion by giving us a background on integration. Dr. Stavia, you're welcome.
Thank you so much, moderator. Good afternoon to you all. I know the protocol is diverse, but I request that you allow me to stand on the protocol that is here and recognize each one of you as an important stakeholder in this conference. You are most welcome. You are most welcome. Yes, and for this particular session, allow me to thank the team, HF Uganda Cares, for creating an opportunity for us to further interrogate and discuss about service delivery integration. I am humbled that I happen to be the person to speak first about the subject. You may be wondering, why is this whole drive of service delivery integration? Why is it urgent? Why is it important? Why should we do service delivery integration? To many, before this drive even started, there was already some efforts. Some efforts, if I speak about the tuberculosis program, which I know most because that's where I have worked most of the time, there was already a discussion in there of managing non-communicable diseases that TB patients present with. Instead of these patients coming to the TB clinic, and then you have to send them to another clinic for their hypertension, for their diabetes, we started the discussion of TB and comorbidities. And I think we came up with a guideline. And this was long before this year started. But even before that, you must have participated, especially the district local government teams who are here. In the initial cast, where we went house to house, looking for tuberculosis and creating awareness. I had in the meeting, in the session that we had first today, the biggest elephant actually is not integration, is lack of awareness about health issues, disease prevention. I think that is the biggest elephant we have in the country that needs to be addressed. And the CAST approach was one of those things that we innovated to try to make tuberculosis simple and information available to all the people in our country by reaching them in their households. And we created I remember a leaflet, called it one pager, said one pager means something else, but we were trying to see how best can we have information about this disease with the people that it is affecting. Instead of waiting for those who fall very ill and are coming to the facilities, yet actually we can prevent them from getting sick. But after that, when we reached the homes, we were overwhelmed with the issues that people go through. So before we could plan for the next round of going back to create awareness, because it was a 6-monthly program, the HIV world said, no, you cannot leave HIV behind. But we had not left it behind because whenever we find someone who is suspected to have TB, we were supposed to also check their HIV status. We did that alongside. But we also, because of the persons that are in the household, we said the opportunity of being in this household or in this community for an outreach could achieve more than just the TB service that we have come to offer. So that discussion started some time ago. And what was driving this is to make sure that the people that we serve actually receive comprehensive services for prevention and care. So around last year and I think this was also driven by what was happening in CAST at the Joint Review Mission, the communique that came up and the strong position that the ministry took was to come up with a framework on services integration. So following that, the ministry started continuing to brainstorm, to discuss, until about late last year, when we were supported by one of our partners, that we could get someone to support the ministry to actually start thinking about this framework. Early January, working with the MakCHs School of Public Health, we got one of the professors and they started the consultations and the discussions about integration. But no sooner had he set in and settled and consulted and engaged the national stakeholders than the work stop order came in. So what started as something that was going to be slowly developed and planned and until the framework is out, became an emergency. You know what happened in your districts? Those of you who are coming from regional referral hospitals, you know what happened. Everyone was in panic. As we had a good number of our health workforce being supported by the US government. It was, and these were the ones manning the HIV clinic. The most affected, I think, was the HIV services at that time, because the health workforce anyway was offering the routine health services in an integrated manner. But the HIV services and some other services had been manned by other health workers, mainly supported by external donors. So we managed the panic, and I'm happy about the decision the permanent secretary took. We started engaging at the national level. What happens? What do we do? How do the recipients of care continue to get HIV services? So together with other commissioners and the technical teams at the Ministry of Health, she led the process of what you saw as the services improvement circular that was released early February. So following that, still the health services, the recipients of care could not get the quality services that we needed, because the people who were on ground, who had been left on ground, who were the public service healthcare workers, some of them for a long time did not know how HIV was being managed in our country. So capacity issues became obvious. People were getting wrong regimens of ARVs, and so on and so forth. So we sat down as a department together with our colleagues, because the circular had more than just communicable diseases. It had issues of non-communicable diseases and systems issues. So we needed to guide and build capacity. But before we could even sit down, because of that pressure of the noise that was coming from the service providers, we had to organize online sessions to understand what is happening out there. What have you done? And then we encouraged those few that were there to start organizing few sessions to build capacity among the other people who didn't know how to offer HIV services. So we started the process of developing what we call the technical guide on service delivery integration, a simple guide showing people the steps that could be taken. And if I may rewind, if what the minister was trying to achieve with the framework was to treat the issues of silos that had been happening. If I give an example of this conference, and thanks to my commissioner, non-communicable diseases, for accepting that we work together and organize a joint conference. Thank you, Dr. Oyo. I want to recognize that. Initially, we had started to organize an infectious diseases conference. But the first engagement we had, there were sentiments about non-communicable diseases. They are on the rise. And by that time, he was already organizing a conference, I think at the Guru University on non-communicable diseases. When I reached out to him, he said, we have a conference this August, but we can go ahead. And that is how this conference came to birth. But you can imagine at the Ministry of Health, yet the person who, you may have a communicable disease today on top of a non-communicable disease. Or you may have your communicable disease, you are living with diabetes, but in your lifetime, you will definitely get what? In a way, you may get one of these communicable diseases. So bring this conference, and there are some communicable diseases that lead to non-communicable diseases. And then there are non-communicable diseases that make someone vulnerable to communicable diseases. So the fact that we have been able to come together today is one of those things that the minister wanted to achieve, to break the silos. And we come together and think together as a team about the health issues of the country. If you can think about it more broadly, apart from reproductive health, which may be unique, you may not put it in the two. It may not be a non-communicable disease or a communicable disease. The rest of the business about health is dealing with these two conditions. You will either have a communicable issue or a non-communicable issue, and so you will need to prevent it. You will need to get care. So the business about health is about preventing communicable and non-communicable diseases in our country. So this conference, I am sure, as part of the integration, breaking the integration silos, is a testimony for us to move as a team. So I am very happy about this session. I don't know how many minutes I have, moderator. So to break silos was one of the issues that the minister has had at the back of its mind in coming up with a framework, but also to ensure that we get efficiencies, create synergies. And now that one came in handy with the stop work order. And even now, even if the funding is back, we may not ever go back to the full funding that we had then, pre-stop work order. So we need to see how to use whatever will be made available to us to achieve the health that we need for our country. So efficiencies and integration are key, but above all, this person who needs our services, how are we receiving them? Are we receiving them as someone who is living with HIV and letting them go? Yet, this person may have, now they live even for their entire life, may get cancer of the breast, may get CS cervix, we already integrated, may get any other non-communicable disease because the numbers that we'll be hearing on Wednesday, they are not to only a specific group of people. They are to all of us. We are the denominator where they get the numbers that eventually they care for. So we have to deal with this denominator. If I'm looking for TB or HIV, I'm not looking for it in a specific group. Malaria is not for a specific group. It is for the entire population. So we need to rise up as a nation, as a population together and focus on the person who is likely to get this communicable disease, who is likely to get this non-communicable disease, and deliver the prevention message and prepare for care for this group of people. So this framework is aimed at improving integration across programs, strengthening the services, essential healthcare services delivery platforms, and also progressively improving the financing that we need in our country to address these conditions, and reducing the waste and fragmentation that we have observed over time, and empowering communities and individuals to take charge of their health. So service delivery integration is around there. I know the people who were used to the HIV clinics are still grumbling. Some will stay because of what is happening. You are promoting, because when we designed the technical guide, we said, if you're a higher level facility, create chronic care space where people with chronic conditions will come and receive services. If you are a lower level facility, keep the OPD mode, Health Center 3. People come, they receive services regardless of what condition they have. But that has to take time for people to accept that it is aimed at improving the quality of care they are getting from the health system. So we need all the stakeholders, the managers in the different districts, to rally behind the person-centered care, to prevent, to treat, and keep our population healthy from communicable and non-communicable diseases as the agenda. So with those few remarks, allow me to open this session and wish you good deliberations. Thank you.
I believe we could have clapped much better than that. In a good spirit, I believe that we have a good background on why integration. And I know most of us that are here could have missed that background. There's been a lot of talk, funding shock, and then we are suddenly here. But now we get to know that the ministry has been preparing something in the pipeline for quite some time. And so, thank you for setting the stage for us, Commissioner. And to all of us here, I want to invite our next speaker for the next 20 minutes, who is Dr. Anna from Jinja Regional Referral Hospital. And she's going to be answering a very interesting question. I know some of us have questions. Is integration working anywhere? Now we have an opportunity to answer the question, and this is what I want you to answer, Dr. Anna, in your presentation. How is Jinja Regional Referral Hospital advancing integration of services across departments with support from partners? Because one of the things we see is that the partners have reduced, but we still have partners. And it's a fight in some of the facilities, you know, between now the facility heads and some of the partners. Do we still need partners? There is a case example where partners are working in harmony with Jinja Regional Referral Hospital. And this is just one of the case examples where HF coexists with the Ministry of Health. And with that support from partners, we have seen improved patient outcomes and operational efficiency. And Dr. Anna, you're welcome to come and take the stage and tell us what is happening in Jinja. Thank you very much. Let's clap for her as she comes.
I think I prefer following from here.
You have to. Is it not that?
That
You
is
can follow up.
No, it's fine. You
No, you follow you for the head.
Ah.
So you step. So you point here.
Okay, cool. Thank you. Yes. Good afternoon, ladies and gentlemen, all protocol observed. I'm Dr. Kavana Anna from Jinja Regional Referral Hospital, and I'm sending greetings from the Senior Executive Consultant, Dr. Yai Alfred. So I'll be answering the question that has been asked, and yes, I think you can follow. So so this is the presentation outline. We are going to learn a little bit more about Jinja Regional Referral Hospital and the background of it, where it is located, and also when it comes to the integration of health services. The previous speaker talked about it, and I'm going to just hint about it briefly, and also how Jinja Regional Referral Hospital is carrying it out, both at the hospital but also within the region of Busoga. Yes, we are also going to look at a little bit more about the chronic care clinic, and the steps that we have taken to make sure that, yes, as the integration process is going on, we want to make sure that our patients are still getting the services that they need and they are not really hindered. Yes, and also the capacity building that we've been doing, the achievements, the challenges, and also the lessons learned, because this is very important that as we are progressing and we are carrying out all these different changes, there are some lessons that we've learned and we've been able to implement them not only at the facility, but also throughout the region. Yes, so Jinja Regional Referral Hospital is a 500-bed capacity public hospital that is found in Jinja City, that is in Busoga region. And it was established in the 1930s. Previously, it was a health unit for the World War II veterans, but you're going to find that later it was upgraded into our district hospital, and then eventually it became a regional referral hospital that serves Busoga region. It is the highest referral point in the region, and that was established in 1995. So it coordinates, it is the coordination hub of Busoga region, and Busoga region has 11 districts and one city, Jinja City being one of them, but we have several districts including Bugweri, Kamuli, Iganga, Luka, very many districts in there. And we're having a catchment population of around 4.5 million people. So the hospital is unique in that it has two campuses. We have the main campus and the pediatric campus, which is called Nalufenya. So you're going to find that it is 1.5 kilometers away from the main campus. So for the Nalufenya, it mainly caters to the pediatric population, but there's still one hospital. The integration efforts, we started them. It had been an ongoing process since the circular came out on the 7th of February, 2025. But it officially, we were carrying out the planning processes, we were carrying out the activities slowly, but we officially started the integration efforts on the 26th of May, 2025. So throughout that entire period, we had been doing a lot of preparations and making sure that the different departments are involved in the decision making. And I think that is one of the things that has helped, that's one of the processes that has helped Jinja Regional Referral carry out the integration a bit more smoothly, because we made sure that all the departments are involved in the decision making. So as it has been talked about, Integration, it is a concept that has been talked about on a global scale for quite some time. You'll find that there were frameworks and there were different documents that were published by WHO encouraging, talking about integration. There is even integration of health services. It was also part of the technical series that was published, that was in 2018. So you're going to find that this concept isn't exactly a new concept. It has been ongoing, and it has, on a global level, it has been encouraged. So the move from the vertical programs, as we saw, the disease-based standalone clinics to the integrated services, it's pretty much the way to go. And you're going to find that most of these conditions, like the previous speaker said, you'll find that one person has multiple diseases. It doesn't stop someone with hypertension from having malaria as well. So with the integration of services, it's one of the advantages that we will see, that the patient can get all the services at one point. So this change that Jinja Regional Referral implemented, it was also based on the circular that I've talked about, and it was aimed at making sure that we're providing quality, patient-centered and sustainable healthcare to our patients. And Jinja Regional Referral, it has taken several steps in making sure that we merge the chronic diseases into one OPD. Currently, so this is something that will ensure that we provide holistic care to our patients. So the integration, like I said before, Jinja Regional Referral is the coordination hub of Busoga region. So as we are carrying out these activities at Jinja Regional Referral, we are also ensuring that the other facilities are also doing the same in the region. And it has been one of the other advantages that we've had as Busoga region is that we have very supportive DHTs when it comes to the districts. The district health teams have been very supportive, especially the DHOs and the CHO. They have been extremely supportive when it comes to integration, and they have been spearheading it also in their own districts. But we have also been fortunate that we have several partners who have been very supportive, like the previous speaker said as well. At the regional referral, we still have Uganda Cares that has been providing some support, and there are other partners that have been supporting us in the region as well. One of them is MJAP. We have the Uganda Health Activities, UHA, Enabel, World Vision, AMREF, and WHO. They have still been supporting the activities that are going on and the integration efforts that are being carried out in the region. So as of now, there was an assessment that was done by MOH to assess they have been doing some assessments to see the integration efforts and where we are scoring. And as of now, Jinja Regional Referral was scoring 90.3%, which is good. If you had to look at the different services, they were looking at health financing, they were looking at the leadership, they were looking at different parameters, and it enabled us to score highly. But like I said, the integration process is ongoing. This is showing the assessment and the different domains that were assessed. And you'll find that we look at the governance. One of the advantages that we have is that we have very strong leadership, and they have been very supportive when it comes to the different changes that we are making at the facility. And as we make the changes, we also learn from them, and then we keep on editing on what we are making, on the changes that we are making. And you're going to see as I continue with the presentation. We also looked at the service delivery, the supply chain and medicines, information management systems, human resources, the lab system, community services, health financing, quality improvement. For the health financing, it was mainly looking at whether the facility is using PHC funds to enable integration, the integration efforts to continue. So right now at the referral hospital, we are using the chronic care model. At some of the, from the health center 4s and above, we are using the chronic care model, and the health center 3s are using mainly the general OPD model. And For Jinja Regional Referral, we transformed the art building and it became the chronic care clinic. So we do have a general OPD and we have the chronic care clinic. And both of them, they have their triages in order to make sure that we are offering the best services and at a timely level, at a timely manner. Then we are also, as of now, like I said, it is a work in progress. We are carrying out all these different things, but it is a work in progress. And for the chronic care model, for the chronic diseases, they're being managed there. But we are also managing, if a patient comes in with a chronic disease and they still have another condition that they're presenting with, they're not being referred to the general OPD. They're still being seen there. Then the other thing that I really like to appreciate our partners for is that the partner with the GOU staff are working with the partner staff. So we do not have that the partners are on their end and they're only seeing their particular conditions, for example, HIV and TB, and then the GOU staff are seeing others. No, we are seeing all the chronic diseases there. We are seeing the sickle cell patients there. We are seeing HIV, TB, diabetes, hypertension. They're all being seen by the same clinicians because it doesn't stop someone from having sickle cell and HIV. But we are building, that is one of the things that we've been doing in the building the capacity of our staff to make sure that they can manage these patients. So like I said before, we have the general OPD and also the staff are working together. We operate from Monday to Saturday and we're using the electronic, we are using the Clinic Master. There are two systems. There is the IAFIA system and Clinic Master. For the referral hospital, we are using Clinic Master. For some of our other facilities in the region, they're using IAFIA, but we are going digital. Okay, and we have the OPD pharmacy. We have one OPD pharmacy for both points. This was one of our learning points that I'm going to talk to a bit later. Previously, we tried, because again, integration, this is something that came a bit, this is something that will take a bit of time for us to reach the finish line. We were doing several things to make sure that we provide the best services to our patients. For example, when it comes to the pharmacy, originally we had transformed the art pharmacy, which was mainly catering to HIV patients, and we had transformed it and made it into the chronic care pharmacy, where the antihypertensives, the diabetic medication, hydroxyurea for sickle cell, all those different medications, they were found in the chronic care pharmacy. But later, we realized that that wouldn't work because we were straining the human resource and also in terms of the privacy. So we've gone back to providing the general OPD and the chronic care clinic are both having one area where the patients are receiving the drugs. And as of now, it is working well. We haven't really received many complaints because of that change. Because when it comes to that pharmacy, there is a bit more privacy when it comes to it. And also there is a bigger waiting area. So that has been a lesson learned. I'm going to talk about it a bit more, but it is one of the lessons that we learned, that we started from one place and then we eventually had to change. Another thing that yes. So one of the other things I wanted to talk about, one of the other things I wanted to talk about to show the trends when it comes to the OPD attendances, if you are to compare with 2024 and 2025, and you're going to find, I don't know if it is a bit clear, but you're going to find that we haven't really had very significant differences in the numbers. When it comes to 2024, for example, let me give an example of May 2024 and May 2025. You're going to find that in May 2024, the OPD attendance was 7,679. but in 2025 it was 7,672. We did have a bit of drops when it came to when the integration process had just started, which wouldn't be shocking because there was a lot of fears, there was a lot of misinformation that was going on. But as of now, we have seen that the upward trend is it's coming back, and we haven't really had significant changes when it comes to the attendances in 2024 and 2025. So what are some of the advances, the key steps that we've taken as a hospital to make sure that, yes, we are carrying out the integration across the different departments? And the fact that we are having this chronic care clinic is one of those things that we can at least say that is a key step, because majority of our clinical staff, especially the doctors, they are rotating in the chronic care clinic and they're offering their services there, just like the clinical officers are also manning the general OPD. So, and majority of the staff, because when we were making these decisions, we didn't just decide on our own. We involved all the staff and the different departments. So there is a sense of ownership when it comes to the integration efforts at the hospital. We've also established a WIT team, the work improvement team, and also focal persons at the chronic care clinics. So you're going to find that with the work improvement teams, we have representation from the different departments. So any decisions that are being made in the clinic, they are part of it. We have the surgeons on board, we have the pediatricians on board, we have the clinical officers on board, we have the nurses, we have several people who are part of the WIT, and that has been very beneficial, because as we are making some of these decisions and some of these changes, we get their expert opinions based on the fact that they are working in those different areas. And those are some of the things that have enabled, that have guided us. Then for the capacity building, as we know, like the previous speaker said, before in majority of the places, the personnel who are working on some of these vertical programs, they were mainly manning those vertical programs, and the GOU staff were seeing the other patients. But now with the integration, they're working hand in hand. So you'll find that there are some gaps when it comes to the information. In the package that we were given for integration of health services, it was very helpful, because some of those conditions, they were also listed there, and we were able to carry out the trainings. But this is a work in progress. Learning is something that doesn't stop, it has to continue. And then for the shared human resource, like I said before, all the clinicians and the nurses, they're rotating in these clinics. It may be a bit of, there are a few gaps, but at least it is something that is happening. Then we're utilizing the clinic master, because we want to be digital. The hospital is aiming to be completely digital, and that is something that we are working on. But currently we are still doing the appointment keeping, not only for hypertension, DM, but also for the other chronic diseases, because we want to make sure that as we are implementing all these changes, our patients are coming back. So, and even HIV, TB, the appointment keeping is still there. Then we have also strengthened the internal referral mechanisms. One of the things that has helped us with the integration effort is that, yes, we have strengthened that internal referrals, that most of the patients are seen at one point. And then the patient education at the facility. When the patients come in the morning, patient education is one of the crucial things that we do, and integration is one of the messages that is being passed on. Not only at the referral, but also we are encouraging the districts as well to pass on the message to the patients so that they do not get scared. Because previously we had some patients who would get scared. Before the HIV patients, they were used to their space. They were used to the comfort. You come and there is a way you are treated. There is a special care that you are given. Then all of a sudden you're coming and you're seeing other groups of people there. All of a sudden you're seeing teenagers there. So it was something that we had to make sure that patient education, it was one of the earlier lessons that we learned. We had to make sure that the patient education is done every single day, so that they understand and they do not get scared and run away. So for the capacity building, like I've talked about before, this is a continuous process. And one of the things we've done is the CMEs. We are doing the CMEs, and also we are really utilizing the peer-to-peer mentorships. Because for some of our clinicians, like I said before, some people may be good at one condition and others may be good at another. So we are making sure that they work hand in hand, and it has been very beneficial. Yes, so what are some of the achievements that we've had as a facility? There are some few achievements. For example, previously we used to have, it was a bit chaotic, but as of now we have the clear patient flow, and you'll find that it is fully organized. And for the health workers, we've been grateful that yes, we still have some partners who are still supporting us, and we also have some of the volunteers, the staff. One of the reasons why we did not have a lot of issues when it came to integrating the services before is that some of the staff who were partner supported before, they still stayed with the hospital, and they have been providing a lot of support to the clinic. And all the health workers, they're seeing, if a doctor is seeing a particular, they're seeing all the cases. So we do not have that this one doctor is only seeing HIV, this one doctor is only seeing hypertension, DM, no. When you come and you have a condition, you tell, and that is part of the patient education that we are doing now, that when a patient comes, they are free to tell the staff that they have met, either the doctor or the clinical officer, the issues, all of them, and they can be managed instead, which is also helping in reducing on the transportation. Because before, if someone had hypertension, DM, maybe let me give another example of HIV, you'll find that they might have like 2 appointments in 1 month, and that is all transport that they're spending. But this has been very helpful in making sure that the patient is seen comprehensively. And then there is improved coverage of the OPD by the GOU staff, because we do have a duty roster. For the region, on a regional level, because like I say, Jinja Regional Referral is not just for Jinja alone, but it covers the other districts as well. And yes, it covers the other districts. And we've been conducting trainings at the district levels. We've been conducting mentorships, and that is something that has been very, very beneficial. And then we have also established a regional coordination mechanism. We have WITs that are established in the different districts, and they do report to us. Then all the districts and the facilities, they have access to the different dashboards. There is a dashboard on integration, there is a national dashboard on integration, and the districts have access to it, so that they see how all these scores are. And also the routine client feedback mechanism, because as you can, routine client satisfaction feedback initiative, because as we are carrying out these changes, we have to make sure that they are beneficial to the patients, and we get the feedback from the patients. And that's why it is very crucial to always look at these look at these dashboards, and then you see, and then it can help you to make adjustments. And that is what the districts have been doing. Then also the IPs are still working with the region. The different districts still have some IPs who are working with them, and that has really been beneficial for us. It has made the integration efforts a bit more smooth. Then some of the challenges that we have as a regional referral, yes, the human resource that we used to have before has reduced a bit, and also the high workload. And then the EMR, the fact that this is a system, but with change everything, it takes time for people to get used. So you'll find that when it comes to to a computer, people can take a bit of time just inputting vital information or biodata, but there is some improvement because we are also carrying out the skilling as well at the hospital. Then the drug stockouts, I think that is one of the issues that sometimes we have. And also, for example, if you want to give the patient maybe for 3 months, and then there are few drugs and you have to give for 2 months or even 1. And then the limited infrastructure, like I said, this hospital was established, it became a regional referral, yes, in 1995, but the structures are still pretty much the same, but we are working with those structures that we have. And as of now, the waiting area, when we know, one of the pushes to make sure that we utilize the pharmacy, the one pharmacy, because it had a bit of space. But in the chronic care clinic, it is perfectly arranged, and there is a bit more privacy, but the limited infrastructure the patients, they do not have really a waiting area. So those are some of the challenges that we had. And then for the regional challenges, yes, the HR constraints, the workspace constraints, because you're going to find that in some of the different facilities, with these changes, again, people were used to the privacy of and different types of care and different levels of care. But now, due to the integration, there are some changes that we have to accept. You'll find that in terms of the space, the fact that we are combining all these conditions together, some places they do have a bit of workspace constraints, but those are some of the things that they are also working on, and also the privacy challenges like I talked about. Then also the regular technical support supervisions are needed at the districts, and the high workload, again, because of the HR constraints. Currently, we have the HMIS tools, the paper-based are being phased out, and we are mainly moving towards the digital, and it has been a bit of a challenge. And also, like I said, majority of people are not very good when it comes to IT. So you'll find that if you want to input data, it takes a bit of time, but that is a work in progress, and majority of the facilities, they're working on it.
2 minutes.
Thank you.
Oh, yeah.
Okay, let me just, for the lessons learned, I've talked about some of the lessons learned. One of the key issues that we noticed is strong leadership, strong and supportive leadership. It is very crucial, because when it comes to these changes, if you are making all these different changes, you need leadership that is committed. And that is one of the beauties that we've had with Jinja Regional Referral. But also, it has helped in reducing on the duplication of services. You'll find that if this patient is going to be clerked, they do not have to necessarily come from here. They are seen by this particular doctor, and then they go to another one to be seen for the other condition that they have. So it has really helped in the duplication of services. We are making data-driven decisions. One of the things that we are doing now is that we are reviewing the data. So every single time we are keeping on board, and those are some of the things that are making sure that are guiding us in making the decisions that we are making. Even before the assessments were brought, we are doing our own internal assessments. Once we started the integration process, every single week we were doing our own assessment, and we had our own parameters. We were asking the clinical officers, the nurses, the doctors every week, and the information they would give us, the feedback they would give us, is what was guiding the decisions and what changes we have to make the following week. And that was extremely crucial, because we even reached a point where it was them who were coming to us every time to remind us that you have to do this assessment. And it helped us bridge a lot of the gaps before they became big. And then for the community involvement, like I said, we had a bit of the radio talk shows, and we'll talk about the integration process, but we need more of that. And then the regular staff engagement, the decision making at Jinja Regional Referral is made by, we make sure that all the different departments are involved. For the next steps, maybe to maintain the strong coordination, to carry out the capacity building, that is extremely important, expanding on the digital systems, and also mobilizing of sustainable funding. And then in conclusion, yes, integration, it can transform service delivery, it can improve health outcomes and optimize resource utilization. Maybe just to acknowledge the different players. Yes, thank you so much for giving me the time.
Thank you very much, Dr. Anna, as being very generous on time, because people are very attentive to this discussion. I know that we may have some questions at the end of this, but allow me, in the interest of time, again, I still have another panelist that will be speaking to us, Miss Flavia Chomukama. We've unfortunately eaten into a lot of the time, so you're going to use 15 minutes to be able to speak to us, because we want our participants here today to be able to ask some questions. Welcome.
Good afternoon, ladies and gentlemen. All protocol observed. Allow me to say thank you for inviting me to take on this session. It wasn't meant for me, but More is ready to take it on when it is called. I am Chomkama Flavia, and I'm Executive Director of the National Forum of People Living with HIV Networks in Uganda, NAFOFANU, and I'm glad to be here. The topic I'm supposed to discuss or an assessment or give an overview of the current integration process in light of communication. And for me, I have rephrased my question to say integration, not disintegration. And I think this is where I'll hinge much of what I'll be discussing. And I would also like to say that I live with HIV since 1994. When I was discovered with TB. 1995, I was one of the guinea pigs for PMTCT when we were just taking as we went into labor, and I'm glad now it has become fully blown into EMTCT, and we are seeing less mother-to-child transmission. I have undergone divorce. I have lost a husband. I have survived cancer. I have been into emotional strain since the stop work order, and I'm still the same person. And I think that is the best description of integration we are talking about. And yet, I continue to survive, and that is the voice of community. On the 7th of February, on the 27th of January, we came to office to be told, no working. And our intermediary who was giving us resources, the East-West Management Institute, was terminated a few weeks later. So much of the grant that the National Forum had was cut. So we were disabled. As if that wasn't sufficient, on the 7th of February, the Ministry of Health announced a closure, or rather to make it better, integration of HIV/TB clinics into the chronic care department or the general outpatient clinic. As if that wasn't sufficient to make us scroll and scramble and worry, in April and May, we heard of global fund reprioritization. So it was like we were under attack. And why I'm saying this is because integration wasn't meant to be only for HIV, but was meant to be for the entire health system. But much of what was done was directly affecting that person living with HIV and TB. And we are continuing to feel the brunt. We got frozen, we defrosted, we woke up, emotionally supported ourselves, and we are now in recovery mode. But I'll now speak to integration and its implementation. The first level of integration is normally about service delivery, and is looking at us, the recipients of care, as targets and beneficiaries of these programs. Unfortunately, even when we are the targets, there has not been a deliberate community health integration campaign or movement to educate us about what this integration is about. We only came to the shock of new faces, to the shock of new rooms, to the shock of getting pills, 3 tins of pills, and others are getting a small envelope of medications, and to questions, how come for you are getting a lot of money? And ladies and gentlemen, HIV is not the same as all the other diseases. It carries a stigma. It has sexual connotations. Because even us in this room, how many of us do across the counter and buy a condom, even when we have been with HIV for 40 years, and we are practitioners and health providers? So HIV is quite different. And we came to a day when we had to find ourselves on those lines. We have seen violence in some cases. I left you home. What were you doing at the clinic? We have had to explain why we went to the clinic, and we have been forced to sometimes disclose when we are not ready. And some of us have undergone violence. The integration came and is targeting target beneficiaries, but we have seen a lot of stockouts. You will say it is redistribution. As a person living with HIV, I don't care whether it is redistribution or it is complete stock out, the government has no medication. My interest is to ensure that I survive, I live another day. So over these last months, we sleep and look at the ceiling and we say, shall we have all our medication? I personally went to my clinic and I was told there is no medication. You have to go back to DTG, on which I was weaned about 5 years ago. And so I was like, I cannot take it. I was lucky because I couldn't. I called across the country. I got it from Chegegwa. But how many were able to refuse and get the right medication? We have had switches to what we had left long time ago, with advice from the physicians who have been put by this government. And we have been told the medication is there. Yes, we know that second and third line was finally brought into the country around early September, but we continue to see stockouts. We ended 3 weeks ago, they didn't have a pediatric AIDS treatment. I was told it is redistribution. A few weeks ago, Koboko didn't have third line treatment. We were told it is redistribution. When we redistribution, consider that the target needs to continue taking the medication to avoid loss to follow up, to avoid resistance, to avoid apathy, going to the clinic. Last week I went for my ARVs. I was given only 1 month. I'm supposed to be a 6 months person because I'm suppressed from 2005. But I have to go every month. That is really destabilizing, demoralizing. We are saying that there is limited loss to follow up. There is loss to follow up, and to increased up from last year. There is increased non-suppression, and these are the targets we are working for. But we are not targeting them for information, for the right timing of medication, for the right availability of medication, so that we don't spend so much moving back and forth and worrying lest we are even criminalized because we have an HIV Act that criminalizes intentional transmission. In this country, we still have that. The second level I will talk about is communities as speakers. We all know that when the cuts happened, 8,400 community health workers were laid off. We are a public service that the government has not really recognized and has taken donors to show the government that community health workforce is not only in the health facility, but is in the support groups, it's in the drop-in centers, it's in the safe space, it is in differentiated service delivery. Many of our members who have been speaking, supporting at the community level, have been laid off. It was earning a livelihood, it was providing a service. Both are gone. But I'm glad to say, recently, in the Ministry of Health, Civil Society and Community level associations mapping, we found that a number of those who are still in the communities providing pro bono services are people living with HIV. And our structures are still intact. And that's why I started with saying integration should not lead to disintegration. The community structures, and particularly that of people living with HIV, has stood the test of 30 years of time. It is immobile. You can tell me now to give you somebody in Amudat with HIV, or a community member there, an expert patient. I will do it in the next 30 minutes. And that is a structure we think integration should not disintegrate. How do we ensure that as we integrate, we bring the other services, the other community health workers together to fit into existing structures? And I thought that is the definition of integration. We have found that most of those community organizations that had come from Kampala have since evaporated because they don't have resources. But we still see our community support groups, our district forums, our sub-county forums, our support groups, our expert patients still doing that work, mobilizing, educating, holding by the hand to the facility, and remaining in the facility because we live the experience, we live passion. We know what it means to have HIV, an advanced disease. The third level is around contribution. We have done a lot of good work doing home-based care. We have been doing direct observed treatment, and we know that has reduced a bit, but we still do it in an integrated manner. We refer for family planning. We refer for SGBV prevention. We engage with police. We provide nutrition education. We provide adherence support. That is integration, ladies and gentlemen, and in the community perspective. We have champions who continue to champion in the communities on different community groups. We are into water, we are into gender, we are into climate, because this affects us. And for us, integration is not just starting. It started a long time ago. Through our clubs, through our support groups, we don't only do HIV, TB, but we go ahead and refer to the facility, because that is one of the linkage areas that we need to work with. As contributors, we have our groups, our support groups, which provide psychosocial support, livelihood support, body support, emotional support. Mental health is critical. And I would like to say we are losing a number of our people living with HIV, not because of ARVs, but because of the integration, the way it was brought into place, the way the stop work order happened. People are just wondering, shall we even live? Does our government really love us? How do we ensure that we sustain what we have gained over the last number of years? As implementers, the National Forum of People Living with HIV forum, which I inherited in January, all the money was cut. We are living, and this is just one example of communities. Most of the communities on malaria, on TB, those who were organized, a number of them, they have shut down. They have closed shop. The mapping is very clear. NAFOFAN didn't close. It closed the infrastructure because the building was dilapidated. The lease has ended, so we have to have a secretariat. We are seated at the AIDS Commission, but we don't have space. We are working online. We are virtual, but we are still here talking and working and visible. But we are only saying, what is integration without community infrastructure? What is non-communicable diseases? When people who are living with communicable diseases who would like to support and offer services don't even have where to sit to support the communities to continue the good work. We were doing treatment literacy in over 20 districts. We have motorcycles there, we don't know what is happening to them. We had cycles there, we don't know what's happening. We are no longer doing this work. We have improvised by having weekly meetings. We have every Wednesday 7:30 to 9 to ensure that we call upon our members to see if we can discuss and see what is on ground. And we are using this forum as an advocacy forum. We are using it as a monitoring forum. We are using it as a capacity building forum. We are using it for emotional support, but also for informing each other about what's going on. So ladies and gentlemen, when the stop work order happened and the termination of grants happened, most of the equipment, we were given laptops, motorcycles, we were lucky we retained ours. Many were recalled. What capacity building is that to communities where projects end and equipment, cabins, the only thing they can't take back is stationery. But virtually anything else we have been using in form of equipment, vehicles, they were taken back. So how do we be integrated? Probably the ministry needs to give us some vehicles to use so that we can do the work of public service nature that is not facilitated, but we know that without it, we cannot stand as a system of health until we reach the communities. The system must ensure it embraces communities. We have even been struggling to be in these conferences. The Self-Motherhood Conference, we struggled to be on the speakership on the table. And we are saying, how long are we going to inform ministry that we are mutual partners? We are not fighting. We would like to deliver the same health outcomes, because when we are well, the country is well, and we even move to the next level of development.
3 minutes. Ms. Flavia.
Thank you. The third level is experts, and this I'm not going to belabor. We are experts, and we are experts with our lived experiences. Our stories, our experiences inform policy, programming, and budgeting. Is it possible that we are co-opted regularly? It took a while for us to be integrated into the National Advisory Committee on Integration, on the National Task Force. We are now there. We are glad we are. We have participated in the development of the materials. We have, for the first time, been invited to do support supervision and mentorships for facilities. And we have been supported through the civil society arm to do the mentorships. And we are bringing on board person-centered, stigma-free, human rights-friendly services. And for the few places we have gone, it seems to be working. And finally, as communities, decision makers in integration, it's very, very important that we continue to be part of these programs, continue to inform them, continue to guide and also bring the community voice. It is rich. It is not quantitative in nature. It is qualitative and brings a perspective of what is exactly happening. And in that, we do community-led monitoring, where we monitor the services. The recent assessment was very clear. There is still stigma. There are still stockouts. There is still limited involvement in integration at those lower levels, except for a few places. And I would think that we need to work together to ensure that at the center, and we have already said greater involvement and meaningful involvement of people with HIV, we can replace it, greater involvement and meaningful involvement of communities in planning, programming, and budgeting. And then finally, financing. We have been part of the National HIV Financing Dialogue. And last week we had the National Financing Dialogue, always arranged by CSOs. That is the 7th. But we are also part of the National HIV Response Sustainability Roadmap Development. And we are suggesting, and it has been put in the roadmap, that we need to see deliberate investment in community system strengthening, where the donor has gone, who had seen our role and our importance, has highlighted it, and government has seen there has to be deliberate investments. And we are calling upon investments in light of social contracting, in light of deliberate Ministry of Health facilitating us and financing us to go to the communities to mobilize. There are people mobilizing. We are not fighting the VHTs or the CHUs, but we know that the work is there. It's too immense for them to do this work alone. We need to add on our communities. The public health role we play, pro bono, is very, very important. But we need to be facilitated to go beyond where we can only walk and ensure that we reach the last mile. I want to thank you, and I end by saying, let us have integration, not disintegration. Work within the existing structures and ensure that we get the joint and mutual health outcome. I want to thank you, but finally, I would like to invite all the civil society representatives in this room to stand up for recognition. Thank you for the work well done during the stockouts, during this phase, and moving forward. Thank you very much for coming.
Thank you very much, Ms. Flavia. Very touching. I could see most of you picking up your hankies. But thank you for stressing those very key ideas. And I believe as I was sitting close to Dr. Stavia, I saw her jotting down some very key elements of response. So right about now, in the next few minutes, I'd love to hear from us. Presentations have been made. It's a discussion on integration. It's been ongoing for quite some time. And I'd love to hear from us if we have any questions. Yes, from around us, and we have an expert panel here that will be responding to some of these questions. I can see some hands, so let's have a microphone go around. That's quite a number of them. Okay, so let's start from that end. I think we'll pick about 7 questions. Yes, brief to the point.
Yes, thank you very much, and very, very brilliant presentations. My name is Nathan Okiror from Bella Foundation, Uganda. And my question goes to Dr. Anna from Ginger Referral Hospital. She presented on integration and their experience in Ginger. My question is, I think you said you have you're running both models, the chronic care model and also the OPD model. Now, when you go to the chronic care model, especially, you're talking about drugs, antihypertensives, antidiabetics, My experience and the experience I had with one of the funders is that Uganda cares, to be precise, that they will provide drugs, they get some buffers to support people living with HIV who are getting care. And then they say the challenge was that we can't be able to afford these other chronic care drugs for all patients because they have to account after all. What is the experience in Ginger? Do you get these challenges? Are they providing drugs for everybody? Things like that. I think it's a challenge. And then the other question was that you also said that I think the issues of pharmacy dispensing, that you moved away from the chronic care and everybody now is getting drugs from OPD pharmacy, I think. Maybe I haven't come to Ginger Referral Hospital, but how do you manage that issues of moving from one spot to another? I thought getting drugs from one center would be better, but I don't know how you manage it, that people move from the chronic care and then they get drugs from the OPD section. Thank you very much.
Thank you very much for those questions. I'll pick another from this.
Can I speak as they get a microphone?
Yes, please.
Thank you so much. I am Kamara Daniel. I'm a nutritionist. And my question goes to Ms. Flavia Chomkama. Thank you so much for the good work. We've seen most of the persons living with HIV, they're reportingly having diabetes. And I haven't had anything related to nutrition integration in the HIV clinics, which is very, very important. In the former education, nutrition and promotion was emphasizing that when you get HIV, you should eat everything, but now it must be individualistic because each patient has their own individual nutrition needs, those who live with HIV. I'd like to hear you trying to do that, Mrs. Chomkama. I want to thank you.
Thank you very much. Allow me, I may have to dictate. The questions are quite a number, and I know we have to go for lunch. Can we have, I am being bribed? Yes, please go ahead.
Thank you so much. Thank you so much. I'm Shalom Kotsabe. I work with IDI and I support South Central Region TB HIV services. Very good presentations, and thank you so much, the presenters. One goes to Dr. Kabone, Ginger Regional Referral. I really appreciate the presentation and I'm really excited about this integration thing, but I'm really worried about the overall quality of care that we're looking at with all this integration. And the other thing, supporting the region, I see, especially in Wakiso district, whereby most of the clinicians were saying that HIV/TB patients were IDI, and all of them were withdrawn with effect from end of September. And we've had a lot of challenges that speak to, one, the medication errors. We talked about people not knowing their regimens, because we really know that it's a good thing we're integrating, seeing patients together with all the silos and everything. But we also know that most of the times the government staff have majorly been in OPD, seeing the malaria, the TB, and the diarrheas and other things in OPD. And then TB, HIV, even if I was in med school, I started them 5 years ago, things are different if I'm not practicing. And as IDI was trying to do the mentorships, the trainings and everything, but I really wanted to find out the effort the government is putting in to really support these facilities with these trainings, because we really see it's a very big problem. And of course, with the dwindling funding and everything, the sustainability from the IPs is also low. So we need to look at the long-term, plan in regards to that, but emphasizing the quality of care that we are providing to the HIV patients. Thank you so much.
Thank you very much. Yes.
Thank you so much, the presenters. My name is Michael Chiyinji from MakCHs University Joint AIDS Program, and I'm the program advisor. My first question goes to Dr. Anna. If the clinics were integrated and the attendance are going low, I'm not sure why they are going back to pre-integration levels. Either some people are moving out, or probably their appointments have been spread out throughout the whole year or something like that. I'm not so sure why the numbers have increased in a certain clinic, but then the attendances are going to pre-integration levels. The second thing is about the integration efforts at certain levels. For example, the harmonization of data management systems. We've had, you have Clinic Master, you have IAFIA, you have Clinic Master, and in the HIV clinic, I guess you're using EMR. Clinic Master everywhere. But in many facilities, there are different data systems being used between the facility and then the HIV clinic. The integration at that level, and also the supply and commodities system. Some commodities were supplied through joint medical stores, and then others through national medical stores. So the integration at that level, have all the commodities gone to national medical stores? And if they have not been there, what are we going to do about the availability in the facilities? Thank you.
Okay. Our second last question. So one and then the last one.
Thank you very much, Dr. Raymond. I work with the Ministry of Health. This is for Dr. Stavia, Commissioner. Dr. Stavia, now that we've started integration over the probably about 6 months, is there a possibility of an evaluation probably soon that can inform our scale up and then going down from probably building capacity to the lower level facilities, or are we just going straight down to the lower level facilities for the integration bit? Thank you.
Thank you. And our last question. Yes.
Good afternoon, ladies and gentlemen. My name is Collins Joshua Kabogoza. I am a postgraduate student, Masters Biomedical Engineering, Bara University. Now, mine is not really a question, it's a kind suggestion. I've loved what Ms. Flavia has talked about, and yeah, with something to do with integration and not disintegration, working within the existing systems. Something I would suggest, there are a lot of organizations that we have in Uganda. Some, like she said, are kind of dissolving down because of the funding. But how about we create something I could call a Yuga Aid for the Ugandan people? USAID was from the United States of American people. How about Yuga Aid? And this is something that can be initiated by this scientific community. I understand very many of prominent people are in this room who have the potential to initiate something like this. We create a funding, I would call it a repository of money, probably in different banks or a Bank of Uganda, where we can have a reserve of money that we can use with HIV, AIDS, we can use with tuberculosis. And I understand there are very many businessmen in Uganda living with HIV. They would love to see something like this get off the ground, and they can't get it unless it's coming from the scientific people. If they don't know about it, they'll continue going to the hospitals, and they will continue getting told that, drugs are out, we don't have them, we are going to restore, and all that stuff. But if we could find a repository, do something like that, probably we could get enough funding that we need from Uganda for the Ugandan people. Thank you very much.
Thank you too. And the millionaires are clapping. So allow me, I'm going to just entertain very brief responses, straight to the point. And I'm just going to go in order from Dr. Anna. Then, of course, Dr. Stavia, you're going to have to be the last one to respond to the multitudes. Over to you, Dr. Anna.
Yes, thank you so much for those wonderful questions. One of the key reasons as to why we delayed to fully implement the integration efforts in the hospital were some of those worries on making sure that we're providing quality care to the patients. So one of the questions they asked about the chronic care and the general OPD, yes, we have, that is the chronic care model. So we have the chronic care clinic that is running where the former art building used to be. We just transformed it and it is managed, that's why we're managing the chronic diseases. Then the general OPD is still there. So we are having 2 OPDs with 2 triages, but we have one pharmacy, and that brings me to the second question about the pharmacy, how we are managing. We tried the first method where we were having, the art building had a pharmacy. It had a pharmacy in there. And at first we brought all the drugs that were to manage the chronic diseases, even the communicable diseases, all the different conditions in the chronic care clinic, because the whole point is the patient doesn't have to move from one place to another in order to get the services. But we tried that, and eventually we realized it wasn't working, mainly due to the resource constraints of the human resource constraints. We have the pharmacists are few, dispensing those drugs takes a bit of time. So that's why we brought it back, and now we have one OPD pharmacy. And that was from the guidance of the pharmacy department. Yes, we had several discussions on that matter, several discussions, but it boiled down to the fact that that was the best decision to make sure that we are using the resources that we have. So we have one pharmacy, and that pharmacy, it has, the beauty with it is that it has a waiting area. And that was one of the big issues we had before with the chronic care clinic, because it was catering mainly to the art patients, and the waiting area wasn't so big. But when we brought in the other conditions, that was one of the challenges. And now the pharmacy, the patients, they come after being seen by the clinicians and everything is done, then they come to the pharmacy and they wait from there. When it comes to the drug stockouts, I think I'm going to tackle it with another question as well. For the drug stockouts, yes, we do not have the buffering, for example, like for HIV, but the drug stockouts are there, and it is a very big challenge, I think, in most places. One of the things, and I think you saw the circular which was released for the patient groups, one of those are some of the initiatives that we are trying to come up with, but the drug stockouts are there. The other question was on, yes, yes, the overall care, I've talked about it, the overall care of patients when it comes to the quality of care that we are delivering. Again, that's why it took some time, because we had to make sure, one of the innovations that we did during that period of time, from when the circular came out to the time when we actually fully implemented the integration in the facility, is that we're mainly utilizing the peer-to-peer mentorships, and we were encouraging the clinicians before they were managing particular conditions. You'd find that on Thursday and Friday, people know they come and they manage their patients for hypertension, DM. And that was something that they knew. But you would ask them, and there was a lot of nervousness at the beginning when it came to managing HIV, TB, because the guidelines are constantly changing. It's time out. But, yes, okay, but what we have been doing mainly, that we are doing the capacity building, the peer-to-peer mentorships, especially the peer-to-peer mentorships. Some of our partners, for example, like Uganda Cares, they have also helped in the facilitation of some of these sessions. So it has really been helpful. Then, in terms of the effort that the government is doing in ensuring that the capacity building isn't just done at the regional referral, but also in the district as a whole. Yes, we do have some limited resources, but with the few resources, again, that is one of the key issues of integration. If someone is going out and they are carrying out a support supervision, maybe they have gotten money from the malaria department, nothing stops an expert from another department to join them. That is one of the things that we are trying to emphasize. Recently, the pediatric team was working with the OBGY team. So we have to use the resources that we have for now, and we make these different innovations. If you're going out to carry out, if you're going out for the CAS campaign and you're talking about TB, nothing stops you from talking about the other conditions and carrying out the different messages, because you have the platform. So that is maybe the message that I can put out there, that as we are integrating the OPDs and the pharmacy, let's also integrate the messages that we are carrying out in the community. This will also, and also integration of the different departments. If you have fuel to go to a district and you're going for a pediatric, maybe you're going to talk about sickle cell, you can also talk about another condition as well, and also invite the expert to go with you. Yes, thank you so much. Oh, sorry, just the one for the IAFIA and clinic master. Yes, IAFIA is in the district's, clinic master is at the general, is at the regional referral. Yes, the systems, I think the ministry, someone else from the ministry will talk about it further, but yes, they have been very beneficial in management of our data. Yes, thank you so much.
Yes, Flavia, 1
Thank
minute.
you. Thank you very much. I think I had only one question, another compliment about financing. The issue of nutrition, the detail about integration will be discussed by the ministry, I believe. But as communities, in our usual work of treatment literacy or treatment education for communities we engage with, the manual, the treatment literacy manual, has got a section on nutrition. So we also do sensitization in our usual work around nutrition. And of course, in light of also the poverty-stricken communities that we work with, it's sometimes a little bit difficult also to take the medication or treatment, not only for HIV, but even diabetes and other diseases. They require that you have adequate food and nutrition. The one thing I didn't speak about was around, in this integration, this is just the final one which I had missed, is around those places where there are many centers of excellence where we get treatment who have not been integrated. And we also realize that it is becoming problematic. We see constant stockouts. And then the other one is the private not-for-profit where we were getting treatment. We saw the cost of getting medicine from there skyrocket from 2,000 we were paying to, in some places, 10,000. For nevirapine, sometimes it was 20,000. And we even had extreme cases where we were asked to pay subscription of 50,000. So how do we do that? Then finally, in light of data migration and digital processes, how do we ensure that this integration does not leave out the stories and community data? We are doing CLM. How is it integrated? And also on the recipient side, we have had cases where we have to wait for electricity and internet to get on for the queues to continue moving because people are tired of writing. They don't want to write and then enter. So how can we have this integration offer great or ready electricity availability as well as internet connectivity, because, and also maybe working offline? How long are we going to be standing in the queues as we await for electricity? And sometimes we are told, go back, come tomorrow when the electricity is back. So there are lots of things happening. It is good, integration is good. Over 80% or 90% could be accepting, but mainly in public health facilities, because that is possible. But where we are in different clinics that are not public, we have not had guidance on how to move from there to go to the general clinics. And then all of a sudden we are told, come and pick your medication. We go for a month, you have a stockhouse. You go for 3 months, you have a stockhouse. So it's really challenging. Integration is good, but still has limitations, and we need to interrogate most of these things that we are raising from the community. Thank you.
Thank you. You've raised more questions for our commissioner. So over to you, Dr. Stavia.
Okay, thank you, fellow panelists, and thank you, team, for the interactive discussion. We have moved on this integration agenda as we learn, and all of us are key to make the integration a success. The good thing is that we've been convinced that you actually think we should go person-centered care to improve the way we are managing our conditions. But we also need to be cognizant of what we have been having as challenges even before integration came. Now, I seem to hear some of those coming up here as if they have just We used to have stockouts, didn't we?
Mm.
I don't think that is because of integration. Integration has not brought more people in the country or in the catchment of the district, in the catchment of the facility. So the reason why we're having stockout cannot be integration. There must be another reason, which we need to address together to make the integration experience better. If it is funding issues, we need to all advocate for resources to have adequate funding for commodities for our people. If it is a planning issue, then we need to address the planning and acquisition of medicines from where they are kept. For the recipients of care who have not had their respective regimens, I don't think it is because of the stop work order even, or it means there was an issue in our planning process for these commodities, which I think we need to continue to work with us, you advocate with us to make sure that there is smooth planning for the commodities that we need for our people who require care. Issues of now electricity and the data systems. The issue could be because we have gone digital. But the issue of electricity is a long-standing what? So we need to work together with the Minister of Energy to make sure that we have better connectivity for electricity and so on. So there are some general things which you need to take cognizance of that have not been brought about by integration. If you said waiting area, increased maybe workload, those can be part of the discussion of the integration, and we see how to address them using the quality improvement approach like the colleagues in Ginger are doing. Someone asked about the evaluation. Like I have said, this integration process is a learning process. And in learning, you have to document every step from the beginning as we move. As I talk now, I think the team of School of Public Health is conducting an evaluation mainly on HIV integration. And thanks to the Global Fund, I think they are supporting that process. But we also have other people who are interested in supporting the documentation around integration. And every time the facility assesses itself or we go out to supervise, there's an assessment that is done across the domains for service delivery. And that information is available. The dashboards are requested the people who are managing to make them public so that people can understand how the process of integration is going. Have we integrated the supply systems? Yes, for public, we know national medical stores. And for private, we know joint medical stores, and the supply of the commodities, I think, has been largely integrated with that arrangement. We really take note of the nutrition integration with people-centered care. When you meet a person, there's nothing you miss out. We know, for example, that nutrition affects a number of conditions. HIV, like you have said, if you are malnourished, we know that you are easily going to get TB. Both if you have overnourishment, like you have diabetes, you are more prone to TB. If you are undernourished, now malnutrition, undernutrition is the key driver for TB, you're still prone. So the integration for nutrition is mandatory. It is automatic because it is a determinant of the disease states, but also it helps us prevent some of those diseases. So we need to work together. Like I said in my communication, the business we are doing in nutrition is about preventing non-communicable and communicable diseases, but also making sure that the children who are being delivered, the mothers, are in good nutritional state. That is the business in the nutrition spheres. So we need to work closely to make sure that that happens. The stigma that is loaded with HIV is real. But we also need to be aware that even non-communicable diseases, actually there is more stigma with non-communicable diseases than HIV. No, someone is saying no because of, you've been there both. It was easy for you to, no, but there is a lot of stigma with most of these conditions, but I really appreciate the HIV stigma. I know what it means. Now it is even much better. Before it was very bad. Thanks to the advocacy and the communication we have put in together with you. HIV program, I hope you are listening on the refills. Where there are medicines, I don't think the amount of refills should change, but if they are not there, we cannot give you 6 months and your colleague cannot get a supply. We need to understand if there is limited stock, we need to use what is available to serve all the people. So if we give you 6 months, your colleague who will come will not get any supply. Maybe that is what is causing that, the stock constraints. Anything else? I think that is what I can pick from what remained. The data systems are being worked on. It is taking time, but I think we will get there. The funding. We have to advocate for funding. We have to increase our domestic resource financing for the health services. Thank you.
Thank you very much, Commissioner. Come on, let's clap for them. As we end this discussion, I want to say that integration is a pathway to a Uganda where patients must not be able to choose between receiving hypertension treatment or HIV treatment or treatment for TB, but where they get a full package of services in one visit. And so for us, the vision is one visit, one client, one visit, an integrated package of services for them. And this is my parting shot to all of us. Integration is not really a cost-cutting strategy, as most of us actually may be looking at it. It is a smart investment in system resilience, equity, and sustainability. And so I want to call on all of us, whether you are a healthcare worker, a delegate from the Ministry of Health, a partner in the House, but also members of the public, that integration is the way to go. And trust me, it is going to deliver more than what our patients were previously receiving. Thank you very much for your patience and for your time. During the break, we can be able to answer more questions. I believe all these panelists will still be around. Thank you very much. Allow me to hand over to our chair. So our panelists, you can take your seats. Thank you.
Thank you, Dr. Hudson. Colleagues, a big hand clap to the last session. They have discussed quite a number of issues, and we request that this is not the end. Like Dr. Kazora has mentioned, we have a secretary that is keeping some of the issues. Please, if there's a burning issue, note it down. We shall find time to have it addressed, even during the course of other days that are coming. So for now, our lunch is ready, and it's going to be served at the Sunseed Hall. Once you move out, the ushers will direct you. And we request that you take care of your property, much as we shall have a team to stay behind to look after it. And again, please move with your lunch voucher so that you are able to be guided. Thank you, and let's try to keep time. We intend to start the next session here. here by 2:30. So we have about 40 minutes to finalize with our lunch. Thank you.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination app.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination app.
have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 500 guests for this conference. And this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination act.
We have received over 400 abstracts. We expect about 500 guests for this conference. And this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination act.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with MakCHs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination act.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with education. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities.
Sound. Good afternoon, ladies and gentlemen. You're welcome from the lunch break. Time is not on our side, and we are going to go for our third session for today. The presenters and the panelists for the third session are already with us in the room, and also the session chair is with us. This being an afternoon session, we request that we observe time so that we are able to achieve the objectives of today and the sessions that we had planned. Mr. Kato, Sulaiman, and the team, you can close the doors behind and let the ushers get in the people in the room so that we can take our seats and focus on the next session. So our afternoon session is going to be looking at issues of mental health. And to take us through this, we have a team from the ministry and a team from the key stakeholders in this area. They have prepared a panel that is going to discuss key issues, but also a keynote address to open this discussion and presentation for the afternoon. So without going any further, I would like to call upon Dr. Hafsa Rukwata. Please request that you step forward and you take your seat at the podium. You can give her a clap as she comes up. So doctor, you'll come here and you invite your panel and your keynote speaker to take us through this afternoon session. You have up to 4 p.m. That's approximately 1 hour before we go into the next session. Thank you.
Thank you very much, Mr. Michael. Good afternoon, ladies and gentlemen. It is my pleasure to welcome you back from lunch, but also to see you all here. In our world, in the mental health world, we usually see many people who work within mental health, Butabika Hospital. So we rarely see people who are outside those circles, but you're all very welcome. I understand with us we have some DHOs, the COWs, and directors of hospitals, and many other distinguished ladies and gentlemen. I'm so happy to have you here. We are going to discuss mental health, and our theme today is breaking the silence, advancing mental health awareness, and building resilience. We all know what is happening in our country. Everyone is breaking down every other day, and we are all having issues, but just keeping quiet with those issues. I think it's time we broke the silence. So I'm going to have a panel with me. But before the panel comes, I think we shall listen into the keynote address, and this is going to be said none other than Dr. Rachel. Dr. Rachel, where are you? Yes, you're going to be welcome. And after Dr. Rachel speaks, we shall listen in from one of our distinguished judges of one of the judges of the High Court. And I'm sure the room will be joined by some other big dignitaries from different sectors. So I would like to take this opportunity to invite you, Rachel. We don't have a lot of time on us. They've given us just 1 hour. So I want Adnoa to spend a lot of time talking. So we would like to see our presentation put out here. Juliet, where's our presentation? It's coming? Okay, so okay, Dr. Rachel is going to introduce herself better. I cannot do it any better, but she's coming from the McChs University School of Psychology. So she's going to give us the keynote address. Thank you. Rachel, you're welcome. We have 1 hour. We have just 15 minutes for the keynote.
Interesting. 15 minutes. Okay, we will do that. Good afternoon, everyone. Very welcome back from lunch. I'm wondering, are there more people coming in? Okay. I know usually the transition from lunch takes some time. So, is anyone helping me with the slides, or I have to do it myself? Julie, can I move them myself? Yes, I can sit there, I just need to move it. Okay, so my name is Dr. Rachel Nwagaba, just like I've been introduced. I'm from the School of Psychology, that's MakCHs University, Department of Mental Health and Community Psychology. I'm a counseling psychologist by training and practice, and I spend a lot of time teaching, but also doing clinical work. So just a summary, my research areas are there, that's interest, that I really take time. I would like to be, just like in academics, we teach, but also do research and community engagement, and I also do some consultancy work. Oh, that. Is it working? So which one? Sorry. Are you good? Okay. So mental health, just like Dr. Hafsa has said, I keep saying that we live in a very good time where we are now thinking about integration. I've been in this field for over 16 years now, and maybe 20, I will say. But I've realized that most of the times we have lived or worked in silos, which has not supported generally the well-being of the people that we serve. So I have a little personal story that comes from my childhood. At about 7 years, I was with my auntie, and she had a friend who was also a very close person to my parents. So she sent me and said, Rachel, can you help me get an item for me? I won't name it because it was quite personal. It's a cloth. And I told her, I don't put it on. And I was a very young child. But when I think back, at that point, for me, I was very interested in really observing human behavior. Because what went through my mind, and I can actually remember, I was wondering, why don't you go get it? Since you're not busy. So think about the children that you spend time with. They're usually thinking beyond what you actually imagine. So over the years, it's been an interest of mine to actually observe behavior, study behavior, pay attention to what's going on around us. So I have a very little mindfulness activity for you. That is part of the work that I do. Just look around the room. If you don't mind, you can actually stand, if you don't mind, and look around the room. Have you looked at the whole room? Okay, you can take your seat. Just have a mental note whereby you are putting down 2 questions that you're going to ask me, that you'd like to ask me, just 2 questions. You can take a mental note or write them, it's up to you. And then 2 things that you are grateful for after you looked around the room. Make sense? 2 things you're grateful for after you looked around the room, and just 2 questions that you may want to ask me. So I have an ask of you today. As we think about the well-being of all the people that we serve, or even the students that we teach, for me, my students are very special because they're people I spend a lot of time with. And I'm usually trying to project them to think beyond being at the university. What else? What are you doing as you move around? Hence, engaging them in a lot of projects. So I would like to ask you to just be present in these few minutes that we have together so that you look at mental health as is today, not as would like it to be, but what it is exactly today within our communities. So I know this is generic, you really know what it is, but let me repeat. So mental health refers to the way we think, feel, and behave. And specifically, it's an essential part of our overall well-being, encompassing our emotional welfare or well-being, cognitive functioning, social connections, and resilience. When someone's mental health breaks down, even the simplest thing in life or chore or activity in life becomes very difficult. Doctors, when you give a person medication, as long as their mental health is broken down, they will hide the medicine and they will not take it. Why? Because there's no purpose. Why should I live? But also, there is a disconnection with what is going on cognitively for them and emotionally. So you may keep giving medication, which will spend a lot of money, and the person doesn't take the medication, and you recognize the treatment outcomes are not improving or they're not positive at all. That's back. So why do we need to focus? So specifically, why do we need to focus on mental health today? One, to avoid overestimation of symptoms without data and other related consequences. I am sure you have seen a lot that is going on. There are so many reports. All of us are reporting about mental health. Anyone can come up with statistics and data at any point. So why is it important that the people in this room actually pay attention to mental health? We will be able to avoid the overestimation that happens once we are not controlling what's going on. We need to recognize the difference between what are mild symptoms, moderate, and severe symptoms. Sometimes, so let me give something that I had some time back. 1 in 4 Ugandans have a mental health condition. And many people kept calling me and they were in a panic. What is it? So everyone is not well. Actually, the person reporting could be saying that maybe 1 in every Ugandan has a mild or has mild symptoms, which we can all agree that that is possible given what's going on in a person's life. But we may not actually say that it is schizophrenia or the severe symptoms that are manifesting. So just that consciousness. The other bit, our country is relatively small. So it is not very difficult for us to actually provide services. For some of you that have traveled, which I know it's a number of you, you have found way bigger countries. So even our own country could be just like one of the states in some other countries. What does that mean? There is hope that we can actually pay attention to the details of what's going on in the different parts of our country because we can reach it. It's also important for us to consider the consequences of co-occurrence of mental health conditions, addictions, and physical ailments. So what we appreciate is the past research always showed us that separate mental health, separate physical conditions, separate addictions. What we see a lot now in the research, actually, if you are assessing for mental health, you need to be assessing for addictions. Why? One can actually lead to the other. I will take a drug to self-medicate for my mental health condition. So you may see me at the bars every evening taking a lot of alcohol, not actually because that's what I'm choosing, but because I'm trying to self-medicate for an anxiety disorder or for a depressive symptom. So just to be alert to that. And then for us, when we are doing assessments, the first questions we want to be asking, is there a medical condition? So we ask our clients, we want to pay attention to that. Are you seeing a doctor? What are they saying? So that if there's a medical condition, let them first go to the doctor. Just paying attention to those details. So co-occurrence is critical, and we need to be aware of that. We also need to see, which we already know, the impact of the COVID-19 pandemic and mental health. That brought us a whole array of new issues, or maybe what was already going on that we were not aware of. But now we had more time to actually concentrate and look inward. So post-COVID, we cannot ignore mental health services or support. Another bit, we have a very young population in Uganda. 75% are below 35 years. What does that mean? A lot of hope that we can actually work with a population, that is alert, attentive, that we can engage with. The negative aspects are they are very easy to influence, okay? So we have to be alert to their needs. And they have a lot of dreams. I just gave you a picture of the dreams of a young person. They are diverse. When you see them move, or the stories they will tell you, there is just so much going on in their minds. And they have a lot of possibilities. They imagine that they can do so many things. So we need to be alert to that as we think about mental health. Why? Because that can actually draw them in places of disappointment or frustration when they don't get what they think they should be getting quickly. And the challenges that come with just growing up and just living life. So those are some of the causes of mental health, especially among adolescent school-going children. I just collected some, there are a lot more. When you look up there, I'm sure there are many that you can relate with, that you've observed, but also research gives us a number of those, and the work we do with young people as well. So today, even as we focus on the younger individuals, think about that, because some of these are in your home. One that I would want to speak about strongly is sleep deprivation, because it is something with us. Many of our young people sleep for a very short time, not the 6 to 7 or 8 hours that are recommended, or even some 10 hours. Children are on the buses at 5:30 a.m. in the morning. They get back home at 7 or 8 p.m. and they have homework. And then they go to bed maybe at 10 or 11. Maybe they're waiting for mommy and daddy to come. So some of them actually wait. So when you look at, especially as they go through school, those in boarding school, I'm sure you've had, they wake up at 4 or sleep, 2 hours, they are reading. There's a lot of reading going on. I don't know whether that's how we read during our time. I now also talk about myself that way because I'm older than them. So just to think about those who have schools in this place who can influence the education system, sleep is a big deal, and that's a time bomb for us. There are many other things going on, pressures, academic pressures, abuse. We see a lot of that going on, despite the fact they're saying no caning, but there are other ways of abusing children that are growing in our society. Neglect, we work many or long hours, hence children feel neglected or they are actually neglected. So just paying attention to some of these things, recognizing that their mental health could get at risk because of some of these challenges. So I just wanted, this could be, I know it's something that people in this room, I'm preaching to the converted. You already have this information. Mental illness does not leave us the same. Our brains struggle once there's a mental health condition. And I just wanted to make sure I bring that image there. There are many images, you can go online and you'll find them. Parts of our brains get damaged as long as there's a mental health condition that is not diagnosed, that is not being treated. Medication supports the healing, and you'll actually see the brain heal, and the gray matter that is being lost because of a mental health condition starts to grow again, and it looks better. So let's pay attention and recognize that when you hear, whether it's a mild condition or moderate or severe, and you won't see it because it's in the brain. We are seated here, we can't check each other's brains. Once there's a condition, it keeps on getting worse. It doesn't get better unless there's treatment. So I just wanted to emphasize for those of us that are here, that are policymakers, just recognize that the 45 plus million Ugandans, once people are not treated, even if you keep treating all the other diseases, the brain keeps on degenerating. Let's talk about addictions. Remember, co-occurrence, comorbidity. Once there is an addiction, the executive functioning of the person or the individual keeps on degenerating. That's actually damage that we see through an MRI. It will show us what's going on in the person's brain as long as they have been taking drugs or substances. Also behavior addictions, let's pay attention to gambling. It's also an addiction. And you know that sports betting centers are everywhere. That has an impact on the person's brain. So it's observable, but through an MRI. So if we know individuals that are struggling with these conditions, there will be a destruction over time. Some statistics for us by people who are seated in here, colleagues, ourselves, just showing us what do we have currently in terms of mental health conditions. So some colleagues there came up with data that's in 2022 and recognized that 30.2% depression was at 30.2%. Pre-COVID, we recognized that approximately 22 to 25, that's where we were in terms of mental health conditions. During and after COVID, we can see a rise, 30 to 32% or more. And then we need to also see, Uganda brings in so many refugees. Among the refugee population, it's higher. And we have a record of 67.6%. But also, we realize that there are among children, 22.9% actually have or struggle with a mental health illness. And that was a report of 2022. Today, I want to just go into our major population of the young people. Those are some statistics available, but I want to take us to even the last one that says that girls and senior students are at a higher risk of mental health conditions. So we can pay attention to that population, but generally it's around 17% and 13.2%. That is for depression and anxiety. The most common mental health conditions among young people is anxiety and depression. That's where they score highest. So as I conclude, I would like to come to a conclusion where I'm going to ask us to just invite you, government, individuals in private sector, engage fully, be open. There's a lot of research. We have so many people that are trained today around mental health. Ask the questions, engage, collaborate. Dr. Hafsa is here, and she wants me to stop, and I'm stopping now. Some recommendations for us: let's increase awareness, integrate mental health services in the primary health care, and reduce stigma. Utilize research to inform our decisions. Recognize the importance of cultural humility and community-based service approaches. And then choose, I'm using that word intentionally, choose to hire professional mental health providers and remunerate them accordingly, because they are all available. It's a choice we have to make. We want to thank you so much. Thank you for making the time. There's a lot more we would have said, but we invite you to interest yourselves in mental health work, and there's a lot available, and we can actually collaborate and keep serving the nation. Thank you very much.
Thank you very much, Dr. Rachel. That was really wonderful. Let's give her another round of applause, please. Dr. Rachel, you have not told us why we looked around the room, but we are still here. We still have 1 hour of mental health. And yes, and she's telling me that because to be grateful, there's something that you saw around the room that you can be grateful for. Not the building, not these lights, but even the people, and even yourself, your breathing. Anyway, in the spirit of integration, we know that mental health is a cross-cutting issue. It's not only in health, it is in local governments, it is in your families, it is in your neighbors' homes, and everywhere. For us as a Ministry of Health and as the mental health fraternity, we have brought on board the justice, law, and order sector. And the next speaker Honorable Justice Gaswaga is a judge of the African Court on Human and People's Rights at Arusha, Tanzania, and a judge of the International Crimes Division of the High Court of the Republic of Uganda. Isn't that a big person? He's also a fellow of the Commonwealth Judicial Education Institute, Halifax, Canada, and an international resource person in many areas of law. Justice Gaswanga has previously worked as a chairperson of the Anti-Corruption Commission. I know we fear that a lot here in Uganda, but he wasn't here. He was in Seychelles. And he also served as an expatriate judge of the Supreme Court and the Constitutional Court of Seychelles. How many of us have been to Seychelles? Some island somewhere there in the Indian Ocean. You should go there. It's very beautiful. He will tell us, I think. He must have had a time when he was really enjoying that place. His lordship was a distinguished jurist in residence. Do you understand that? We shall know. Distinguished jurist in residence at the CWR, Center for, I forget that one. School of Law in Ohio. There's that university, the Case Western Research University, School of Law in Ohio, and there's a visiting professional at the International Criminal Court, ICC, The Hague, Netherlands. Prior to this, Justice Gaswanga was the General Secretary of the East African Magistrates and Judges Association. He has something to tell us about mental health in that sector. Can we warmly welcome the judge to speak to us? I want to be closer, so I'll be here.
I think I'm the one.
Thank you very much, Doctor. Good afternoon, everyone. Allow me to stand on the protocol that has already been established, and so that we can have a conversation this afternoon. I was invited to make a speech, and I'm used to writing and delivering judgments, so I didn't do slides, and I've prepared about 60 pages of my conversation. For us, we are not economical with words like the previous speaker. We have to share those words that we have. So, ladies and gentlemen, it gives me great pleasure to join with you this afternoon. And in particular, I would like to thank the MakCHs, the Minister of Health, and MakCHs University School of Public Health. Thank you so much for the invitation, and Dr. Babirye for always checking on me, and I don't want to say putting pressure because that might amount to something else, but for ensuring that I turn up. I was a little bit engaged and running here and there, especially outside the country. When I was told that I should come and join you, I asked the kind of audience that I was going to meet. And they told me that it's full of doctors and scientists, professors, teaching fellow professors and doctors and so on. So I said, no, this might not be easy for me. And I decided to come with a team of lawyers also, so that we can be able to balance. So for that reason, allow me to introduce part of my team. Some are still coming. With us this afternoon, we are honored to have Madam Anne. Madam Anne Muhire is the Deputy IGG of the Republic of Uganda, Inspectorate of Government. She's here. She's so much interested in the topic. She wants to know what exactly happens with the issues of mental health, because when she saw the statistics of, is it 1 out of every 4, it worried us that 1 out of every 4, they have some mental health issues. You can count 1, starting from me, 1, 2, 3, 4. That is scary. So those are, she wants to know the people she leads. How are they living? What is the effect and so on? So it's important that we get this information. So, Madam, thank you so much for making time. She's a very busy person, but she decided to be with us. Secondly, I came with Dr. Diana Musoke. She's a professor lecturing at the university. She's a lecturer, remain standing so that they can see your face. She's a lecturer of family law. In other countries, it's called domestic law. Those are issues you know when you talk about family law. And you looked at the causes there, and so on. She deals with issues of divorce, child support, people who are there, and all that. And she teaches and also deals with them. She's the leading lawyer right now in Uganda in issues of divorce and so on. You may be seated. Now, you will know other things why actually we came with her. Then we also have Madam Bako. Madam Bako, could you also stand up? She is also a lecturer at UCU and dealing with a lot of issues related as well. And most interestingly, she's writing her PhD on mental health issues. She's doing some investigation. All these people that you see, the others who are coming, the team is quite big. All those people that you see here, there are certain things I do with them that are in the area of mental health. We are not doctors, but I don't know whether you can call us Kamyufu doctors, I don't know, but something like that. That's why we are here this afternoon. Now, with my 60 pages, I've been given 30 minutes only. I've consumed about 2 so far. So I'll try to be a little bit fast. So in my remarks, I decided to prepare some bit of introduction. Then for my introduction, just talking about mental health, and I can see my sister has already done some good job about the same. I'll try to look out as a lawyer, to look out for a connection between mental health and human rights. And then I'll look at mental health issues in schools and universities and give you a few examples which we are dealing with, then make some recommendations in my conclusion. Before doing that, I want to comment about the theme. I want to commend you for making this is a great choice of the theme, breaking the silence, advancing mental health awareness and resilience, advancing mental health in schools and universities. It is said that a problem shared is a problem halved or half solved, something like that, isn't it? The question is, how do we get people to talk about this? I'm telling you because where myself and my colleagues belong, we have even VIPs there and so many other VIPs that we met. They have also children and so on who cannot easily open up for various reasons. So my speech is going to give you a very different, it's going to come from a different perspective compared to a lot of science and so on that has just been going on here. So, by advancing awareness, sensitization, and resilience, could that be the thing? Remember, mental health is a preventable disease. That's according to my research. And prevention, they say, the people tell us that prevention is better than a cure. Then the Bazungu say a stitch in time saves 9. But in my view, if not prevention or elimination, then early diagnosis of any disorder would be the best and the cheapest option. That's for me. You may correct me. For there is no health without mental health. That's my observation. So it was a very brilliant idea that you put all these people under the same roof. I want to thank you so much and commend you for that, because I know that we have researchers, policymakers, we have leaders, and so on, and now even us, the lawyers, finally are joining you. So as a judge, when I speak about the effects of mental health on the population, you know, it scares me a bit. But I speak now from a place of first-hand experience. You know, sometime in 2020, an article published by the New Vision, to be specific, I think it was on the 19th of September, 2020, featured my opinion on the need of mental health social support to judges who face challenges as a result of dealing with the gruesome evidence in some of the cases. And I'll just give you one example. You see, for us in law, I don't know about you so much, but for us in law, everything you say we want evidence. We will call for evidence. So I was training judges, and I mentioned that, you know, we need also support, because let me tell you, we hear all sorts of things that happen in society. Some of them are so horrible, you will not believe it. They are so horrible. Somebody will come and narrate in evidence how they killed another. A witness will tell you how they saw this one after even being killed, how they chopped them into small pieces and so on. Let me tell you, we've just been dealing with, I was on the panel dealing with the LRA case of Uganda versus Koyelo. I'm sure everyone at least knows something about it. But simply, this case is about what happened in northern Uganda during the Kondi times. And we had all sorts of things. We saw videos of, bodies being exhumed. Witnesses came and they kept telling us how they were forced to commit the murders, the killings, and so on. It is terrible. Young people taken, young girls taken and turned into wives and so on, and just at what age, and we just start imagining, how did this person give birth, and so on and so on. So we had witnesses coming, and you know, after every 10, 20 minutes, after saying 1, 2, 3 words, they break down, the court stops, and those are resources. We are forced to retreat to chambers. Then they go, the experts, we have to bring in experts to work on them and so on. Then they recover. Somehow when they recompose themselves, you move on for 30 minutes, they break down. Their testimony is going to take about 3 or 4 days, one single witness and so on. So I'm talking about my area, our area, with my learned colleagues here. So that is our world. So we decided that, and then we've also noticed that many other professionals too actually are prone to mental health. And I don't think you are also spared. But it is, yeah, you are the doctors, but I don't think you are spared. And it is worse actually when you doctors are also affected, because we rely on you. You are the people that are going to, when we fall sick, for me, I just come and throw myself there. I leave it to you. When you tell me swallow this, I believe you. I just swallow. Do this, that's what I will do. So I think this is a matter that we really need to discuss, and that's why we decided to come and join you. And in schools, it's worse. Now, there is no way I can leave this podium without saying something about human rights. So I have to create a relationship between mental health and human rights. And being a lawyer and a judge serving at the African Human Rights Court for Human and People's Rights, I think it would be a disservice if I walked away without making that link. So mental health, I will give my definition. She gave hers, very brief. Mine is about a page. Let me give it to you. Mental health is a state of physical, mental, emotional, and social well-being determined by the interaction of the individual with society. It is therefore shaped by the conditions in which people are born, they live, the conditions under which they work, and cannot be considered in isolation, therefore. And it also means that for them to be realized, you must have a respect for human rights. And the bottom line here is that we must recognize that mental health is intimately linked to a person's socio-economic and physical environment, including exposure to poverty, you see the causes there, violence and discrimination. This therefore calls for a holistic approach, according to me, for a holistic approach. If you closely consider most of the factors leading to depression and other mental health disorders, they stem from human rights abuses and violations. Most, according to me, I'm looking at it with another lens. For example, a student who is still under the care of their parents, they have a right to education, a right to food, a right to clothing, shelter, emotional support, among others. When such needs are not catered for, and at times, due to social pressure in schools and the like, such students may find themselves as culprits of mental health disorders. Therefore, it is crucial to bear in our minds that there is no promotion of human rights in our surroundings. When there is no promotion of human rights in our surroundings, then we have set up ourselves for failure in trying to promote and protect and promote mental health. And if mental health is not promoted, especially amongst the young people, then we stand to lose our future generation. And without being an alarmist, I want to tell you that where we are standing now, the future generation, you may have survived with so many things, but the youngsters are in trouble. We need to double our efforts in helping them out. Now I come to the main topic of advancing mental health in schools and universities. In order for us to understand this better, my sister gave some statistics, but for me, I also want to look at some statistics in addition to hers. I will start with the worldwide. Mental health issues are prevalent among adolescents in school, with rates of 50.2% for depression and 43.6% for anxiety disorder. And she has already said it, anxiety. In Uganda, approximately 24.2% of adults and then 22.9% of children in Uganda, they have a mental illness. Those other terms, I will use them interchangeably, but I know I'm in the right place. You will correct me, but at least you know what I'm communicating. You will use the right terminology. So research carried out by the School of Public Health, where some of you may have been involved, recently showed that girls carried a greater emotional load than their counterparts, the boys. And in addition, they are likely to experience emotional disorders like anxiety and depression again, compared to their male counterparts. This now brings in the gender aspect, human rights and so on, the gender aspect. The latest statistics indicate that 17.6% of children attending school in Uganda are struggling with the depressive disorders, alongside increasing instances of anxiety and insomnia. She stressed that as well. This situation can no longer be overlooked. It can no longer be overlooked. Let's now just have an example, a survey of just Kampala. We have some statistics here to just Kampala city alone. The data from there may be a little bit worrying. And you know data, some people are not captured, but the data that at least was captured. In Kampala city alone, we have 90,530 cases of mental health disorders among students. And this was registered between July 2024 and June 2025. That's a span of 12 months, 1 year. That is what we have. And now, making it a 12.2% increase compared to the previous year. I've told you we are in trouble. 12% increase is a very, very big percentage. The common mental health conditions, let us try to unpack this and see. They include epilepsy, 29%, bipolar disorder, 19%, schizophrenia, 14%, anxiety, 6.6%, and then substance and alcohol use disorders, 6.3%, and depression, 5.3%. Meanwhile, experts have warned that suicide cases are on the increase in secondary schools and higher institutions of learning. The solutions should come from here, nowhere else. There is no Muzungu going to come from anywhere to guide us. Ladies and gentlemen, I have told you that me and my team there, as you see us, we are community doctors. We are helping some people there. So we've decided that we should share with you just a few cases. They are live, they are ongoing, and you will advise us. They are ongoing, we are dealing with them. I'm not going to reveal names or particulars or so on, but just the facts. In court, we are not supposed to comment about ongoing cases. In medicine, I don't know. You can advise me, I don't want to be arrested here. You discuss, even reveal the names. Okay, fine. I'm on the right path. Example 1. There is a student who has been taking drugs since senior 2. He's currently in his final year of study and struggling to stop taking drugs. In fact, he also confesses to supply drugs to some students, and the parents are nowhere, are not aware. He also has suicide thoughts, and he has tried to kill himself 3 times in vain. He also says none of the parents know what is going on in his life. The parents pay the fees or the tuition, whatever, and provide him with money, but they are not available. Absentee parents, and so on. It is ongoing. In that case, we are advising him. Pick out the issues there because of time. My 30 minutes, I've so far used 5. I will not engage in more. Second example. Another student has been taking drugs for the last 2 years, and is also a supplier of drugs to his colleagues. He says that when he joined the campus, the parents say they would only pay the fees, and that the other requirements he has to find himself. He says he had to start supplying drugs as that brings in quick money. But to keep customers, he also needed to start consuming the drugs. He has also tried to commit suicide. And he has also been self-harming in various ways for the last 1 year. In fact, he has scars on his body. We saw them. And his parents are not aware of this. The case of insufficient provision by parents and so on. Issues also packed there. Live cases ongoing. Example 3. One boy had joined a group of S2, a group in S2, and they started taking drugs. They would go out of school and get weed cookies. But because this boy had a very good relationship with his parents, especially the father, he woke up one day and decided he no longer wanted to be part of the group. This was because he didn't want to disappoint his father, who is also his friend. His friend, he claims, he said the father is his friend. This goes to the significance of the relationship we have with our children. As parents, we have to be deliberate with our children and befriend them. To date, one of his friends confesses that the said boy has never taken drugs again. Let's look at the relationship we have with our children. How do we relate with them? Just look at this boy, how he respected his father. Example 4. Some schools have a system of restreaming the learners according to their grades. By the way, some of these things may look small and light and but they have grave effects. This is another case here. Some schools have a system of restreaming the learners according to their grades each term, which affects their self-esteem. The stability of such learners is affected, and sometimes they fail to keep up. In a certain school, 2 students came from the same village, but one of them from a relatively better school and with better grades, and they joined the same class, When they joined the senior 1, they were both allocated to the best stream, because there was stream. There was, according to him, he said there was, according to Hatch, he said there was north, east, west, and south, 4 of them. But I think south was west, that was for people. They don't call them poor students, they call them slow learners, isn't it? It boils down to the same thing, but the terminology, being diplomatic, is always good. However, as time went on, the one from the better primary school and with better grades declined in her grades and was eventually shifted to the last stream of poor performers or slow learners. This brought about pressure from her parents, who expected her to do as well as her colleague. Eventually, after efforts to improve were futile, she lost morale, gave up, and settled for the last stream until she left the school. So every other year, she would go to one step back. This learner could not cope with the stiff competition and lost interest in not only the school, but also her studies generally. Like I've told you, and I want to stress, these are live cases. In a court, everything you say must be backed up with evidence. We cite cases, so these are my authorities I'm relying on what I'm saying. But in all this, what are the causes? Why are we there? What are the causes of all this? I am glad my sister here has made my work very easy. So I will just fly over. That may help us save maybe some 5 pages and some 3 minutes, because it is very easy. I can just point out a few: stress in relation to workload, like candidate classes, and also students who are doing courses like law, engineering, medicine, and so on, you see, and coupled with high expectations from parents. Long study hours, you've talked about it. These kids leave very early in the morning and they go, 5, they leave 5:30, the mother and father also leaving, and then for them they come back at 7, father and mother coming back at 10 also, chasing after money and career, promotions and so on. And this affects them, it deprives them of enough sleep and rest, and affects their concentration, causing even some sleep disorders. Peer conflicts, they struggle in relationships with each other, especially at university, which bring things like bullying, negative teasing, body shaming, even cyberbullying, and so on. All these things are going on. Depression coming from homes, family conflicts, broken families, parents fighting and quarreling in the presence of the children. They say them, all these things, and they've told us. Trauma, childhood traumas, growing up in abusive environment. What sort of environment is your child growing up? If it's abusive, use of drugs and alcohol. This, she mentioned it, and I don't have to explain much about that. And this is going on especially at universities. But they are starting in secondary schools. These kids are buying very expensive bottles of alcohol, which even myself, I can't buy maybe once in a year, birthday or Christmas. But now the other question is, where do they get the money? They are given also too much money. It's another cause. Whereas some are being given too much money, there are some parents who are giving, they have given them pocket money nowadays, weekly allowance of about 1 million. So meaning the kid will have, university students has about 4 million a month. I don't know how much, what the salary scale in your, and whether it is worth for me to go back to school if my parents are giving me that and they have bought me even the best phone that is on the market and that kind of thing. So all these things. But the irony is that whereas that is a cause also, we also had the other one is poverty and, lack of financial hardships, lack of funding is also, another cause on the other side. Yes, then we also have too much use of social media and its influence among the children. Do you know what your children watch as you are here, especially when they are doing during holidays? I don't know whether you know. I don't know how many parents put in some restrictions here and there. But even if you put in, I have a parent who was telling me that she has a son who breaks all passwords. Even when the father's password got, he couldn't remember, he called him in, and within a few minutes, gone. So even when you put some of these restrictions, our children are too sharp. They will bypass all these things. And so what are they watching? And then for how long? You make a journey one of these days and get out of your room at about 3 a.m. and venture and just go to their rooms. You'll find them there watching or communicating with the rest of the world. They are doing things. In this era of internet, things, everything they are doing, So what are our children filling their minds with? And it's very dangerous. Again, let me give you a perspective from court. First, we had recently a case. Of a young boy who befriended a young girl online, and on their very first meeting, he killed her. It's a live case. The lawyers will tell you. I think my sister there was even involved. My sister there was involved in that case, and Justice Mutonyi dealt with it, and then killed her. And when they came back home, they asked, when they said, he told the parents out, and they also saw it because he had dragged the body and there was some blood and so on. It's a case, it's there in the court. Like I told you, for us, we deal with evidence, So how much time do they spend there, and what sort of stuff do they actually look at? Unmet emotional needs, like you've said, and then there are also these social biases and so on. Big boys, men don't cry. How? But when something is paining you here, me nowadays, I would rather go to my room and cry when people are not seeing me. If it is going to give me some relief, I would rather cry than listening to people telling me that big boys don't cry. You see, because that kills you. Absentee parents, chasing after money, like I told you, career, and so on. We are too busy, you know, hopping from one country to another. We're on this flight and the other one, and then we go back at night and so on. Sports betting, I was surprised. Gambling, I was so surprised. Anyway, let me leave it at that. The causes are just too many. But in all this, there are so many challenges. The absence of a coordinated national response. From my research, I could see that it's quite a challenge. Weak community support systems. You know, people long ago, you would get somebody to offer some counseling services easily. But nowadays, it's not easy, even within family, you see? So the system is weak. Lack of data. All these relevant data, all these worsen the whole situation. Others would include low funding, insufficient numbers of trained personnel. I was surprised to learn that we only have 50 psychiatrists in Uganda. I didn't know. The more reason I should be more careful so that I don't get into that, because 50 doctors, the ratio, that means the ratio is 1 to 1 million actually. 1 to 1 million, one psychiatrist, you know, to help 1 million people. Yet, we have already seen some statistics saying that 1 in every 4 Ugandans. Then when will the doctor get to you? I'd better remain straight. Then strain on the mental health services, which is facing an increasing number of cases and lack of psychosocial support programs in schools and workplaces. Now, underlying workplaces. When you invited me here and the flyer was sent out, I want to tell you, I received the calls and I received the calls and I received the calls and I received the calls. That goes to you, that's why I'm looking at you. Not only from the judiciary, not only from the legal fraternity, but from so many places, even now. And they complained. They said, I told them, no, mine is confined to children, school children. So they said, no. How about us, the adults who look after them? We are the ones who raise them. We have to be in good shape even before, you know, so we should be able to take good care of them. So out there's a lot of work. We have issues. But I like it when you say from our theme, how do we open up? They are not opening up. And I want to tell you that myself and the people you are seeing there, we are some of the few lawyers, if the only ones to whom people open. But we are also overwhelmed. We don't even earn a salary. We just do it on a pro bono basis, just giving back to society. But how many are there out there that cannot access us? And when I was coming in the car again, I started getting a lot of complaints. They told me, I gave them a link. They said, Judge, the link you have given us, you have really cut us out. We are supposed to pay. Is it about $300? They've told me that to access. And they said, because they wanted to attend online. That means if they wanted to attend online, it means people are curious. They are looking for solutions. There must be something happening in society out there. So this is for us in this room to come up with the solutions and see how we can deal with it. Next time, maybe we shall get a sponsor so that we open up the link and we don't limit them. They will get to know. So, we have all these issues there. If there is failure and refusal to open up, then people will be suffering. People will be suffering, and it will just aggravate the whole situation. Some fear to open up. Another person told me they fear to open up because they will be judged by the public. It's a very big challenge. But not only judging, looking at the causes, others said they might be charged in court. Because, you know, if, for instance, for us in court, if you say attempt to take your life, but the mission fails, now we charge you for attempting to take the life of that person. So you are punished. You see, so that is another fear. So opening up becomes a challenge. And that's why some of them really try to make sure that if they attempt, they must go. But we don't want to lose people. You see? Treatment gap. I was surprised to learn that 75% of mental health patients receive no treatment at all. Is that true? because they don't come to the facility. But you have everything, the manpower, the medicine, the fund and everything. Okay. So I told you that I will skip some pages. Let me conclude by looking at a few recommendations here and there. Some of them my sister has already given. What should be done in these circumstances? I just have 2 or 3 recommendations to make, very few, because the others have been already put there. And some are specific to academic institutions, our youngsters, but also some are general. One of them on the specific would be sensitization, that we need to sensitize schools and school-going children and university students about mental health. Very little, I will tell you, very little is known out there. Even big people that you would think that they know something, they don't know anything, or they don't know much, or they just know very little. And so some of them even associated, they fear to come up, they're associated with a clear, or should I say qualified or mental illness. But I've been told from what I've heard that not every mental health challenge actually qualifies as, you know those categories. Let me not bother myself. Me, I take them as the same. Yeah. Can we break the stigma and create awareness on mental health? Teach the children that it's okay, it's okay to be okay and not to be okay. And so that they can be able to speak to us and speak about their mental situation and open up. It's a very, very big challenge. And the other thing is, what we should endeavor to do also, to tell people out there, is to create a conducive environment that will make them talk. I don't know how we are going to do that, but since we are going to put our heads together, I know we will get answers. Integration of mental health into the curriculum, somebody has talked about it, and starting from lower primary up to university level. Then the policies by Minister of Health, Minister of Education. I know that there are some guidelines that were issued, but the question I have with the guidelines is implementation. Do the teachers know about these guidelines, the lecturers, school administration? How about the students themselves? Do they know about these guidelines? It's important that we bring them at the fore. How about policies on long school hours? Do we have them? Minister of Education? I spoke to somebody from Minister of Education. Long school hours. I know that there's something that one time they wanted to implement, and they said, no, coach, what we call in Uganda coaching. You remember? Everyone wants their, child to go to get better marks, and but then so they have to go for coaching. If you don't go for coaching, you are left behind. How do we balance that? And when the government started actually arresting some school administrators, there was some kind of a riot, and then people would take their children and assist the teachers to break the law by teaching them under, behind their own the bedroom, behind their homes, and so on. But the rules, there are some regulations. Then here, the role of parents. For me, when, much as our children spend more time, say about 9 months or so, 8 to 9 months with the teachers in schools, but we have a very, very big role to play. We have a very, very important role to play here as parents, because for me, it all starts from home. How can parents help us in advancing good mental health amongst these learners? Are they available to monitor and guide their children? You see, we've talked about the cases of absentee parents. Then schools to build a line of open communication with parents. That is very, very important, I'm telling you. Some kids are very good at home. Some of them are even born again at home. But I want to tell you that when they get to school at times, it is something very different. I've lectured before, and I would be surprised. But I also want to tell you from my personal experience, I was not there, but one of my nephews was telling another nephew and friends that, my son, who is at university, was complaining and telling them that Dad has forgotten that I'm at the university. He carries on with VDs even at the university. And look, because I want to know what my son is doing, So I've reduced on the visits now, but I go there and I want to know to some extent. Even on the very first day, I took him to get the room, to time the room which was going to take on and so on. But all was because of the love I have for him, because I want to know. And I always insist I want to know their friends. And the friends come home. Some of them I even travel with them up to the village. Now, what he didn't know, and he complains that I still think he's still in secondary school, I go to the lecturers. Because all the other, when he was still in secondary, I mark them, I even sign in their books. All of them. You'll find Namagunga, Smack, where I go and check in their books. Much as I fly a lot all the time, but I have that time. I'm telling you, I have it. So I go and check. So that also, and they always tell them when I've already arrived that your father has come. So when they come, they find him in the staff room. I'm already interacting with the teachers. Now that has helped me a lot to know a little bit about them and how they behave at school. And they are prevented from, I think, doing certain things because they know that I monitor Big Brother is there, much as most of the time is in the skies, but he knows what is going on. Because I have even phones for that, and I go there. Even those at university, I go and check their work. So, but how, maybe you could borrow a lift since you are clapping, it could be a good thing, but it helps you, but also monitor the friends. So you communicate with the lecturers and so on. But also we may need also to conduct some research in these schools, and so that we can know what is going on. Now I want to run to the general recommendations, as now I finally get to the end. I looked at the budget that you have, and I realized that what is allocated to mental health is less than 1% of the budget for the whole sector, means of health. I wish Dr. Diana was here. I would be looking at her. And then they allocate. All things come when they already, all she has to do is to give you what belongs to you. But also I checked, and according to World Health Organization, they recommend 5% of the health sector budget. Do they give it to you? 0.9, not even 1. So what do we do? Here I am. Much as I'm not in the Ministry of Health, but as a judge, I really, really want to appeal to government to look into this and increase on that budget. This thing is eating us. We have to fight it. It's a silent killer. Do not know even the people who are making those allocations. They don't know that they may actually need these services. So it's better that when the time comes when they need those services, you are there to be able to attend to them. So I'm worried about that budget. Then I looked at the element of staffing also. I've already said that, one psychiatrist, 50 of them in the country, to serve 1 million people. I think we need to do much more than that. And I noticed that I think within the framework, we don't have some provisions for psychiatrists, clinical psychologists, social workers, and occupational therapists. I think who should also be even distributed, concentrated in urban areas, but also deep there, because this thing is eating people. Then the public service legal framework for the Ministry of Health in particular, I think there is something there again. They don't seem to define certain roles. Psychologists, psychiatrists, clinical officers, and psychiatric nurses, so that they can be accommodated. Because it appears like when they complete their courses, they go to do other things other than coming to serve us in the sector of mental health. And this can also lead to brain drain. They will be taken away by others because they are on market. They are needed everywhere in the world. I noticed that I think with Butabika, they produce about 500, you call them psychiatric nurses, and then psychiatric nurses, and then 50, what are they called? Terminologies, clinical officers. That's a very good number every year. 500 and then the 50, that's 550. Imagine if they had places within the Ministry of Health so that, and they are distributed in the districts. How many districts do we now have as of today in Uganda? Are you sure? 142. Because they keep growing. You might be here when it's so 142 Quick mathematics, 550 divided by 142. I'm not going to ask lawyers. You help me, the scientists. I will spare them the embarrassment. Yes. How many are those per district? So every year, like that, do the multiple, and then things might change a bit. For me, that's what I think. Those are my views, and I would then multi-sectoral collaboration that my sister has already talked about. So we put our heads together and don't leave out the judiciary. I am telling you, don't leave out the judiciary. We are waiting for you. We want you to come and you know, we have a discussion. Not that we are very, very bad love, but we need you. You come and we need you. I realize I want to end with this one on legal aspects. We have to take note of, as we discuss this topic, that you know, suicide is a medical condition, according to you. But according to me and my sisters there, it is a criminal offense. So how do we deal with it? You will tell me that decriminalize it so that people can come up and open up and you know. But for me, I'm saying otherwise. So my view on that one would be that probably we should have a debate on the same. Now that lawyers have started joining you here, we should have a debate on the same so that we can have a good. And finally, again, another debate on alcohol consumption. You look at it in a different way, but the government looks at it in a different way. They are looking at the revenue they are going to collect, the taxes. And I remember the president of Uganda one time saying, was commenting, you know, how he makes his comments and so on. But then he said in Uganda, now for him, he's looking at it, yes, and for us now, we are looking at it in a very different way. Ladies and gentlemen, thank you so much for listening to me. I'm happy to have been with you.
Thank you very much, Justice Gashwanga. The chair was burning me, and I stood up and sat again. I think we're not doing very well with time, but I think you're going to give me another 10, 15 minutes, just that. Yes. So kindly, let's put our hands together for that. I'm calling these ones the new kids on the block for in the mental health world, because I think they're going to be ambassadors. They're going to help us to talk. For us, we don't know how to talk. We just say things, this is the number, I have anxiety, there's schizophrenia, there's this, and then I keep quiet. But now I am hearing another voice putting it in another language. I'm so happy that this is happening. Colleagues, ladies and gentlemen, that was the judicial's mind telling us something to do with mental health. We are in the health sector, but doing very poorly in mental health. How many of us here, district leaders, have a mental health focal person in your district? Just put up your hand, please. I'll be happy to see that person. You see? There are very few. We have 142 districts and about 20 have focal persons. But it is in the law of 2019 that every district should put in place a mental health focal person to be able to coordinate mental health services in the district. For those of you who are here and you do not have a mental health focal person, we badly need one because the mental health status of Ugandans is not okay. We need to purpose to do something differently. First, we have talked. We have told you the figures, we have told you the science, what is in there, but we are keeping quiet. Can we break the silence? Dr. Kalani, come over, we have 15 minutes. Let's get a panel. We're going to receive some people who are going to talk about just a few things. The theme is breaking the silence and building resilience within our communities. We have poor mental health in our workplaces, colleagues, ladies and gentlemen. Can we do something? We certainly have to do something. The previous speakers have talked about education. Education, yes, it is badly there because the population is highest in that side, but the workplaces are doing so poorly, and you are the sole providers. Dr. Kalani, kindly introduce the people.
Thank you so much. Let's clap for Dr. Hafsa. Her passion for mental health is palpable. She forgot that she was a session chair and, and went on to give the speech. So, in the interest of time, we have, I'm going to chair a panel of 3 people, and the intention is to advance the discussions that we've had from the previous speakers. I must say, it gives me so much joy to listen to the judge of High Court of Uganda talk about mental health in the way that you spoke. Thank you so much, and I think that is the true definition of multisectoral integration of mental health, recognizing that mental health is a cross-cutting issue. So, ladies and gentlemen, allow me invite Miss Harriet Abe, Dr. Harriet Abe. She graduated with a PhD. How many days ago? 3 days? 2 days ago. She's a fresh graduate. So Dr. Harriet Abe is a research fellow at McChs University School of Public Health, and she is going to give us a picture of the burden of substance use amongst young people in the country. Where's Dr. Harriet Abe? Okay. So I hope her presentation is up. We have about 7 minutes to present this. So over to you.
Yes, I'll just rush to the findings.
All right.
Hello, everyone, and it's a bit surreal to be here, but I'm very excited to be here to share with you some of the findings of the TREAT Consortium, where my work is a part. So right there, you can see that we have a very big team that's been looking at substance use among children. What does this work? Okay, so since I have only 5 minutes, I would like to observe all protocol and go straight to the point and build on what the justice left as his last remark, and that's looking at substance use. So for the longest discussion, most of the focus has been on adolescents and young people in universities, but under the TREAT Consortium, we found that there was much earlier use, and so our research is focusing on much younger children. Yes,
Your point here.
oh, sure.
Yeah.
Thank you.
Yeah.
Thank you very much. So as part of our methodology, we had a mixed method study that looked at adapting a child-appropriate tool to screen for substance use among children as young as 6 years of age. And this was built on evidence that showed us, I think around 2019, that children as young as 5 years were already consuming alcohol within the eastern region. And so we wanted to quantify the burden of this problem. And so we did a study in facilities, in school settings, as well as in the community. So within the facilities, we found that 1 out of 4 children that came to facilities that were aged between 6 to 17 years actually reported some form of substance use. And when I say substance use, I don't mean a little sip, a little accidental use, but actually intentional use. And within the school setting, still about 1 in 4 children who were aged between 6 to 13 years were using substances. We also found within the community that about maybe 1 in 5 children were using substances within the community. But overall, about 7.2% of the children who are aged between 6 to 13 years met the criteria for dependence. That means that you could characterize them as those that have severe use. So when it came to finding out what's, leading these children to use substances, who was initiating them, if at all, any, we found that it was mostly the exposure at home. So for alcohol, most of that exposure was happening at home, among peers, just as was stated earlier, but also this use was linked to adversity, that is separation of parents. Children who had lost a parent were more likely to be users compared to those who hadn't. Additionally, there was also the element of curiosity. So among the substances, you can see the ones I've mentioned above. The most prominent one is alcohol. And then when it came to access, how does a 6-year-old access alcohol, if at all? We found that alcohol in Mbale was so easily accessible. First of all, it was cheap, as cheap as 200 shillings, which was quite affordable. And in the event that the child could not buy it with cash, they could actually access it by doing some form of manual labor as a substitute for alcohol access. Then the other access point was the promotional trucks. So we have these, trucks that always make noise and they're promoting alcohol beverages. They often distribute these into the community free of charge because you're sampling, and some of the people who are accessing these are children. And then in addition, of course, we know the home brewing within our communities. So when we asked additionally about, among the parents who had children who were users, where do you go for help if you have a child that's a user? We found that most parents did not access any type of help for their children because they deemed alcohol or substance use as bad behavior. So it was seen as such. And so they did generally seek help for that. But among those that felt that this was extreme, you found that they expressed senses of helplessness, not knowing what to do, the stigma associated with accessing help, where people blamed you for having a problematic child. And so those sentiments ultimately hinder parents from seeking care for their children. So we went to the facilities as well to ask the question you asked, Judge, about are our facilities ready? And we found that only 1 out of 3 facilities were ready to manage substance use problems. The rest really weren't. And the biggest problem we have is the lack of trained staff who can manage these substances within facilities, as well as the underutilization of guidelines that can offer guidance for how to manage these substances. So I think the cake out of all our research is the opportunity that we gain from identifying children early, is that we piloted a screening tool that's child appropriate to help identify substance use among children. And what we found was that most parents were very positive about having children be screened within the health facilities because many of them did not know their children are drinking alcohol or using some substance. And so this then becomes the opportunity that if we can use our health facilities, our schools, as an opportunity to identify early use, then we can act early and ultimately influence the outcomes of the trend that's going wrong. So one of the key recommendations that I look at here is the one of integrating child-friendly substance use screening, not just in health facilities, because most people with substance use problems don't go to facilities, but they're going to schools, but they're also in the community. So we can use this as an opportunity. So the take-home message for us is this: we should consider screening early, acting early, to protect Uganda's next generation. Thank you.
Thank you. You can take a seat in front. Just that in the event that they allow us 1 or 2 minutes for Q&A, that can be addressed. Thank you so much, Harriet, for that presentation. Allow me welcome the second presenter. That's Anne-Mathe Solheim-Ska, who is the Director of Cluster at the Norwegian Institute of Public Health. She is also the PI of the Treat Interact project that is housed at MakCHs University School of Public Health. She will briefly talk about TREAT, but also share her experiences in multisectoral collaboration in advancing mental health. So over to you, Anna Mate.
Thank you so much. It's a pleasure to be here. And I am part of this TREAT consortium. You heard Dr. Harriet present. Sorry, I need to move because I'm too low, so I need to see the screen. So she defended her PhD thesis only a few days ago. So that's one of the great outcomes from this Norway-Uganda collaboration. So we have, yeah. So we have worked together in this consortium for close to 10 years. And before that, even longer, a close collaboration between the University of Bergen, the Norwegian Institute of Public Health, and MakCHs University. So I want to acknowledge that collaboration, and we know from research that research collaboration across countries creates better research, more cited, more impact. So it's a win-win situation. So I will go very briefly through this first slide because we already touched upon many of the topics. Let's see. We will not use more time on the prevalence. We know there are high prevalences of mental health disorders globally in an adult population as well as in the child population. What we have a specific focus on in one of the TREAT projects called the TREAT Interact project is violence prevention. And that has also been discussed earlier as one of the key determinants of mental health challenges. What is good about violence is that it's preventable. So that's why we put a lot of focus on that. So one part of my position is at the Norwegian Center for Violence and Traumatic Stress Studies. We have a whole center dedicated to the prevention of violence. And that is because it is such an important factor in the health, both physical and mental health of children and adults. There is also a lack of prevention and treatment in so many countries globally in terms of mental health. And that's why we're very happy to have this session today. Many barriers exist, and we will try to go through some of these barriers in the coming minutes in what we do in this project. There is a clear need for action given the high prevalences, the high costs, and the suffering for the individual as well. So in the TREAT Interact project, we use implementation science to investigate how we could implement a task-shifting approach for child mental health promotion. That is, we develop intervention for teachers at primary school level, and that is because we know that early intervention is key in order to prevent mental health challenges. We train the teachers, we collect data on mental health, on implementation factors, and we do this through a so-called stepped wedge trial where we have 18 schools included. We randomize these schools to receive the mental health intervention at different stages. And we use the pre-intervention data as control data, and then we see, are there any effect along the way after training of teachers in mental health literacy, in stigma, in their ability to detect those in need for further services. So we are in the last part of the data collection as for now, so we don't have the final data to present today, maybe next year. So we collect data from teachers, also from caregivers and children themselves. So the aim, as I said, is to promote mental health, starting with the kids, but thinking that this will also have an impact on the teachers and the community. When we talk about mental health, we talk both about the need for prevention at the large-scale community level, and also treatment for those in need for the services. And I think this was very nicely addressed by previous speakers, that it's not like you have or have not a mental disorder. It is a continuum, and you might move out of one condition into another, or you could have healthy periods and then things happen, and that's life. So it's complex, and we need to focus on prevention while at the same time, of course, have available evidence-based treatment methods. So in the Treat Interact project, we would like to prevent mental health problems by increasing knowledge among the teachers, giving them the tools needed to identify children in need of mental health services, so that they also can refer those in need for the health system. So in terms of prevention, we have developed this manual for the teachers. We are doing the training of the teachers throughout the trial, and then collect data before and after. In terms of the treatment they receive in the health facilities, we give training in the MakCHs program developed by the World Health Organization. We only have baseline data to present today, so I'll just briefly go through that. And this is the PhD work of my colleague Nora, who is sitting in this room. So she found an association between higher mental health knowledge among both caregivers and teachers, and also lower level of reported aggression towards the children. This is being linked to lower mental health stigma. So this is important data for us to work further on in the trial, and hope that we could increase knowledge and decrease violence and stigma. She also found that corporal punishment and aggression towards the children, it was reported by approximately 70% of the children. This is linked to higher level of mental health challenges in the kids. Also, we see that there are discrepancies between what the caregivers themselves report and what the children report. And when there are these discrepancies in the perception of violence, this is also linked to higher levels of mental health challenges. So this tells us the importance of children's voice themselves in mental health work. The last paper in this PhD defense, which is soon to be delivered, so in a few months we will be able to clap for her as well. She did a meta-analysis and systematic review and revealed high levels of probable post-traumatic stress disorder rates across African schools. So with this project, we really hope that we will be able to close some of the gaps we see within mental health. It's a small project, it's only one step moving in the right direction, but we hope to develop knowledge needed to move forward within this field. There's an intervention gap, as we talked about, there's a service gap, there are different barriers to receiving help. And there's also a big data gap, where there was a systematic review a few years ago on implementation studies. It was only a few percentages from low and middle income countries. So the majority of the implementation knowledge we have is from high income countries. We really need more focus on implementation. Of course, we need information as well on effective interventions that are developed in the context, tested in the context they are supposed to be used, but also focusing on how could this program be implemented successfully over time and with sustainability. So that was the closing from me. Here is the, let me see. So we will, just lastly, we will develop implementation guidelines that hopefully could be of use based on the results of the trial, which will be finalized by closer to summer. Thank you.
Thank you so much, Anna Mathe, for sharing those findings and presenting the role of treating in advancing mental health care in Uganda. My next speaker is from Ministry of Education. I think from this entire session, we've noted that Ministry of Education has a huge role to play if we talk about mental health of young people and people in school. So ladies and gentlemen, let's welcome Ms. Rebecca Namakula, who is a Senior Education Officer in charge of guidance and counseling in Ministry of Education and Sports. And she's broadly going to share the perspectives of Ministry of Education in advancing mental health care in young children. You have many questions that have been addressed, so kindly address.
Good afternoon, ladies and gentlemen. My name is Namakula Rebecca. I'm a mother of 3 and a wife to 1 man. I'm happy to be here. Thank you, MakCHs University School of Public Health, and thank you, Ministry of Health, for inviting me. A lot has been said about mental health, the causes, the triggers. Mainly what I'm going to share with you. Technology, where do I press now? I need your assistance here. What I'm going to share is about what we have done or what we do as Ministry of... Oh, here, okay, thank you. Here? Okay. What we... This one. Okay. What we do as Ministry of Education and Sports, or what we have done. A lot has been done and a lot has been said about... I'm going to ignore all these statistics, maybe a few here, because a lot has been said about the prevalence of depression and anxiety amongst our learners. And to add on what Justice said, there are a lot of mental health issues in our schools. But as Ministry of Education, we are saying, we are not only concentrating on learners, but we are starting with the school staff, the head teachers, the administrators, these proprietors of schools, the warden, the askari, the matron, the cooks. You can just imagine if the cook is not okay upstairs, she can poison the food of the whole school community, and we may end up losing them. So for us, we are saying that we are looking at the whole school community, and we've tried to start with the administrators, the HMs, the school managers, because when they are mentally okay, they will take mental health as a priority in their schools. When the HM is not okay, he will transfer his problems to the teachers. And what will the teachers do? The psychologists here, we know our displacement as a defense mechanism. They will transfer the problem to the teachers, and then the teachers will transfer their problems to the learners. So we are building capacity of the teachers to help them to manage their mental health, but also to be in position to help the learners, because they cannot provide what they don't have. They cannot support when themselves are also going through a lot. So that is what we are saying as Ministry of Education. We are supporting the parents, we are supporting the teachers, we are supporting the learners. Of course, parents have to come on board. Like Justice said here, many problems stem from home. Dysfunctional families, divorce, domestic violence. And for those parents who can provide whatever their children ask for, they think that that is enough. The truth is, these learners, these children need us in their lives. Recently, there is a school I went to, I won't mention the name, it's one of the big schools. I had gone to talk to the S4 before they started their exams, how to manage examination anxiety. But after the session, all these students came around, they had many issues. These children were crying. I call them children because I'm a teacher. Yeah, they were crying. And most of the problems were stemming from home. Actually, one was even contemplating suicide. So parents here are providing money, giving money is not enough. These children need us in their lives. What are we doing as Minister of Education? Of course, some policies are coming up, but to start with, we came up with Circular 20, we call it Circular 20, which we drafted in 2022. And this circular has very many things. What should be done in a school setting to see that mental health is being supported in a school community. We are talking about the mental health hour. We are saying that at least 1 hour weekly 1 hour should be put on the timetable to cater for mental health. We are not saying for learners only, but also the staff. It has very many contents. That is our circular. We are saying that in that circular, some of the contents in that circular, that at least we designate 2 staff members to be in charge of guidance and counseling to provide mental health. One of my colleagues said that we should make it a deliberate intervention to see that we put in trained personnel to provide the service. That is what we are also advocating for. We know that the people providing the service in the school, the senior men and senior women teachers, very few schools have been able to hire professional counselors or psychologists to provide the service. But now they keep telling us, Wejibiru, there is no money. Now we are saying as education, as we advocate, as we make a lot of kerele, we are saying that we will not just sit and see our learners perishing. We train these senior men and senior women teachers to handle our learners, the issues of the learners. But now the question comes, who will handle the teachers? Who is handling the HM? Who is handling the deputy who is very rough? Who is handling the warden, the askari, and the cooks? So we keep on saying that there must be this professional in a school setting to provide the service. And also to orient them. We give them the best skills. They are not professional counselors, they are not professional psychologists, but at least we give them a minimum of how to handle the learners. Then we form a guidance and counseling committee. And we are saying that these people who are providing the service in the schools, they shouldn't be part of the disciplinary committee. Because when they are part of the disciplinary committee, learners will not go there when they have issues. Because they will see them as judges, as people who are there to judge them. So we are saying that these people should be, the GIST committee should be a neutral committee, and members of that committee should not be part of the disciplinary committee. And we are saying that at least 1% budget of the school should be allocated to mental health. And then we map partners around the school community to see where we can seek help, because like we have said, we are not professionals, we as teachers, to handle. There are those difficult cases we cannot handle in school settings, but we are training these teachers to identify those cases and maybe refer. Actually, for us, we are using the term link. We don't refer, we say linkage, because when we refer, they don't go there. So we are saying we just handle them like this, and we pull them up to where they can get the service. Even the adults here, when we refer them, they don't go. So with these adolescents, we are saying we link them to the services. That is the mental health circular. Audio. Press for me. We also have that. A moment. We've also developed those materials. Like Minister of Education, our role is to provide information. So we've come up with some readers for our learners. Easy to read, that they can easily understand them. We have those for primary, which are mostly pictorial for them to understand. And then we also have for secondary. For the primary, call them My Mental Health, My Pride.
And then for secondary, we say that mental health and well-being guide for post-primary students in Uganda. There is a truth they can understand. When they have issues, they are able to say, to identify that maybe I have this issue, I can go to here, I can go to so and so for help. We also have a handbook for teachers. Like I said, teachers cannot help when they also have issues. So we developed that handbook for teachers. It is also easy to understand even if they are not psychologists. Then we also have an online module. It is there on our website about mental health. You can Google it there and find it there. It is easy to read and understand. And anyone who is not even a psychologist can understand. For us, we are providing information. And that is my last slide. We are saying that we need to work as a team. I had some questions came here like, what is Ministry of Education doing about of course it came from lack of sleep, that children do not sleep. But I may also ask a question. These children come from homes. Why would a parent release a child at 4:30? I mean, you have a right to say that my child will not go at that time. Yes. Why do you say EE? Because if classes are starting at 8, why should your child leave home at 4:30, at 5? We should not point fingers, colleagues. What I'm saying is, everyone has a role to play. I personally, I decided my children do not start the holidays. They have to rest in holidays. Even if it is a school program, whether they are candidates or not, they do not start the holidays. And they pass. So if you're a parent here and you're releasing your child at 4:30 and then you keep on blaming the Minister of Education, then I also wonder. You blame government. Who is government? Government is you and me. Yeah? Who is government? Like, we shouldn't point fingers. We should work as a team. Ministry of Health has a role to play. Education has a role to play. Gender has a role to play. Police has a role to play. Let us, all of us, let us play our roles very well. Then we'll be able to improve our mental health. God bless you.
Thank you so much. What I get from the presentation is that mental health requires all of government, all of people, all of society approach. And so integration becomes key. I think this is what we are going to talk about time and again. We have about, I know our time is fast spent, but I'll do injustice to all of us here if we don't allow time for some questions. So Bina, I'm going to allow only 4 questions. Please, I need only 4 people because our time is fast spent. So, I'll take only 4 questions, and then we'll see if we have more time to take the other round. Yeah, you are the first. Okay, so who has the microphone? Who has the microphone? Please move it around. You are the first. Who is the second? You are the first. We need the second. One of him.
Who is the first?
Yes. And then this side as well. Who?
Where's the microphone?
Another side. There. Okay. And then one person the other side. So that's the first round.
Okay, thank you so much. And Hafsa knows me very well. You know my late sister, Dr. Margaret Mungerera. Many of you knew her. She said, even everybody has got a mental health problem. It just depends on the extent. And she always said that. Even when she went on the television, she said that. After diagnosing all of us in the family, including my poor mother and father, she always had a condition for each one of us. I realized one thing. We are working out in the field, but diagnosis of mental health is a problem. You know, we work with, I've spent over 30 years working in the community, civil society with who. A person says, I'm not going to eat food, and they don't eat food for a week, and no one knows that is mental health. So as we are treating other diseases, we do not know how to diagnose mental health. So my issue is that we do not have people in the community, in the districts. That's number one. Number two is stigma. Do you realize that many children are kept away, locked up somewhere because of the stigma of mental health? So I'm suggesting that as you talked about nurses, psychologists, social workers, and those people who
Simon Civil Society. I would like to applaud the presenters. Really, this is exciting session we are sharing. My concern here is on diagnostic of mental health. I think the family-centered approach is very critical. I've seen the Ministry of Education have set very good strategies, but do the community understand that these interventions are there, these policies are there? As you tell us, not our children to wake up very early. You have made very good policies, even telling us not to go with food at school to visit children. But you announced it, the following visitation, we went with food. There was no action. The same thing when I don't take my child, we lose what those ones are grasping out. So we need to be policy makers and enforcers. If you say holiday, no education, let it be. You can't tell me I don't take my child when others are studying. Do we have a policy in Uganda, really? If it is a policy, why others take them? And why others, you are telling them not to take? Schools are doing whatever they want at their own pace. I'll not take a lot of time, but I want us to have more discussions on these matters and this multi-sectoral approach with our judges, with our counselors, education like you. Let's continue these discussions and build a very bold policies and laws for the country to continue surviving. And we fight the prevalence of really mental health is too high. I can't say much. We can spend here the whole month. It's a big thing. Thank you.
Thank you. I think a comment and about policy implementation. You have one more there on the other side.
Yeah, thank you.
Really brief and short.
Congratulations, our graduate. And I was looking at aspect of the communities that the study was done in. And you brought it very clear, the exposure to the substance, family, separation, and curiosity. Then I was thinking, what about the urban-rural disparity? Was there any difference amongst the rural and urban or peri-urban dwellers? And then income level. Was there something related to that about the children maybe from the well-to-do families are the ones who are abusing this much or from the poor families? Then Minister of Education just tickled me about screening. I know that within the school communities, we do screening of many workers there. And those who are cooks, we screen them for other common ailments. Skin diseases, mention them. I don't know whether we do mental health screening because you brought something that tickled me. Because the head teacher or any other staff may annoy this cook who has a mental problem and will transfer the aggression, because they're emotional labor. I don't know whether that is done. If not, could that be a food for thought to inform our policy? Thank you.
Thank you. There was one hand, the other side.
Yeah, thank you. I don't have any kind words for the official from Ministry of Education. The last person who spoke.
Who has the microphone?
Is here. I'm here.
Okay, all right.
Yes, this side. I don't have any kind words for Madam from Ministry of Education who last spoke. I never went to nursery, but I passed. I never did the holiday studies and I passed. Moreover, in a village school and I went to a government university and I passed and I'm here. So everything that was done in education those days has changed upside down. We are talking about mental health, our children are breaking down. You are the cause. You need to reanalyze your policies and implement what you say. What you presented there is a paper, but physically you do not do the right things. Thank you. I'm a health worker. I talk the facts.
It's about policy again, but please be kind. One more, the other side. There was one hand. Okay, all right. Then we allow time for the panelists to give comments.
Thank you. Good afternoon, everyone. My questions and comments will be mainly directed to Ms. Namakula Rebecca, Ministry of Education, Guidance and Counseling. One, you talked about having handbooks for teachers to help the students in the absence of a psychologist. Now, the teacher is trained to handle something very different. Something very, very different. So when you say that you have given them handbooks so that they can do the work of the psychologist, for me you are implying that anyone can do counseling. And I think that is already questionable. And it is happening in our schools and it is harming our children. When a child is suicidal, what is the teacher supposed to do with that child without training in mental health? What are they supposed to do? I have had a head teacher who boasted that he told a child who had tried to commit suicide and told them, go ahead, commit suicide. And then he asked the nurse, did she commit suicide? The nurse said, no. Yeah, that is how to treat them. But is it the way to treat them?
Thank you.
So, this handbook, if you are not giving these teachers training, please don't send them to the schools. You are harming the children. Two, paying professionals. You're saying there is no money to pay the professionals. Madam, I think there should be, you should be going back to the drawing board. This is a service that we need in schools yesterday. And you need to pay the people who are providing this service. Did they say they are Save the Children?
No, they are here to do a job and they expect to earn a living. And they are doing the job. Pay them. Let them do what they must do. When you talk about senior men and senior women teachers in schools, those roles are disciplinary. They have nothing to do with counseling. When they bring to you a child as a senior woman teacher or a senior male teacher, they expect you to give that child a punishment for whatever they did not do right. Is that what counseling is, madam? So let us put these things where they are supposed to be. We are mixing things and we are comparing mangoes and oranges. Let us stop. Let us do the right thing. Thank you.
I think the point is, yeah. So you're going to respond? Okay. So that's it. No. We are not taking any more questions. We really, our time is fast spent. Let's allow time. Our time is fast spent. So Rebecca.
Thank you very much, madam.
In 1 minute or less.
I will try. First of all, when I talked about the teacher's handbook, this teacher's handbook is known to help them counsel the learners. Actually, I have a copy. This teacher's handbook is to help the teachers to know more about mental health. We are trying to popularize mental health. Not very many people know what mental health is. I think you agree with me. So to start with, we are trying to make people understand what mental health is and appreciate it.
Give me that.
In a school setting, like I said, we expect teachers to support our learners. But these teachers cannot support learners when themselves are suffering. So we came up with this handbook to help teachers discover themselves, identify the issues they have, then they see how they can seek help and be helped. Then afterwards, they can be able to help the learners. This handbook also helps them to identify the cases when they arise. Like they can be able to see the symptoms and tell, I think this child is going through depression. I think this child has anxiety. So the handbook, okay. Sorry. Does it help? Okay. The handbook, like I've said, maybe it's because of time and I was rushing through my slides. The handbook, this teacher's handbook, is to equip them with the basic knowledge of what mental health is. And when you have the knowledge, then you can be able to see how to seek help. Secondly, you talked about when a child is suicidal. Like I said, we orient these teachers. In a school setting, for us, we do not diagnose. But when we see the symptoms, we can say, I think this child has a problem. When a child is suicidal, we are telling these teachers to refer such cases. That's why we are saying that each school should be attached to the a nearby health facility. Of course, in a school setting, a teacher cannot handle suicide. You talked about pay. When you say you, what do you mean you? Me as Rebecca, me as Minister of Health? I think I was very clear. We are advocating, we are lobbying and saying that each school should be with a full-time psychologist or school counselor. My commission has written, I don't know how many concepts. But when it reaches Minister of Finance, of course, they say wage bill. And you can attest to what I'm saying, that not even all schools have school nurses. Yes, some schools do not have school nurses. But we are saying each school should be with a school nurse, each school should be with a school counselor. When you say when Minister of Finance does not release money, do you want Rebecca to get money from her pocket and pay these school counselors or what? What some schools have done, before we go to that, they have been able to employ, to recruit their counselors paid by the school, not by government, to handle such issues. Like I said, we already have a structure in place according to our educational policy, educational act. We have senior men and senior women teachers.
And we're using this structure. We are orienting these teachers. We are providing them with a basic knowledge. Of course, we've just started. Actually, all of these materials were developed last year and some this year. And we are trying to orient the teachers regionally. Last year we were able to go to some school to get some teachers from the east and central. This year we are planning to do north and west. But of course, with the little budget we have, we've not been able to reach all the schools. Thank you very much.
Thank you so much. Work in progress. We need a whole day to discuss mental health, I think so. Next time. So
We shall ask for a whole day, Manange, because
with that, the rest were comments. My panelists, let me allow my panelists to go down. Let's give them a mighty hand clap for a very good presentation. Thank you so much. And I will hand over to Dr. Hafsa. My time is also up.
thank you very much for the time well spent. Thank you very much, people, for listening in. Thank you very much for your comments. I'm seeing people living like there's something to be done. That is so wonderful. We have tickled you. You need to do something. It starts with me. It starts with you. Before we end, kindly give me just 5 minutes. I cannot invite a whole big dignitary and just sits in here to do nothing. I'm just requesting that let's listen in. I'm giving her 5 minutes from the IGG to say something about mental health and speak to us. Thank you. Just kindly give us some 5 minutes. Dr. Kalani, kindly give her the microphone. Would you like to come over to the podium or you want to speak from there? Kindly, thank you. Thank you. Just 5 minutes, don't worry. It shall be done. Wonderful. Thank you.
Thank you so much, Doctor. Is this working? Thank you. Thank you. I was telling the doctor I would do less than 5 minutes because I'm sure everyone is already burnt out. I don't want to try your mental health. I want to thank you, Judge, for inviting me to come and listen in to this very critical and very important topic on mental health. This, we take mental health issues for granted. And of course, from our societies, the African society, it's a taboo to talk about some of these things. But the impacts are fundamentally on our output and on what we do, or how we serve society. So I am happy that there is such a forum where we are discussing these issues. I also know that the issues of mental health cut across. They cut across in different sectors. I was discussing with my colleagues I was seated with, we're thinking about you health practitioners. You put in so much, you give in so much to the society, to deal with our issues. And we're wondering who deals with your issues. In fact, I was sharing with them, who deals with their issues? I was sharing with them that little wonder we go to health centers and you see some of what your people, doctors, do in the health sector, and then you're thinking, no, there's a problem here. There must be a problem upstairs. It is something that I have discussed with Diana. I've told her in the past to find a solution, to find a solution for you, our people. It's not enough for us to insist on limited resources, because you'll be insufficient if we don't proactively address the issue of mental health. So I was looking at, and Doctor, you can take it from here because you're the one who is here. You look at ways of addressing issues that affect our colleagues in the health sector very seriously, because I know that once we address these issues, then the environment will be conducive for everybody, everyone else, to avoid the issues, the impact that comes to our society when we don't deal with these issues. Of course, there's a correlation between mental health and the ethical values that we have in society. You have seen that there is an increase in we are poorly rated as a country when it comes to issues to do with corruption. And it also has a nexus with mental health issues. Because you look at the things people do in society. For me, as an investigator, I'll tell you, and I'm happy that the judge gave you some examples. Off the cuff, I can think of some 2 cases where people have done things, and I'll give you one in the mental health, in the medical field. We had a case in Masaka, I don't know whether you saw it, where a doctor in theater refused Masaka Referral Hospital. I think I sent the matter to the medical board. Refused to attend to a patient because they needed to be given 300,000 shillings. And he dared the patient. I said, omwana wo yagenda kufa. Bonoba tulese sente mitwala sa. Don't you think there's a mental issue there? Is it just about the money? Is it just about the 300,000? And guess what, doctors? That child died. You Google, you will see this story. It's there, it's on the internet. So I know that if we handle this, if this discussion is taken seriously at all policy levels, then we'll go a long way, not just to help our citizens, but also to ensure that we improve service delivery in our country. So I want to thank you for helping me to be part of this discussion. And I pray that in future you invite different, even us as stakeholders, because when I come, when I'm more organized, then I'll be able to give you many other stories where we have been affected. And now this triggers my mind to think even outside the box, and not just to look at the punitive ways in the fight against corruption, but also to think about the mental well-being of these individuals that we deal with in society. It's important. It's important because the kind of greed or the level at which we are as a country shouldn't be comfortable for any of us, and it should stir some thinking and intentional, action on all our part. Please think about that. Think about the mental well-being vis-a-vis the nexus. I think it should be the next topic in the fight against corruption, and I'll be happy to contribute to that topic when the time comes. I thank you.
Thank you very much. We are getting people on board, and so very happy. I've also been told that the media wants us to be engaged, or wants us to engage them so that they can be the link between, they can broadcast the messages around mental health, but also on NCDs. Our call to action. By talking openly. Okay. Our call to action. By talking openly and supporting each other and seeking help when needed, we can create a more inclusive and mentally healthy society. That is what we are calling for, and we have to be intentional in doing this. I thank all of you for listening to us, and I call upon you to this be your first step in improving your own mental health, but also the mental health of the people around you. So with those many words, I want us to end here. I have been promised, yes, I've been promised that we shall have another day for mental health. And we are inviting you again and again, please, when you hear mental health discussions, mental health dialogues, please come up with your issues. Dr. Oyo, I don't know where you are, but the media is calling on us. We want to give a vote of thanks. You're giving a vote of thanks? No? In the afternoon. Okay, so I'm being told that there's another discussion going to happen this week during this conference. It's going to be on Thursday in Mirror Hall, and we are going to talk about mental health in the workplace. And I think it touches on all of us here. So before we really go, I want us to have a group picture. A group picture. Those of you who are here, we take a picture with the judges, with the IGG. Hey, and we feel happy. It is part of our self-care. So colleagues, stand up. Let's come for a picture. There's no music, but for us in mental health, we really love to dance and be free. So thank you very much. I wish there was some music to keep us going. Colleagues, there's going to be another meeting here. So those of you who want to take part in the pictures, guest of honor has to be there. Guest, kindly be there. Stand down while others will stand up. So please, those of you who want to take part in the picture, kindly come up. There's going to be another meetings, and actually we are leaving this room. So until we meet, until we meet again on Thursday, I want to wish you fruitful deliberations for the rest of the week.
Okay. There's a chance that my head will be seen. I was on the microphone. Okay. Wow. Let me also have the opportunity to stand next to this one. I don't know what.
Okay, thank you. Colleagues, you can give a big hand clap to our guests for that session. We have a place for more group photos outside. So the team, you can continue and have group pictures outside. So as you move out, ladies and gentlemen, we have a roundtable discussion coming up, but this is for the invited chief of parties and the civil society organizations. Please stay behind, and we are going to be having a meeting taking place now. We expect to have JCRC, TASO, AIC, Beira, Uganda Cares, MJAP, Uganda AIDS Commission, representatives from the US government and World Health Organization, executive directors from the regional referral hospitals, and representative of the CSO, Flavia, and your team, and also a representative of the people in care. Please stay behind, together with a team from the Ministry of Health, led by our commissioners and the technical officers from the HIV and TB program. Please, we request that you take the front seats, and this session is going to be chaired by Dr. Stavia. So as others move out, please that you stay behind. We have been informed that, yes. We have been informed that please take care of your bags. Take care of your bags, watch out. We already have an incident reported of a missing bag. So please pay attention to your bags and your laptops. And if you carried a bag by mistake, you can report to the secretariat so that it's handed over to the owner. So colleagues, let's give space for the next meeting to start. For the people that have been mentioned, represented by your chief of parties and the directors from the regional referral hospitals. So the rest of us, let's meet tomorrow, same time, for the day 2 activities to begin. Thank you for coming. Yes. So members, let's take our seats for the meeting to begin. The chairperson for us, let's come in the middle. Our round table is going to be here in the middle where you see Dr. Savia. So the eyes, let's meet in the center. And the ushers at the back, please help us maintain the door. Maintain the door. The media you can leave. This is an in-house discussion. So the media team, you can leave. This is for the people that have been mentioned here and from the organizations that we have mentioned. The rest of us, we shall continue the meeting tomorrow. The IT team, I request for 2 microphones because we are going to use the downer part, not the stage. So colleagues, let's take our seats. Let's take our seats. Those having discussions, we can continue outside. We want to call the meeting to order. Let's take our seats. We need to come together. We are using the first 2 tables here in the middle. The Ministry of Health technical officers, Kato, help me mobilize the team. We are taking these 2 tables here. Other people can continue with the discussions outside. Let's have the meeting begin here. We are using the tables in the middle. And again, just to emphasize the invited people for this meeting, we expect all the IPs, their representatives, the civil society representative, directors from the regional referrals, and also the Ministry of Health team led by the commissioner and other technical officers. So people at the back, kindly give us some time to start. Kato, you can mobilize people at the back and we start.
This is not our agenda.
Thank you.
Thank you, our moderator for the day. Cordelia, you are sitting very far away. I don't know where the other technical officers are. I'm not seeing them. Mutumba, where are they? So, wow. From prevention to, I'm not seeing them, but that's fine. So I want to take the opportunity to welcome you to this discussion. They said round table. I don't know how round this is. It is horseshoe. I hope we wanted to be looking at each other's faces, but I see some people are looking at other people's backs. So, but in the interest of time, we shall start. The agenda for our session, I think we will need to know each other. We assume we have prayed since we started, since we are joining a session that has been running. Then we'll have a brief from the Ministry of Health. Then we'll have a brief from the Centers of Excellence. The recipients of care can have a joiner there. Then we have a discussion.